Good morning, dear students. As we understand, the exam is over, and I hope it went well according to your hard work, your expectations. The good news is awaited. But today's session is basically to recall some of the anatomy questions and have some discussion upon the same, so that you can have a little bit of confidence that most of the questions you have answered were correct, and maybe few scattered one you could not answer correctly. Anyway, you have to get 50% scoring. So with that hope and trust, let us discuss the questions which I have collected. It is basically a recall-based session. So there might be incomplete questions, but the purpose is just to have an overview. And later we can go into more details as and when we get them from you itself, because it is you who gave the exam. I believe there was a question on a diagram-based question on testosterone and inhibin, and I'll show you the diagram. They were asking about the feedback mechanism, because we understand that in the testis there'll be some cells like Leydig cells which will be giving the testosterone, and the Sertoli cells which will be giving the inhibin. So there was a diagram, and the diagram appears to be something like this. As is evident, this is a magnified view of the diencephalon, that is hypothalamus. Hypothalamus is the major center for controlling the endocrine system, and it is the hypothalamus which will be giving us gonadotropin releasing hormones towards the anterior pituitary, and then anterior pituitary will be giving further hormones to take care of testis, because in this question we are talking about Sertoli cell and the Leydig cell. Now, as the anterior pituitary will give follicle stimulating hormone, luteinizing hormone, they'll have positive impact upon the cells of the testis like the Sertoli cell. And then there is interstitial cells of Leydig. Now, as we are telling, it is the Leydig cell which is giving us testosterone, and testosterone will have some androgenic effects. Plus, there'll be the Sertoli cell. It will be helping us in spermatogenesis, positive effect. They are all positive signs, as you can see. But then there can be negative feedback mechanism working. Say, for example, you have too much of testosterone, too much of sperms being formed. So you have to give a feedback loop. Sertoli cell will give us inhibin, and which is working at the anterior pituitary level. Maybe this was marked as A in your question. Marker B was here, feedback mechanism by testosterone. Now we have to understand that testosterone as such is mainly working on hypothalamus and partly working on anterior pituitary. So if it is about inhibin given by Sertoli cell works on anterior pituitary, reducing the follicle stimulating hormone and thus counteracting the function of testis. But if you talk about the testosterone, testosterone chiefly works upon hypothalamus, reducing gonadotropin releasing hormones, and then reducing the hormones secreted by anterior pituitary, though it also works upon the pituitary. So the marker which was given for pituitary as well as hypothalamus would belong to testosterone, and the marker which was given only till anterior pituitary will be the inhibin. Now I'm looking at, okay, chat as well. Good afternoon, yes, Dinesh, Dr. Priyanka, Angel, Ravi, Andrew is telling very hard paper. Cannot comment much upon that, but I think what you remember is only those questions which you couldn't answer. You would have answered a lot of questions correctly, and it is human psychology that you won't be remembering them. You will be remembering only those questions which you could not answer. So it appears like the paper was hard. But let us keep our hopes intact and trust that whatever hard work we have done towards exam, the result will be brilliant. And of course, you have to go across that 50% barrier. Okay, so I don't have the complete questions as such. Conceptual oriented. Yes, see, these are all conceptual questions. Okay, so as we proceed further, so this was the question which I told it was on testosterone and inhibin and marker AB. Now, the next question which I've got is they were asking about esophagus, and in esophagus, they were asking which is the missing layer. As such, if you talk about esophagus, it'll have certain layers, like because it is a gut tube, it'll have the mucosa, and under the mucosa, you'll have the submucosa, and then it'll have the muscular externa, and it'll have the last layer. The last layer is connective tissue adventitia, but we have to understand that part of the esophagus enters the abdomen also, and that distal part of the esophagus will have serosa. So some part of the esophagus does have serosa, but most of the length, the esophagus is a long tube, so most of it does not have the serosa. Instead of peritoneal serosa, it will have connective tissue adventitia. Let me show you the histological picture as well. And as you look at this picture, which we continuously keep discussing, you find that this is the lumen of the esophagus, which is collapsed at present. And the very first layer is mucosa over that. And then as we go beyond, under mucosa, you'll have the submucosa, this layer. This is the layer which is submucosa. And over that, you'll have the muscular externa. So you can see this layer is the muscular externa. And the last one, which you see a little bit of that here, adventitia, connective tissue adventitia. So most of the length, the esophagus will be covered by connective tissue adventitia. But when you enter the abdomen, below diaphragm, around 2 centimeters of esophagus will have serosa. Question was, which among the following is missing from the esophagus? So the answer should be serosa, though, as I'm telling, it does have serosa also, but most of the time, most of the length, it'll be missing. So maybe they wanted you to answer it as serosa because it does have mucosa, submucosa, muscular externa, and connective tissue adventitia. Location and position of hiccup causing nerve. Yes, that we will discuss. Phrenic nerve. Okay, so as we proceed further, there's a question on craniorachis. Craniorachis is one of the questions which keep coming all the time. And maybe they gave you this diagram. As we understand, the craniorachis is basically craniokisis and rachis together. What you find is that this baby, the skull cap is missing and the brain is small, degenerated, exposed outside. Skull cap is missing, brain is small, degenerated, exposed outside. So anencephaly. Not only that, even the spinal cord is exposed outside, CSF leaking outside, the spina bifida. So spina bifida, the spinal cord is open, which is rachis. So craniorachis is the name. Entire neural tube is open, and it is open neural tube defect. Only anterior neuropore should close by day 25 of development, which has not closed. The posterior neuropore should close by day number 28, which has not closed. So entire neural tube is open, which is called as craniorachis. This could be a question in anatomy. This could be a question in forensic medicine also. Anencephaly with craniorachis. That was in the option. Anencephaly with craniorachis. Okay, but anencephaly, and this is rachis. So anencephaly with rachis is together called as craniorachis, because this is cranioschisis. This is rachis. So craniorachis, that should be the term, I believe. And there are two images given. Okay, there were two images, maybe one from the posterior view and one from the anterior view. Okay. All right. So as we move further, you find there's a question. This question keeps coming all the time. This question keep coming all the time. Pterion, epidural hematoma. So I have the trust that you would have answered this question pretty well. So the question was actually asking about see, this is the lateral view. In the lateral view, this is the H-shaped suture, which is called as the pterion. And under the pterion, you will have the anterior division of the anterior or frontal division of the middle meningeal artery, which itself is a branch of the maxillary artery. So maxillary bone will have maxillary artery, will give the middle meningeal artery, it will supply the meninges. It will have anterior posterior division. The anterior division of middle meningeal artery is going to bleed if there was a road traffic accident. This part of the skull pterion, where you have four bones meeting, frontal on front, the parietal posterior, the squamous part of temporal inferior, and greater wing of sphenoid antero inferior. So this is the point where if there is a fracture, this bleed will occur, and you can find there will be an extradural hematoma, idly shaped, biconvex. And if this is the situation, you have to consult with the radiologist and you have to do craniotomy and remove the clot, because this is a deadly condition. These patients will have lucid interval, which is there will be a loss of consciousness followed by consciousness. And again, there is second time loss of consciousness. So there's a lucid period in between the two stages of loss of consciousness. And if you don't bother, then you might lose your patient. Middle meningeal artery, management of EDH was one of the questions. Yes. So management of EDH is basically you have to consult with the radiologist. You have to look at the dimension of the clot, and you have to do craniotomy. You have to remove the clot, because otherwise it will keep compressing the brain. And within 6 to 7 hours, you may lose your patient. You have to be quick. Question was EDH, MMA ruptured, which structure? Skull like that. Okay, pterion. Right. Now, as we look at the next question, I think, I find students telling there were no repeat questions, there were no previous year topics, previous year questions, but doesn't appear like that, because most of these questions they have already asked, and they are repeat questions. What happens is, like I keep telling my son also, if you do not revise 3-4 times, even the repeated questions will appear new questions, alien. So maybe fault is with us, we don't revise often. I have only one advice to the students: practice as many previous year questions as possible. Maybe the questions will not come, but the topics will come. Anyway, exam is over. We are waiting for the result. This kind of talk doesn't help us much. But if you talk about the artery of epistaxis, chiefly the artery which bleeds is sphenopalatine artery, branch of maxillary artery. So the diagram, as you talk about this diagram, these are all these questions which we are discussing are frequently taught to you, not only by myself, but physiology, people, ENT, faculty. Anyway, so as you see, looking from the lateral view on the nasal septum, there is one Hazelback plexus, that is the little area of epistaxis. Children putting their finger or some toy and bleed comes, epistaxis. So chiefly which artery bleeds, maybe that is what they were asking. And it is sphenopalatine artery, which itself is a branch of maxillary artery, though maxillary artery will also give us greater palatine artery. And this greater palatine artery is also contributing to the Little's area of epistaxis or hazelback plexus. There are 4 arteries which we have to remember. These 2 coming from the maxillary artery, though there is a facial artery also, which is giving superior labial artery contributing. So one is the facial artery giving superior labial artery, other is maxillary artery giving greater palatine, third one is sphenopalatine, and then internal carotid artery, which goes inside the cranial cavity, gives you ophthalmic, and from there comes the anterior ethmoidal artery, which contributes to this area. So it can be considered as a meeting point or anastomosis point of branches of external carotid and internal carotid, because anterior ethmoidal artery is a branch of ophthalmic artery, is a branch of internal carotid artery. But all of these arteries, these names, the most important artery of epistaxis should be considered as sphenopalatine artery. Child comes with nasal bleed, which artery? Okay. Aortic aneurysm, one image. Yes, we will discuss that. Internal carotid artery give you the posterior anterior ethmoidal. Anterior ethmoidal contributes to Little's area. Posterior, generally, it does not. That is anterior, which is contributing to hazelback plexus. Okay, scalp hematoma, location asked which layer it is present. If it is, you're talking about scalp, S-C-A-L-P, the L, loose areolar connective tissue, is also called as danger space. And that is where the infection can go deep within the cranial cavity. But the question is, scalp hematoma, location asked, in which layer the hematoma is present. See, the thing is, if you are talking about the blood vessels, there is skin, and below that is C, because it is SCALP, C, connective tissue. In the connective tissue, you will have blood vessels. So basically, the bleed will be in the connective tissue. And that bleed in the scalp is very profuse because the elastic fibers within this connective tissue and even the epicranial aponeurosis, which is deep down, it doesn't allow the arteries to close. They gape up and more of bleeding comes. So if you are asking about hematoma, then it will be second layer. The S is skin, C is connective tissue. In the connective tissue, there'll be the bleeding. And then SCA is aponeurosis, then L, loose areolar connective tissue, then P, the pericranium, the cover periosteum of the skull. Maybe I can work upon that. I don't have any diagram right now, but if you're asking for hematoma, must be second layer. If you're asking about the dangerous layer, it is the fourth layer. Due to injury in brain, eyes become black, which causes this type of question. Okay. So that means the bleed is moving. Is it brain injury or scalp injury? So bleed can move and can cause black eye, but then I need precise language of the question. Anda sign, maybe. If it is scalp injury, then must be second layer. Okay, so let me just go through the questions which I have got, at least confidently, because these questions I'll have to do some research work. Now, there's a question on facial nerve lesion. And as I understand, the students are telling, they have given some details like taste sensation from the anterior 2/3 of tongue is gone, and left eye is not closing properly. That is, orbicularis oculi is not working. And they have mentioned there is something wrong with the ear also. Maybe they are talking about stapedius not working. So that kind of a question was there. I haven't got complete language, but the question was asking, where is the lesion itself? So for that, we have to talk about the course of facial nerve. And basically, we are looking at this diagram, say looking from the right side, a facial nerve on the right side. And as we do so, I can show you some details. Then we can draw a diagram ourselves. Facial nerve comes from the brainstem at the pontomedullary junction, enters the petrous temporal bone, and runs in the middle ear cavity. So when the facial nerve is running in the middle ear cavity, you can see it'll be entering the internal acoustic meatus, and then in the middle ear, it'll have a geniculate ganglion. And after geniculate ganglion, it will give a branch which is called as the greater petrosal nerve. This greater petrosal nerve is going to supply LNP gland, lacrimal nasal palatine gland. I'll repeat. Facial nerve will come from brainstem, pontomedullary junction, enter petrous temporal bone through internal acoustic meatus. Then it will enter the middle ear. In the middle ear, it'll have a geniculate ganglion. After geniculate ganglion, it will give a branch, greater petrosal nerve, which will supply lacrimal, nasal, palatine glands. Then it will be giving a nerve to stapedius. Stapedius is a small muscle in the middle ear cavity for dampening of the sound. If there's a loud sound, that loud sound can damage our inner ear. To prevent that, there is a dampening of sound done by stapedius. There is a stapedial reflex. So that is second branch of facial nerve while it was running in the facial canal in the petrous temporal bone. And then it will give a third branch, which is cauda tympani nerve. This cauda tympani nerve is the one which carries taste sensation, and it joins lingual nerve branch of mandibular trigeminal and goes to supply the tongue. After that, it will be facial nerve coming out of stylomastoid foramen, stylomastoid foramen here, and then supply muscles of facial expression. Facial nerve is the nerve of second arch, supply muscles of facial expression like orbicularis oculi. Now, the examiner is telling that orbicularis oculi is not working. That means the muscles which the facial nerve supplies would have been compromised. It is telling that taste sensation on anterior two-third tongue is not working. So even this branch has been compromised. There is something wrong with the middle ear, dampening of sound also. So this branch is also compromised. Now it depends whether they give or not about the decreased secretion of eye, nose, and the palate. If those secretions were also decreased, then the injury must have been prior to that. Means the injury could have been somewhere here. So basically they are asking, see, if this is the injury before geniculate ganglion, there'll be dryness of eye, there'll be no dampening of sound, stapedial reflex gone, there'll be loss of taste sensation from anterior two-third tongue, and there'll be muscles of facial expression compromised. Lesion could be here, lesion could be before geniculate ganglion, or lesion could be after geniculate ganglion. Lesion could be after stapedius branch. A lesion could be after coming out of stylomastoid foramen. So it depends which kind of clinical features were given. That will decide the level of lesion. So maybe the question was having option before geniculate ganglion, lesion was before geniculate ganglion, lesion was after geniculate ganglion, lesion was before nerve to stapedius, lesion was after nerve to stapedius. Wernicke's raccoon eye image, yes, panda's eye, raccoon eye. Aortic aneurysm, thin nerve, that is about phrenic nerve, yes. Okay, so let me just go through the questions which I have collected, and maybe later we can have a more detailed discussion. There's a question on auricle nerve supply. So as we talk about this nerve supply of auricle, I wonder why students are telling that there were no repeat questions or repeat topics, because They all repeat topics. We continuously keep teaching them. Maybe, yes, I can understand. Maybe some students, they take shortcuts. They just go through rapid revision, or some of them will just do the previous year questions. These days, the examiners are becoming smarter, and they really want you to have good amount of information. So advisable is that go for the main videos. Because we have short timing, we don't have enough time. So maybe then you can resort to rapid revision, or maybe you can resort to only the last 5 year questions. But in case of emergency, normally it is not recommended. And all these topics, they are continuously taught by not only myself, but ENT's faculty, and any platform you'll find, they are the regular usual topic, because they, see, examiners, 80% of time, they will ask you previous year questions. Take it from me. I really doubt if you say they were not from previous year questions, that means you haven't practiced previous year questions 3-4 times. That could be the only reason. And sometimes the truth is bitter. We have to digest it, and we have to improve. We also have made mistakes in our life, but practice previous year questions as many as possible. Questions may not repeat, topics will repeat. Okay, so as we talk about the auricle, see, greater part of auricle is supplied by greater auricular nerve. Greater part of auricle is supplied by greater auricular nerve. So you see, this is all greater auricular nerve. Now, when it comes to the tragus part, if it comes to tragus part, let me change the color. Then this part is auriculotemporal nerve. This part, the tragus at this part will be auriculotemporal nerve. And if you are talking about external auditory meatus, facial nerve carrying branches of vagus will be the supply. So if we change the color, you will find that we are now talking about the facial nerve carrying the branches of vagus. That is from the lateral view. Even if you go medial, you'll find most of the time, see, again, this area where you have the external auditory meatus, it'll be facial nerve carrying branches of vagus. So basically it is supplied with vagus nerve, but fibers coming along with facial nerve. The first answer should be vagus. Second answer should be facial nerve, because it is not facial nerve which is supplying. It is facial nerve fibers are supplying, which are carrying the auricular branch of vagus. That is why, you know, some people, they put some acid, diluted acid, to irritate the vagus and to increase appetite before any big meal is coming up. So, or when you irrigate the tympanic, this area, then there can be irritation of vagus nerve. That is why vasovagal syncope and all that. So it is basically vagus nerve, not the facial nerve. Then what about the greater part of auricle? Greater part of auricle, even from medial view, you will find that it is being supplied by greater auricular nerve. Root valley, sometimes they ask C2-3. And if you go this area means upper and medial, upper and medial, upper inner, upper medial, medial, you know, lateral medial. That is lesser occipital bone is there, lesser occipital nerve. So there you have a separate nerve, lesser occipital nerve. This area is lesser occipital nerve. Again, I'll tell you, greater part of auricle is supplied by greater auricular nerve. The ear lobule especially, maybe lateral or medial. So lateral medial, when you do the ear piercing, which nerve will carry the pain? Greater auricular nerve. Because greater part of auricle is supplied by greater auricular nerve, maybe laterally or medially. Upper part, lesser occipital nerve, and anterior part, the auriculotemporal nerve. And if you talk about the external auditory meatus, facial nerve, but carrying branches on vagus. What is the best way to revise anatomy after completing the first reading? If you have done the main videos, then you can come for rapid revision, 2 times rapid revision. But practice as many MCQs as possible. How do you do that? These last 5 year questions, they are already on YouTube. So you can just continuously practice those previous year questions, last 5 years. If 5 years is over, 10 years. If 10 will be sufficient. See, for this question, when you are talking about raccoon eye, there can be some sign here, bleed coming outside. It could be coming from within cranial cavity, fracture of the middle cranial fossa, fracture of the anterior cranial fossa. So I have to really work upon this question, like what were the options given? Because there might be happening that there's a skull bleed which might come to eye, but then raccoon eye is different. And this sign, there is a battle sign, I believe. So these are fractures of middle cranial fossa, fracture of anterior cranial fossa. I have to work upon this question. I'm not having proper information right now. If patient cannot elevate the shoulder, then it is the trapezius not working, injury of spinal accessory nerve. But maybe that question was orthopedics question, Sprengel shoulder. That question was on Sprengel shoulder. It is congenital high elevation of the scapula. So that could have been Sprengel shoulder. If it was a nerve injury, if you cannot shrug the shoulder, that is due to the spinal accessory nerve lesion and paralysis of trapezius. So again, I have to work upon this question. Okay, so let me just go through the question which I already have. There's a question on levo depression. Levo is left, depression means taking the eye down. So yoke muscles means one muscle from this eye, one muscle from that eye. If you look at the diagram, this is levo depression. Now, when we talk about levo depression, it means that left side and down. Levo is left, depression is down. Now, yoke muscles means the main eye and the other eye. This we know that if the eyes are adducted, if the eyes are abducted, depression is done by recti muscles. And if the eyes are adducted, the depression is done by obliques, basically superior oblique. So superior oblique muscle will depress the eye in adducted position, whereas inferior rectus will be taking the eye down if the eye was in abduction. Say, for example, this eye is in abduction. So we will do the depression. In the left, it will be the inferior rectus because of the axis is such that recti are depressors in abducted eyes. But if the eye is adducted, the right eye is now adducted, then we will do the depression. In adducted eye, depression is done by superior oblique. So supplied by trochlear nerve. Superior oblique supplied by trochlear nerve, right side. So right-sided superior oblique taking the eye down in adduction is the yoke muscle. And if you talk about levo depression, left eye, inferior rectus, rectus supplied by third nerve, oculomotor. So left inferior rectus and right superior oblique should be our answer. And as we proceed further, aortic aneurysm, hiccups. I think this was the question you were talking about. And they must see, let me first give you some details here. If you are telling it is aortic aneurysm, it must have ruptured. And if it is ruptured, then it is bleeding. And if it is bleeding, then it may be irritating intestine, it may be irritating diaphragm, it may be irritating phrenic nerve, and it may be irritating vagus nerve. So if vagus is also there in the option, it becomes a little bit dicey. But as such, for hiccups, this is always a better answer. Sudden spasmodic contraction of the diaphragm. Sudden spasmodic contraction of the diaphragm and hiccup. So aortic aneurysm bleed. It is irritating the diaphragm, irritating the phrenic nerve. If phrenic nerve is irritated, there will be spasmodic contraction of diaphragm, hiccups will be there. But this can happen by vagus also. Vagus can also carry the sensation back. Now, these two will be the efferents. Efferents means sensory. So if these two are efferents, sensory, then which is the motor? The only motor nerve which causes movement of diaphragm is phrenic nerve. So the only efferent is the phrenic. So the sensation can be carried by phrenic as well as vagus. It is understood that they are both efferents, but the only motor nerve to diaphragm is phrenic nerve. So among the two, phrenic should be preferably your answer as compared with vagus. I believe both of them were there in the option. Cadaveric image, yes. So this was the cadaveric image. This was the cadaveric image they gave you. And let me show you some details here. I don't know why they keep asking cadaveric images. Cadaveric images are difficult. Cadaveric discussion is difficult in the dissection hall itself. And I don't know how many people, how many students actually stay near the cadaver. Anyway, long story. Now here, what they have done is, this is basically mediastinal section where the left lung has been removed. What you can see, a large vessel here. This large vessel is the aorta, arch of aorta, descending thoracic aorta. This is the lung hilum, pulmonary artery, pulmonary veins, bronchus. So lung hilum. I think they were putting some marker on trachea, aorta, and nerves. And the nerve which the students are telling were one which is going in front of the lung hilum and one which is going behind the lung hilum. So if they were telling there is aortic aneurysm rupture, some bleed is going on, which nerve is responsible for hiccups? I'll prefer phrenic nerve. Phrenic nerve is anterior to lung hilum. You have removed the lung from here by cutting at the root. So anterior, this is the heart, that is the ribs and sternum. So rib and sternum anterior, this is the heart in the middle mediastinum. Between the two, you'll have anterior mediastinum. This is middle mediastinum. In the posterior mediastinum, you'll have the aorta. So this is the lung hilum. Remember, phrenic nerve and vagus nerve, they keep coming together and they sandwich the lung hilum. Phrenic nerve go anterior and vagus nerve goes posterior. Let me show one more diagram in the similar fashion. Okay, you are telling about the numbers. Number 18, number 19. 18 will be phrenic nerve, yes. This is another diagram, a schematic diagram basically. And maybe now it will become more clear. So this is again the arch of aorta, and this is descending aorta. And this is the phrenic nerve, anterior. This is the vagus nerve. Let me choose another color. Vagus nerve going posterior. And this is the lung hilum. We have removed the left lung. So removing left lung, cutting at the root. These nerves, phrenic and vagus, they come together and they split and sandwich the root of lung hilum. Phrenic going anterior and the vagus going posterior, sandwiching the root of lung. So you can see the same thing here. This is, say, vagus nerve here. This is vagus nerve going posterior to the lung root or lung hilum. And we have colored blue here. So this is phrenic nerve coming anterior. They are coming together and then they split and sandwich the root of lung. So phrenic nerve is more anterior. See, my point is, if there is aortic aneurysm and if it is bleeding, it may irritate the diaphragm. And the sensation of diaphragm are carried by not only phrenic nerve, but also vagus nerve. Both are sensory. Both can be irritated to give us hiccup. But then hiccup is brought about by, which is the motor nerve. The only motor nerve to diaphragm is phrenic nerve. So phrenic nerve will be a better answer as compared with vagus for hiccups due to aortic aneurysm rupture. Wernicke's is on the left side. Wernicke's sensory aphasia. Wernicke's area is basically superior temporal gyrus, more posteriorly, area number 22. Let me draw the diagram. I think they have asked this question, so let me just draw the diagram quickly. Looking from the left, because language area mostly on the left side, though some faculty also they are left-handed, so maybe language area on the right side, but most of us, 95% people will have on left side. Now, as you see, this is the cerebrum, frontal lobe, central sulcus, parietal lobe, imaginary line, occipital lobe, and temporal lobe. This is lateral sulcus. Lateral sulcus. This is central sulcus. So looking from the lateral view, this is central sulcus separating frontal lobe from parietal lobe. Separating the frontal lobe from parietal lobe. This is lateral sulcus, which is separating the two from temporal lobe, and this is imaginary line behind that is occipital lobe. Now, if you say Wernicke's area is here. Sorry, Wernicke's area will be actually combination of this, some parietal and some temporal. So superior temporal gyrus, more posteriorly, area number 22. This is Wernicke's sensory speech area. It is for comprehension of language, comprehension or understanding of language. So if the Wernicke's area is compromised, Wernicke's encephalopathy, vitamin B1, thiamine deficiency, vitamin B1, thiamine deficiency, Wernicke's encephalopathy, the Wernicke's area will be compromised, and there'll be anterograde amnesia along with that. And these patients, if you are talking about Wernicke's encephalopathy, it is different. If it is Wernicke's sensory aphasia, these people, they cannot understand the language. And if they cannot understand the language, then they'll be non-stop nonsense speech, non-stop nonsense speech. They keep on speaking because they themselves don't understand that what they are speaking, because comprehension is gone. So maybe you're mixing two things. Wernicke's area is different. Wernicke's encephalopathy will be different. Wernicke's encephalopathy will be something to do with the mammillary bodies in the hypothalamus. So again, I have to work upon these questions. Maybe you are mixing two things. Anyhow. Now, moving further, anatomical snub box. So anybody telling me that these questions, they are not repeated, I have to really question myself that why you are telling like that. So boundaries, scaphoid fracture, if it is fall on outstretched hand, there can be tenderness in the anatomical snub box, and that tenderness in the anatomical snub box due to fracture scaphoid. So maybe that was the question. Let me show you the diagram. So what I'm telling is, first of all, if they ask you boundaries, there is external, this is extensor pollicis longus, which comes like this. We can shade it like this. And then we have got extensor, but brevis, shorter one. So we can take a shorter one here, extensor pollicis brevis, and it will come anterior. So these are the actual boundaries of anatomical snub box. Though we have this AAA, abductor is additional, is anterior, AAA. So if you talk about the abductor pollicis longus, abductor pollicis longus is AAA. It is additional boundary, anterior boundary, and it is abductor pollicis longus. So normally we don't consider it as the boundary. The boundaries are done by long and short tendon. That is the extensor pollicis longus, extensor pollicis brevis, coming from the posterior forearm. All the three muscles come from posterior forearm. Now, at the floor, you'll have four bones. The distal end of the radius, scaphoid, trapezium, and base of first metacarpal. So four bones are there at the floor of anatomical snub box. Which four bones? You'll find distal end of the radius, and then maybe we can take this color. Which color should we take? So one is the distal end of radius, second is scaphoid, then we have trapezium, then you have base of the first metacarpal. So 4 bones are there, but mostly the one which is fractured is scaphoid, fall on outstretched hand. So when you have a case of fall on outstretched hand, it is scaphoid fracture, and there might be non-union because the arterial supply is such that it may go for non-union or malunion. So I think that was the question. Okay, both Wernicke's were there. Good. Now, fracture, midshaft humerus, wrist drop. Who is telling these questions are not repeat questions? I'm sorry, I should not smile very often, though in social media you are supposed to smile very often. Mostly I don't smile. I remain very serious because it is, it is about your life, and we should be serious about our life, professional life, personal life, whatever. But when there is too much of tragedy, even then you smile. So that, sometimes when you're very happy, you cry. And sometimes when you're very sad, you smile. आपने किशोर कुमार के गाने सुने होंगे, सारे दुख भरे गाने भी वो मुस्कुरा के ही गाते हैं, मतलब दुख को मुस्कुरा के झेल जाओ। शायद इसलिए स्माइल आ रही हो, क्योंकि ये आप मान के चले आपको दुख हमारा दुख होता है। यहाँ पर नाकामयाबी हमारी भी नहीं है, क्योंकि हम आपको सही रास्ता ना दिखा पाए, और पर अभी भी मुझे उम्मीद है कि अधिकतर आप सबके मार्क्स जो हैं वो 150 के ऊपर ही होंगे, आप सब ही क्लियर कर जाएंगे। अभी आपको लग रहा है कि आप गलतियां करके आए, पर आपने नहीं करी होंगी, ऐसी हमारी उम्मीद है। नहीं, आदमी मैं थोड़ा इंसान थोड़ा अलग किस्म का हूं, वैसे इतना सीरियस तो हूं मैं, पर ऐसा नहीं कि मैं सीरियस ही हूं। लोग मुझे 2 रूप में जानते हैं। अगर आप मुझे नॉर्मली देखोगे, जब मैं पढ़ा नहीं रहा तो मैं मुस्कुरा रहा होता हूँ, जब पढ़ा रहा होता हूँ तो मैं मुस्कुरा नहीं पाता, क्योंकि लाइफ की बात है, पेशेंट की भी लाइफ की बात है, आपकी लाइफ की तो बात है ही, पेशेंट की भी लाइफ की बात है, तो इसमें मुस्कुराना कैसा? इट्स अ सीरियस थिंग, इजंट इट? So I think this was a question which is again repeated things. Fracture midshaft humerus, head of humerus, the medial condyle, epicondyle, lateral condyle, epicondyle. So fracture midshaft humerus, this drop, this is dorsiflexion is okay, but this dorsiflexion is not okay, so this drop. So radial nerve, I believe, because radial nerve passes behind midshaft humerus. If it is fractured, it will be compromised. As you know, this is the diagram. So this is the radial nerve coming from posterior corner brachial plexus, and this radial nerve passes behind the midshaft of humerus. That is where it can be damaged. Comes anterior to lateral condyle of humerus. If there is a fracture medial epicondyle, ulnar nerve can be damaged. If there is a surgical neck fracture, axillary nerve can be damaged. So axillary nerve, surgical neck fracture, medial epicondyle, it is ulnar nerve. But our question was on fracture midshaft, so radial nerve in the radial groove. Maybe it was damaged there, leading to wrist drop, loss of dorsiflexion at the wrist. Posterior triangle of neck, patient was unable to lift his shoulder. Okay, if there is posterior triangle of neck surgery, over enthusiastic house surgeon without doing surface marking, draining an abscess, damaging spinal accessory nerve, and paralyzing the trapezius, and difficulty shrugging the shoulder, drooping of the shoulder. If that was the question, that is spinal accessory nerve is the answer. Over-enthusiastic surgeon doing incision drainage, abscess in the posterior triangle, without surface marking spinal nerve, iatrogenic injury, damaging spinal nerve, paralyzing trapezius, and difficulty striking the shoulder, drooping shoulder. That could have been your question. So spinal accessory nerve has been damaged. Pringle maneuver. Pringle's maneuver. You put your fingers in the epiploic foramen of Monro. You are pulling three structures anterior, which are the DAV structure, duct, artery, and vein, bile duct, hepatic artery, and portal vein, and then put artery forceps if you're operating on the lever to minimize bleeding. So you are putting your finger in epiploic foramen of Monro, epiploic foramen of Monro, holding the free edge of lesser omentum, pulling the three structures anterior, DAV structure, bile duct, most anterior, in the middle, hepatic artery, more posterior, portal vein, and putting artery forceps to reduce the bleeding which might happen when you operate on the lever. Or maybe it is, lever is already bleeding, some traumatic injury. You want to minimize that bleeding. Then you can clamp them and you will reduce the bleeding, because 80% of blood through liver comes by portal vein, large caliber, and 20% come by hepatic artery, which is 20% small caliber. But you can block them by doing Pringle maneuver and putting artery forceps. Yes, Sanath, my best wishes are always with you, with all of you. You are the budding doctors, the future doctors, our future. कल को अगर हम बीमार हुए तो कौन देखेगा? हाँ, हमारे दोस्त भी होंगे, वो भी एक्सपर्ट होंगे, पर वो बीमार हुए तो कौन देखेगा? आप देखेंगे। तो आपको अच्छे डॉक्टर बनना ही है। हमारा फ्यूचर आपके हाथ में है, आपका फ्यूचर हमारे हाथ में है। हम हमारा That is why we should be serious. We cannot be casual. We are talking about human lives. Transtubercular plane. कौन कह रहा है कि क्वेश्चंस रिपीट नहीं हुए? So transtubercular plane. Transtubercular plane is passing through the iliac tubercles, and this is L5 upper border. If L5 is not given, L4-5 you can choose. If they have asked the highest point of iliac crest, that is where you do lumbar puncture. That will be L3-4. Anteriorly, it will be umbilicus. Posteriorly, it will be where you do the lumbar puncture. So, highest point of iliac crest, L4. But maybe they have not asked the highest point of iliac crest, L4. They have asked transtubercular plane, which is L5. If L5 is not given, L4-5 should be your answer. Your question was on transtubercular plane, I believe. Earlier, they have asked about subcostal plane. So subcostal plane, where the costal margin ends, that will be L3. And they might be asking transpyloric plane, where you have pylorus of stomach, ending of adult spinal cord, transpyloric plane. And that will be the tip of 9 costal cartilage, L1 lower border. So L1 lower border, transpyloric plane, termination of adult spinal cord, tip of 9 costal cartilage, Murphy sign, Murphy sign. In the main videos, we keep discussing all that. So transpyloric plane, the subcostal plane, the umbilicus level, anteriorly umbilicus, posteriorly L3-4, where you have the highest point of iliac crest, L4, and transtubercular L5. If L5 not given, L4-5. PSM was tough. Yes, I have heard PSM was tough. I can agree to that, because usually what they do is one subject they will make a little bit difficult. So maybe I agree with that, because that is the feedback I have got. L4-5 was option. L4-5. L4-5 is, yes, your answer. Transtubercular plane. Vaginal delivery, melangia paresthetica, repeat question. See, not repeat question, repeat topic. Questions are not repeated, topics are repeated. You have to be careful. Don't mug up the answers to the questions. You have to work upon the topics. So lateral femoral cutaneous nerve, as it comes from lumbar plexus, passes under inguinal ligament, and be compressed because baby is in the uterus, and because of that baby, there is compression, and compression of this nerve, lateral femoral cutaneous nerve under inguinal ligament, and there is anterolateral thigh affected, meralgia paresthetica. So under inguinal ligament, compression of lateral cutaneous nerve of thigh, and but it will relieve after delivery. When the baby is delivered, it will improve. Because the baby is gone, the compression is gone, it will automatically improve. Upper border of lower rib was a question draining. Yeah, if you want to drain the pneumothorax or intercostal drainage, was it pneumothorax or intercostal drainage? Anyway, you will always choose in such a way that if, let us say, this is, let me move it a little bit. If you are talking about the vertebra and the ribs, then this is the next vertebra, next rib. So this is the rib. And you want to do intercostal drainage, you have to be careful that the ribs inner surface has costal groove. Ribs inner surface has costal groove. And there you have the vein going down. Vein going down means intercostal vein artery nerve. Intercostal vein artery nerve on the inner side of ribs in the lower border. So if you want to do intercostal drainage where you have some muscles, here you will have some muscles. So if you want to puncture these muscles and go inside the pleural cavity, where should you put your needle? The needle should be put in such a way that it should not, let us choose this color, it should not damage this nerve or this nerve. So upper border of the rib is preferable, though there are some neurovascular bundle there also, but upper border of the rib is preferable where you push the needle, or lower end of the intercostal space. So in the intercostal space, it will be lower end, but for the rib, it will be upper end. So upper border of the rib is safe place because you don't want to go here. Otherwise, you might be damaging the intercostal nerve. प्रीति मैडम को बुलाओ, आप पका रहे हो, अभिषेक शर्मा। ठीक है, अच्छी बात है, प्रीति मैडम आ रही हैं, आप निश्चिंत रहें। हाउसमेट नी के बारे में क्या ख्याल है? What is the difference between housemaid knee and clergyman knee? ये कौन है ये? अभिषेक शर्मा बताओ। अभिषेक शर्मा बताओ क्या डिफरेंस है हाउसमेड नी और क्लर्जीमैन नी में? जल्दी बताओ। प्रीति मैडम हम बुला रहे हैं, वो आपको माइक्रो पढ़ाएंगी, पैथो पढ़ाएंगी, इंतजार कर रही होंगी, कह रही होंगी डॉक्टर कौशल ने इतना टाइम ले लिया। अरे मैंने कहा था 12:30 से 1 के बीच में खत्म कर दूंगा, 1:30 बज गया है। पता नहीं सर, पता भी नहीं है और बातें भी बनानी है। कोई बात नहीं, शुरू में किसी को भी पता नहीं होता, चलो पता कर लेते हैं। ये फर्क होता है। देखो, हाउसमेट जो है पोछा लगा रही है, ज्यादा झुकेगी, और जब ज्यादा झुकेगी तो पेटला के आगे प्रॉब्लम हो जाएगी, पेटला के आगे प्रॉब्लम होगी, प्री पेटलार बर्साइटिस। लेकिन जो क्लर्जीमैन जो होता है, चर्च में आपने देखा होगा, वो ऐसे करके जो प्रे करते हैं, वो ऐसे बैठता है कि उसके वो नील डाउन है, आगे नहीं झुक रहा, तो पेटला के नीचे वाली एरिया में प्रॉब्लम होगी, इंफ्रा पेटलार बर्साइटिस। तो ये क्वेश्चन आते हैं, ये एफएमजी क्वेश्चन काफी पहले से आते हैं, क्योंकि मेड नील डाउन होके आगे बेंड करती है तो पेटला टच होता है फ्लोर से, तो प्री पेटलार बर्साइटिस, पेटला के जस्ट आगे बर्साइटिस है। जबकि ये आगे बेंड नहीं हो रहा, सिर्फ बैठा हुआ है, तो पेटला की दिक्कत नहीं है, पेटला से नीचे की तरफ दिक्कत है, इंफ्रा पेटलर बर्साइटिस। ये क्लर्जीमैन नी है और ये हाउसमैन नी है। इसको एनाटॉमिकली आप देखना चाहें तो यहाँ पर है कि यहाँ पे आप लैटरल व्यू से देख रहे हैं, और जब आप लैटरल व्यू से देख रहे हैं यहाँ से, तो आप देखें कि एक ये सारे सबक्यूटेनियस है, स्किन के जस्ट नीचे सबक्यूटेनियस है। तो एक है प्री पेटला, जो पेटला, ये देखो पेटला बोन है, पेटला बोन के आगे ये प्री पेटला है, ये हाउसमेड की प्रॉब्लम है। जबकि जो क्लर्जीमैन है उसकी पेटला के नीचे ये इंफ्रा पेटला, ये सबक्यूटेनियस होते हैं। इनकी जब हम बात करें तो दो अंदर भी हैं टेंडर और मसल के, उनकी बात नहीं हो रही। सो वी हैव प्री पेटला बर्साइटिस हाउसमेड, and then infrapetallar bursitis, which is clergyman. If you talk about concepts, these are the concepts. This is how you should, this is how we should teach, and this is how you should learn. Don't mug up some mnemonics. Mnemonics are very dangerous. नहीं अभिषेक, सॉरी की कोई बात नहीं है, सॉरी की कोई भी बात नहीं है, ऐसा कुछ नहीं है। पर एनाटॉमी तो वैसे भी बोरिंग सब्जेक्ट है ही, मैं बुरा तो मनाता ही नहीं। और प्रीति मैम तो सच में ही आपकी चहेती हैं, बहुत प्यारी हैं, और दो सब्जेक्ट आपको पढ़ाती हैं, बहुत अच्छी तरह से पढ़ाती हैं। मैं अभी वो मुझे कह रही हूँ पीछे बैठे बैठे कि सर प्लीज अब जरा मुझे भी आने दीजिए। सो हमारी सारी फैकल्टी बहुत अच्छी है, आप भी बहुत अच्छे हो, सब ही अच्छे हैं। Talus ossification, आखिरी क्वेश्चन, talus ossification. There are some of the bones, tarsal bones, which primary center of ossification will appear intrauterine life, means before birth. This is a forensic medicine importance. So primary center of ossification of some of the tarsal bones would appear intrauterine life when the baby was in the mother only. So you should know which bones are they. And for that purpose, we have this diagram taken from very old Gray's Anatomy. Now they don't give. So if you talk about calcaneum, this is the calcaneum heel bone, then you will see that intrauterine life, maybe 5th month it will come. And then over that talus is sitting. So we can show the talus here. This is talus, 7th month it will come, intrauterine life, and even cuboid it will come. So it will be 9 months. So just remember these 3 tarsal bones, the 3 tarsal bones, calcaneum, the talus, and cuboid. Cuboid is lateral. Their ossification, primary center of ossification, would have come intrauterine life. 5th month calcaneum, 7th month talus, 9th month cuboid. That's all I wanted to take care of. All the best. My wishes for good result and your future. So Preeti ma'am will be joining us, and she'll be taking care of pathology and microbiology. Have a nice day today. Thank you.
Hi everyone, very good afternoon guys. I hope I'm audible and visible to all of you. A quick confirmation please, and we'll start the session right away. So first and foremost, done and dusted. FMG July 2023 is done. I know you are not as happy as you thought you would be after the exam, but at least one sigh of relief is there that the tension is off your head. The exam tension is off your head. Of course, now the result tension is going to come up. But everyone's calling it July 2023. Honestly, it's given me a lot of vibes of August 2020. Where there was a sudden shift which I always give as a reference also, that, you know, till date, one of the toughest papers that came in FMG was August 2020. I think they took that reference too seriously and they thought that there should be something to match up to that exam. So they gave you July 2023. So going forward, I think this is also one exam which I'm going to use as a reference. And especially in this exam, what was the most dreadful part of this exam was paper one, for a lot of reasons. Before I start with the path micro recall, I think everyone would agree with me on this, that number one, all of us had studied a lot of pathology and a lot of microbiology, and we were very, very confident and very strong about it. We thought that easily, you know, 45 questions isme se ho jayenge, and that is going to give us a big, big leap and make us cross that mark. But somewhere the questions were not 40, 45 as we expected. If I recalled whatever I've received from the students till now, I've assumed that from path and micro combined, there are approximately 20 to 25, 20 direct, and with overlaps maximum we can touch a 25. That is for path and micro combined. So one thing is certain, that jo hamara strength tha, that did not come as much as we expected. Second point was, the paper that we don't usually like too much, that came in way too much abundance, and that was PSM. PSM came in a lot of questions, and of course, whenever PSM comes, it has to come as tough only. There is nothing known as all easy questions of PSM. PSM is always moderate to difficult, right? So our strength did not come as much, and our weakness was exploited a lot in the exam. So I believe that is what gave a lot of students cold feet after paper one. But thankfully, paper two was better than paper one. And if you guys remember, this is the opposite that happened in the January exam. January exam mein paper one was very, very easy. Everyone was very confident. But after that, when they went inside paper two, they came out crying because paper two was very, very bad. So one exam or one of the two papers, this has somewhere become the rule that one is going to be a little easier and the other one is going to be moderate. This was one analysis that I personally made after talking to students. The second analysis that I felt was, how many of you believe that the paper was a little lengthy? Or little, nahi, that will be an understatement. The paper was genuinely lengthy. Why was it lengthy? It wasn't, I did not feel that pathology had some different new topic or micro had a new unheard organism. Aisa nahi tha. Everything was heard of. But number one, this looked more like an English exam because many students had a problem in comprehending the question. I mean, why did we call it tricky? Because there was a lot of language issue that this paper had, in the sense that, you know, those questions were written in a manner that first you had to decode the English, first you had to decode the language, then you had to decode the concept, then you had to decode the options, and that was taking a lot of time. So obviously I have come across many students who could not even complete the exam. That came across as a major drawback, and something that of course you must be feeling very bad about, because when you study so much, ekdam se when you see that, you know, I know the topic but I'm still, like for example, there was a question on cholera. Everyone studied cholera, rice water stools, but they did not ask you cyclic AMP. They asked you GM1 ganglioside. Why? That is a PYQ. But it's not an FMG PYQ, it's a NEET PG PYQ. So of course, PYQs were asked, but they probably got a little deviated that from where do they have to ask PYQs. So a lot of NEET and a few INI PYQs were also there. So yes, it's a lot of mixed emotions. While I say that there was no new topic, I cannot deny the fact that the questions of the same topic were twisted in a manner that despite knowing the topic, you did not know the answer. And that I feel is more heartbreaking. Ek hota hai ki ma'am suna hi nahi tha, padha hi nahi tha, meri kya galti hai. But there you had questions which you had read. They were staring at you, they were making fun of you. That, you know, you've read this topic and still you can't answer the question. That is even more heartbreaking, and I can totally understand what you must have gone through in that duration. But as of now, whatever questions I have got, I am going to discuss those. But one take home message for the students ahead is going to be that topics abhi bhi wahi rahenge. It is going to be the same patho, same micro, anatomy and everything. New topics the examiner is not exploring. Topics are the same, but examiner is taking two things. He is going into the depth of those topics. So you don't have to limit yourself only to, okay, read one sentence and khatam. You have to go into the depth of the topic, and the examiner is giving you clinically lengthy questions. So this is two take home messages that I have for the students who are preparing for December and next and other exams that are coming up, right? So this is something which your seniors will also tell you. Topic nahi padhne. Topics are the same. same. Now you just have to increase the depth or the knowledge into which you are going, right? Okay, let's start. I think everyone would, I've just recalled, this is not a recall session, this is a recall of the trauma, I would say. That Abhi, whatever I said right now, it must have got your entire paper in front of you, and this is like so bad that after 24 hours, I'm making you recall trauma. But that is how life is. We have to move ahead and we have to take the positive out of it even when you can't see any. So we are going to recall the question which I've called as recalling trauma for the day. Okay, since you've just come across anatomy before this, so I think this question you've already discussed with the Rajesh Kaushal sir, that is the layer of the GIT which is not seen in the esophagus. Now of course there's going to be a lot of discrepancy in the questions that I'm telling you right now, so you can at any point of time you feel that ma'am kuch alag tha, and many of the questions are much lengthier. So at any point of time that you feel that there's a problem, you can definitely let me know. Or if you feel something needs to be added, of course this is open to discussion. So which is the layer which is not going to be seen in the esophagus? It is going to be the serosa, right? It is going to be the serosa. So you can see this diagram over here. The innermost layer is going to be the mucosa. Below the mucosa, you have something that is referred to as submucosa. Then you have the layer that is going to be the muscularis or the muscle. This everyone in the GIT has, na? Every organ, mucosa, submucosa, muscularis. Esophagus is the only one where the serosa is absent. I know many students are like, ma'am, we really don't care, ab aage ke liye nahi padna, but a lot of students are preparing for December exam also. So please note, future may a question can come which is the organ where the submucosa is absent, and that is going to be the gallbladder. These are the only two layer related questions that you have for anatomy that you have to know, right? Okay, so let's get going. Submucosa is absent in gallbladder and serosa is going to be absent in the esophagus. Done. This was anatomy question. Ye khatam kare. I hope everyone got this right. Okay, let's move on to the next question that you have over here. Look at this, a core pathology or a medicine question, whatever you want to call it. They gave you a case of celiac disease. Celiac disease padte, I hope everyone thought of only one thing: gluten, gluten, gluten. And as soon as you hear about gluten sensitive enteropathy, gluten wale foods hata do. This person should not be eating gluten wale food. What are the gluten wale food? Everyone remembers that mnemonic. That mnemonic was the brow cereals. The bro cereals means barley, rye, oat and wheat. Barley, rye, oat and wheat, all of these have gluten. So these are the things that do not have to be consumed. Tell the patient don't have these things. So barley, rye, oat and wheat, and semolina or suji, that also comes as a derivative only. That is also not to be consumed. So what is the food that can be advised? What will you tell the patient to eat? The patient can have rice. Rice ho gaya, maize ho gaya. These are the things that the patient can consume, and these are the things that you can answer. Someone said momos is the answer. Okay. Up to now you have all the time in life, so you can go ahead with momos and eating all the junk food that you want, right? Chalo, coming back. So this is the only thing that can be advised to the patient. Easy question, I suppose. This also, ये भी सबका ठीक होगा. Started off with questions जो देख के लगे कि हाँ somewhere I'm gonna pass this exam. Of course I'm gonna come to the tougher ones also, but let's start off at a good note. We don't have to be so negative about the exam. Yes, everyone, this is okay question. Let's move on to the next one. This is something which I've got a lot of controversy. Many people saying, ma'am, this was the image. Some are saying this wasn't the image. So this is, I leave it to you guys. If you will have to first confirm to me कि ये वाला photo था या नहीं था. If this photo is there, then I can teach you. But most of the people on Telegram have actually sent this screenshot to me, and they've told me that this is the photo that was there. And I have already taught you that when it comes to pedigree chart, go back to the 2G generation. 2G kya hai? Go back to gender, go back to generation. These are the two things that you have to see. Gender, generation. Why do I say that? Gender. If there is a gender bias matlab, ma'am, something kuch to ya sirf male has the disease, female has the disease. If there is a gender bias, it is X and Y related, X and Y chromosome related. Over here, do you see any gender bias? I don't think so. Over here, male is also having the disease, female is also having the disease, every possible gender is having the disease. So gender bias nahi tha. This means your X and Y things are out. It is one of these two. autosomal dominant or autosomal recessive. And now for that you have to go to generation. So tell me, is every generation affected? This is where you had to read this pedigree a little carefully. Batao, look at this pedigree. Is this first parents are affected? I'll put a plus. Yes, yes, parents are affected. Parents gave birth to 3 children, 1, 2, 3. Are they affected? No, please don't count this. This is not a child of these parents. This is a person whom he got married to. Isse nahi count karna. This is over here 3 children. Are they affected? They are not affected. This means the generation is being skipped. And skipped generation means we are dealing with autosomal recessive. So if generations are skipped, then that means we are dealing with autosomal recessive. If all generations would have been affected, then it would have been autosomal dominant. So this becomes a case of autosomal recessive, provided, again, that is subject to a clause, that is provided if this was the photo, then the answer becomes autosomal recessive. Many of you have agreed with me, so I will also go for autosomal recessive in this case. Is that okay with everyone? We can move forward. Some numerical kind of question. They were pretty fond of genetics out here. They give you this numerical kind of question also, which I've got half recall hua hai abhi tak. But I can tell you different options. You can select, right? Okay, Dr. Zafar still believes it is autosomal dominant. Maybe some other photo again. Like I said, depends on which picture came in the exam. It could be any of the following pedigrees, but obviously the answer will change depending on the answer or the pedigree photo that was given to us in the exam. Okay? Since majority of you recalled this photo, that is why I have described this one. Okay? Chalo, moving on to the next one. Here you have a thalassemia case and they asked you the percentages. What had they written? There is a pregnant woman who has thalassemia trait and her husband is also having thalassemia trait. So both parents had thalassemia trait only. So theek hai, means thalassemia major nahi tha. The female also had thalassemia trait. The father or the male also had thalassemia trait. Now they are saying what is the chances for the next offspring? Ab ye mujhe batao, what did they ask? Bacche mein kya? What have they asked? Were they asking how many kids will be thalassemia trait, or were they asking how many kids will have thalassemia major? Because that changes your answer. I'll tell you how. Thalassemia trait kya hai? Thalassemia trait is autosomal recessive disorder. Capital A, small a, capital A, small a. Let's assume autosomal recessive mein chota wala. This chota wala A has a problem. Okay? So mother is also chota wala A problem. Father also has chota wala A problem. Let's make that analysis and you tell me kya pucha tha. So one child will be capital A, bilkul normal. No problem in this child. One child will be capital A and chota wala A. Ma'am, one child is trait. Okay, next child, again that child is also chota wala A problem, that child is also trait, but this last child has both the chota A's. Both the chota A's means this child is a case of thalassemia major. So now, depending on what was asked, if they asked you how many percentage of kids are going to have thalassemia major, tell me how many kids have thalassemia major? 1 out of 4. 1 out of 4 kids have thalassemia major means 25% of them have thalassemia major. So agar exam mein thalassemia major pucha tha, how many kids will have? You will mark 25%. If they would have asked you how many kids are at a risk of having thalassemia trait, how many kids with trait can you see? I can see 2, matlab 50%. So again, I'm putting it out to you. Many of you have said, ma'am, thalassemia major hi pucha tha. So simple in front of you, if thalassemia major was asked, and this you should even know offhand for your knowledge day to day. If both parents come out to you as trait, mother is also a trait and father is also a trait. So kya counseling karna hai? Kyun counseling karna hai? Why do you have to tell them that they are at a risk in the pregnancy? Because 1 out of their 4 kids will have thalassemia major, and that is something which is non-treatable. That is going to be lifelong and is going to be requiring a lot of blood transfusion. So you have to counsel in this situation, right? I hope this is okay with everyone. Another question settled. Some of you might have got it wrong. These kind of questions na need a little patience. Exam mein jab bahut panicky ho jate ho and you feel, arey abhi I did not know 10 questions and now this mathematical question has come in front of me. Many people get it wrong only because panic sets in. And so many people have written to me that, ma'am, kuch to questions kharab the, but then the questions we knew also na, that we ended up getting so panicky in those questions that kuch nahi aata ya nahi ho raha. We made such silly mistakes, and I can understand that that breaks your heart a little more than the lengthy questions. Silly mistakes are a guilt that you carry for a longer time, right? चलो लेट्स मूव ऑन टू. अच्छा, एंड मेनी ऑफ यू, सम ऑफ यू आर सेइंग कि रिकॉल करने से डर लग रहा है. क्यों डर लग रहा है? मतलब फर्स्टली लेट मी टेल यू, ऑनेस्टली टेलिंग यू, आई हैव कंडक्टेड सो मेनी रिकॉल सेशंस इन द पास्ट फॉर सो मेनी एग्जाम्स. ट्रस्ट मी, समवन हु हैज एस्टिमेटेड अ थिंग इन दिस हिज और हर रिकॉल वर्सेस फाइनल रिजल्ट, उसमें ना 20 का तो डिफरेंस होता ही होता है, वेदर इट इज नीट पीजी और INI-CET और द FMGE एग्जाम. 20 मार्क्स का तो डिफरेंस आएगा ही आएगा. दैट कुड गो ईदर वेज. हाँ, +20 ऑल्सो, -20 ऑल्सो. आई हैव सीन इवन अ बिगर डिस्क्रिपेंसी. व्हाई? Because recall is what based on what students are telling us. Now some information might be missed, some information might be extra, so itna you don't have to take it to the heart. You just have to get an overview that broadly what is the paper like, and that's about it. You don't have to sit in any guilt or any depression at this point of time. And डर के क्या होगा ना, it's happened. Exam you can't change. Now the result will tell you. At least this time that you have, which I call as the golden phase of your life, means that right now you don't have your result in hand, so you don't have to do any future planning. Abhi ke liye you just have to sit and wait. Waiting period is still better, because once the result comes na, that creates more chaos in your life. So abhi catch up on your sleep, spend time with your family, go out for a vacation, spend time with your friends. Kuch nahi karna, just Netflix dekho, but don't get into any depression or guilt at that point of time. theek hai? Chalo, coming to the next. This is another question that we've got. This to everyone must have got it right. Isme kya confusion tha? Some students said that amyloid in hemodialysis was asked. Some students said that amyloid in Alzheimer's was asked. कुछ भी पूछा हो, I think you guys were ready with answers. This too, if you studied from me and if you've not answered, then I'll be very angry with you. This you have to know. So if hemodialysis was asked, then your answer becomes A beta 2 protein. Remember how we used to study it, that there are two kidneys, and most of you said hemodialysis were asked. So if hemodialysis tha two kidneys, तो A beta 2 protein was elevated. By chance if you feel Alzheimer's was asked, then उसमें A beta होता है. But again, most of you, I agree with you. Hemodialysis पूछा था, A beta 2 protein, ये वाला question, हाँ. But again, I agree with this thing that Dr. Bala is saying, that this was not a one-liner. None of these questions were one-liner. But problem क्या हुआ है? Students have come back and given us only that buzzword, because recalling the entire question and with that complicated English and so much of tricky things, twists and turns, is very difficult for every student. So every student has picked up buzzwords, and as long as the buzzword helped him or her answer the question, that student is okay with it, है ना? तो at least ये ठीक था. कैसा भी twist and turn करे, I really don't care. As long as hemodialysis हो रहा है and there is amyloidosis being asked, no matter what twisting and turning may be done, answer will always be A beta 2 protein. Yes, so this though has to be one of our strong +1 wala marks that you have, right? Okay, coming to the next question. This again, this I've received yesterday. No student told me. Today morning some students told me that there was some question about an adult male, and that adult male basically had respiratory discomfort. So there was some involvement of the lungs, and they said that on histopathological examination, asteroid bodies were present. One more thing that many students have told me, कि मैम majority में photos नहीं था. This time, you know, till today, till the last 3-4 years, they have been giving lots of pictures. This time, what did they do? They made life a little easier. Why? Because photo was not there, but the description of the photo was there. Now, many of you kept complaining कि मैम photo blurred आता है, photo समझ नहीं आता, pathology is very tough. They've eliminated that, but then time consumption हो गया ना. They gave you a really long history, and then you had to pick up this buzzword, and this buzzword was अच्छा lungs में asteroid bodies, means we are definitely dealing with a case of sarcoidosis. What are the two bodies that come in sarcoidosis? One of them is in front of you, that is the star-shaped asteroid body, and the other one is going to be Soumen body, right? Soumen bodies and asteroid bodies are two. So whenever they will be written, I will think of sarcoidosis, and the most common organ involved in sarcoidosis is also the lungs. Lungs के बाद कौन सा? Lungs के बाद lymph node. I don't know if lymph node was written in your questions, but usually sarcoidosis comes like that. It's a respiratory discomfort with a lymphadenopathy, and that is what you have to no, right? So this is acha non-caseating granuloma likha tha, then to your life becomes so simple. Okay, I thought this was a separate question. If it's a part of the same question, then to it's even better. I mean, non-caseating granuloma is a bigger hint in the lungs. Caseating hota, I would have thought of TB. Non-caseating hai, to I will think of sarcoidosis. Same question mein tha. So as I see this, I used to tell you before the exam also. Let the examiner talk. Jitna lengthy question hoga, examiner is giving you more hints. I told you this before the exam कि एक ही चीज का ध्यान रखना, patience रखना. Don't feel अरे 10-line question है, what will happen, panic and all of that. No, read it like an essay. You will miss one hint, you will catch the other. If you miss the second, you will catch the third. कहीं तो you will catch the hint, but हाँ, you need to practice on your time consumption for that. Now, time management is very important in such questions. And many students, for students who've given the exam and who are now, obviously, you know, you've gone through the trauma, you've gone through all of it, but you also need to understand that there are a lot of juniors who have joined into this session because they are going to appear for December exam. So please उनको इतना demotivate मत करो कि they should stop studying only, and for 1 month they should go into depression along with you waiting for your result. At least guide them in a manner that, you know, these are the things now you have to do and this is how you need to change. It's all about changing. So give them a little bit of positivity ताकि they can move forward and at least not stop studying, right? Chalo, this is done. Let's move on to the next question. This was a surgery, pathology, whatever you want to call it. It was a breast lump, and breast lump, of course, in an adult female, and there was a histopathology. I don't know if the photo was given or if only the description was given, but this one behind the other wala jo cells hota hai, that's the classical Indian file pattern. ठीक है? Indian file pattern. So now one more thing, as soon as they write Indian file pattern or they give me a picture like Indian army one behind the other, Indian file pattern, image was there, okay, image was there, तो मतलब classical lobular carcinoma. One more hint was given. They also told you that there is loss of E cadherin. This to come on, this I can understand question lengthy raha hoga, but students who had read this, that whenever E cadherin is lost, there are two tumors that occur. Do you remember something that we always used to study as golu? कुछ याद आ रहा है? We had studied this in the YouTube session also. In your, ये तो genuinely PYQ से ही आया है. This you cannot deny. This is a surgery PYQ also and a patho. 1 या 2 तो PYQs have been repeated. So this to we have to know. What is this? Tell me something. I always told you E cadherin is like Fevicol. It's like a glue. Two cells are held together with E cadherin. Now glue is gone. E cadherin is gone, तो glue अगर चला गया तो golu tumors used to occur. What was golu tumors? Please remember, it is gastric cancer and lobular cancer. Breast का lobular cancer, breast. So remember here lobular cancer was mentioned, Indian file pattern was mentioned, E cadherin was mentioned, सब कुछ was in favor of lobular cancer. Please, I hope, fingers crossed, this was also a +1 that you guys got. You have not made an error in this. These questions तो at least जो बिल्कुल straightforward थे उन्हें तो you had to get correct, right? So this was also right. We can move forward. Now I don't have the options of these, but there are some buzzwords again which I've got for them. And what is that? Number one, they gave you a history of RBCs and a pediatric child and the typical cola color, hematuria wala urine, right? So please note PSGN, and same for rheumatic heart disease. दोनों का causative organism पूछा जाएगा. What are you gonna do? So smoky, okay, smoky or cola, this is their favorite. You know, this color they can never stick to one. Sometimes they call it cola color urine, sometimes they call it smoky urine, sometimes they call it coffee color urine. So that basic concept is that they have to denote के urine में blood है. Blood का different colors they will tell you, coffee, cola, red, brown, वो सब चलेगा, right? But I think the organism does not change. Both of them are caused by Streptococcus pyogenes, and pyogenes belongs to what? Group A beta hemolytic streptococcal. Many students knew, I mean, who would not know this? सभी को ये पता था, but still some students wrote to me, मैम गलती से group B mark कर दिया. Now this is again because you panic in the paper, which is human tendency. Because of that you make such silly mistakes, है ना? So of course in PSG, and many of you are saying that okay, there were two separate questions. ठीक है, this I honestly I'm sorry, I was not aware of. मुझे अभी तक what I've got is that PSGN में there was a hematuria and there was a red cell cast and a child was there. So I assumed that बच्चा है with hematuria, so it has to be cola color PSGN. If there was a separate question, then we'll deal with that also. You can let me know at the end. But इसका answer sorted है. It is group A beta hemolytic streptococcus. Yes, let's move on to the next one. Here you had a question which is हर बार का मतलब kind of expected topic है, इसमें भी कुछ अलग नहीं आया. Okay, one thing for the previous one, many of you are telling me that tonsillitis was also present. Fine, that can also happen because of streptococcus, na? Tonsillitis is also a possibility as long as we have entered into the kidney involvement, I'm dealing with Streptococcus pyogenes only. ठीक है, चलो, coming back. Okay, this was the question. Elderly male, low back pain. Some parts of this question I have added on my own because students gave me बहुत टूटा ऐसा bits and pieces, so I assumed कि क्या क्या पूछा होगा. There was an elderly male with low back pain. Whenever they mention low back pain, they go on to radiology and they mention these bony lytic lesions. And when bone is breaking, they always say that the calcium levels will be increased. I agree, photo शायद नहीं होगा. Photo, I am assuming, must have not been there, but they had mentioned that gamma globulin is increased disproportionately. So if gamma globulin matlab immunoglobulin, and immunoglobulin basically means with these bony lytic lesions, with low back pain, with these serum calcium levels. This photo I've got only for showing you. This was not there in the paper, right? So now this is a case of multiple myeloma. Okay, either this was given, many of you are saying, ma'am, they just asked us which cells were affected. So multiple myeloma is a tumor of what? Multiple myeloma is a tumor of the plasma cells. So indirectly, which are the cells that are going to increase in the bone marrow? Bone marrow mein I will see lots and lots of plasma cells. So either ways, either it came across as multiple, but many of you are saying that options में plasma cell था, तो indirect तो वही बात है ना, plasma cell is a tumor, का tumor is multiple myeloma, right? ठीक है, so I think that is settled for everyone. And other options क्या हो सकते थे? Maybe they had asked you about M spike, right? That is one thing. Multiple myeloma was not given exactly. Yes, guys, I've agreed to that. ये हो गया discussion. This was given as plasma cells, so we will assume it as plasma cells. Future में MM plasma cell same चीज, right? So this is not there. Again, Dr. Lokendra, I totally agree. This is not this. The first line I said was I have made this question on my own because students just told me, ma'am, multiple myeloma पे वो gamma globulin वाला question आया था. So this is something what we usually see in questions. This is not the same language that must have come in your exam. It must have been a little different, but overall crux of the matter is gonna be there. Okay, some of you have mentioned Langerhans cell histiocytosis. ठीक है, can Langerhans cell histiocytosis have bony lytic lesions? It can. But Langerhans cell histiocytosis में why will gamma globulin be increased? Gamma globulin is increased, calcium levels are increased. These are something which are very famously known for multiple myeloma. एक और चीज, do you guys by any chance remember the age of the patient? Are you sure? Elderly था, ये बता दो. I will tell you one more differential in that case. Was it an elderly person? Because elderly person में low back pain and lytic lesions, you will think of plasma cell multiple myeloma. Because many of you are confusing it with Langerhans cell histiocytosis. If you have gone through, I mean, ये तो that person would know who's gone through the rapid revision वाला videos also in depth. Langerhans cell histiocytosis is going to be a child with lytic bony lesions. The age also is going to be very characteristic. तो बच्चा होता है with these lesions, I think of Langerhans cell histiocytosis. Adult होता है with lytic bony lesions, and the main crux, गामा ग्लोबुलिन. इसके बाद यू कैन नॉट थिंक ऑफ एनीथिंग एल्स. इम्यूनोग्लोबुलिन बढ़ गया, व्हाट एल्स एविडेंस डू यू नीड ऑफ प्लाज्मा सेल? पक्का प्लाज्मा सेल है. नो कंफ्यूजन आफ्टर दिस. एवरीवन सेटल द कंफ्यूजन राइट अवे. इसका टॉपिक क्लोज. इट इज अ मल्टीपल माइलोमा प्लाज्मा सेल ट्यूमर. इफ दे वर टू डिफरेंट क्वेश्चंस, that is a separate issue. अभी तक everyone has told me that this was one question only. ठीक है, चलो let's move forward and try to recall some other ones. Again, I have not got इसका भी, again like I said, most of the questions everyone's given me buzzwords. So they said that there was a history of a female with a neck swelling which was moving with deglutition, but the buzzword over there was calcitonin was elevated. So if calcitonin is elevated, there is possibly in the entire body only one thing coming to my mind, and that is medullary carcinoma. I don't want to think of other options. मुझे जानना भी नहीं है. Because if calcitonin elevation was mentioned, or in future exams, if amyloid of calcitonin A-cal is mentioned, I will always and always ask medullary carcinoma. So again, this is not a... Yes, what does medullary carcinoma thyroid arise from? It's the only tumor that arises from the parafollicular C cells. So this is also settled over here. But students, now this is one thing that students might not agree, because thyroid tumor pe na, there were two questions. One question was to do with calcitonin. This was, and okay, the history mentioned parafollicular C cells. तो ये तो examiner ने like serving on a platter वाला question है ना. Parafollicular was also mentioned, calcitonin was also mentioned. So this was a +1 wala question. You cannot get it wrong. But many students also told me that ma'am, examiner can never get rid of papillary carcinoma. तो उस पे भी एक question था. But no one told me options. But everyone was very excited कि papillary पे question था. But क्या question था, कैसा question था, that no one really bothered to tell me. One question was expected till now. Papillary pe orphan annii was gonna be there, but this time probably they did not give you orphan annii, and this time they give you something else. The most common wala tumor that you have in the thyroid, most common cancer in the thyroid is going to be papillary carcinoma. Acha, the most common cancer, if that was only the question, then to of course papillary options with except. If you can recall the options with me, I can tell you a true and false. What students told me was simple. Aaya tha, ma'am, what is the most common carcinoma in the thyroid? So we ended up marking papillary carcinoma. But ठीक है, I think either ways papillary वाला गलत नहीं हुआ होगा. Hoping, fingers crossed, that this should have also been a +1 वाला question. Okay, you out of 4 options I've not received. So again, that is something which we'll have to consider. Anyone, if you know, I'll move forward, but meanwhile किसी को भी अगर चारों options याद आएंगे, so I'll bookmark this slide. You can just write it in the comments and I'll discuss this once again. ठीक है? So just in case, अभी तक I've not got, अभी तक everyone asked me most common tumor पूछा था, so my answer is papillary. Anyone who can, please write it down and we'll discuss it. ठीक है? अभी we won't waste time. We'll move forward. There are 2-3 more questions which have come as this only. They asked me that again, ये वाला question you guys have already told me, ma'am, there was a question on non-caseating granuloma. We have already discussed it. This was a sarcoidosis का question with asteroid bodies. तो ये वाला settled है. Many students also told me that there was a burns associated patient, and burns associated में what was the ulcer that they asked you? That was Marjolin's ulcer. This is not a patho question, but students were recalling too much on Telegram, so I thought I'll put it across in your recalls. But this is primarily a surgery question. So burns के patient में Marjolin ulcer, and Marjolin ulcer is at a risk of which cancer, guys? Come on, आगे के लिए थोड़ा information भी देख लेंगे. Marjolin ulcer is at a risk of, is going to be at a risk of squamous cell carcinoma, right? So surgery mein, this is quite an important question that you have. Even in, for that matter, even in dermatology, it is very, very important. ठीक है, fine. So now we come to the next one, irreversible cell injury. ठीक है, so इसके अंदर again, this is simple. I expected कि ये बहुत simple question होगा, but no one told me the exact answers to it. Some people said that myelin figures were asked. Some people told me that they had asked you amorphous density. Some people also told me that they had asked you nuclear shrinkage. ठीक है, so again, this is something which I am trying to figure out. If you guys can help me with this also, that will be great. Because does irreversible cell injury show you amorphous densities? That is, of course, amorphous densities तो दिखता ही दिखता है. It can also show you myelin figures. We have studied. So सब कुछ नहीं होगा options में. Somewhere you have to narrow down the options and tell me that what is it going to be. So plasma blebs, nuclear blebbing. ठीक है. So I'm reading all of these, but as of now, you know, all these options can't be in the same question, because irreversible का इसमें से भी by chance if you say नहीं मैम सभी दिया ही दिया हुआ था, then amorphous densities is something which is quite characteristic. But अच्छा, reversible cell injury are all except, fine. Now the question has changed. So if they had asked you about reversible cell injury all except, then of course I would say that amorphous densities तो reversible cell injury में नहीं दिखता. Right? Amorphous is not seen. Amorphous densities matlab that calcium wala thing, na? That is a very, very characteristic feature of irreversible cell injury. But yes, I believe still this question will carry on for a while. Meanwhile, I think a lot of students have started telling me the answer. Thank you, Dr. Abhijit, who has recalled the previous wala, thyroid cancer wala. Dr. Abhijit has told us that the options were that papillary carcinoma has 98% survival. Honestly 98 नहीं 100% survival होता है. तो basically the prognosis is very, very good. तो I would for the time being consider it as true. Second, you are saying it has a risk of radiology. I think you radiation exposure you mean. बिल्कुल, it is associated with radiation. ये भी ठीक है. Third option, you are saying it was associated with calcitonin. नहीं, papillary carcinoma cannot be associated with calcitonin. ये तो बिल्कुल ही false है, because calcitonin is medullary carcinoma thyroid, है ना? So ये वाला तो false option है. Meanwhile, if anyone can recall the next option, So then you can let me know, but calcitonin to pakka is a wrong statement. That is something. It is seen in young people, bilkul. Papillary to I have seen even in 15, 19, 20, 22-year-olds. Even in teenage, I have seen papillary carcinoma occurring in people. So it is definitely going to be arising in the younger population only. Age group mentioned था 20s या 30s वाला mentioned होगा तो चलेगा. That is the age group of papillary. Calcitonin is never ever for papillary. ठीक है? चलो ये वाला question हो गया. Can we move forward, guys, to the next one? Again, this was 10 years and 98% survival chalega. 98 and 100% survival, same cheese. Na? You have to look at the other options also. In clinical practice, I'm telling you 100% होता है. But ठीक है, they've written 98 because मुझे अपना गलत वाला option तो मिल गया है ना. Then 98, 100 adjust कर सकते हैं. I believe so, right? Okay, chalo, moving on to this one. Many students told me, I don't know if the photo was given, I'm assuming nahi diya tha, but all these points again, buzzwords were written. That is, there's a patient of diarrhea with falling leaf motility. Come on, this you could never ever get wrong. That is why I didn't ask anyone for options also. Isme bhi options ki zarurat thi, so it was a problematic point, right? +1 for this, but the question was very lengthy is what students told me, that ma'am we were digging कि कहीं पर कोई buzzword मिले और answer मिले. तो I think when you see falling leaf motility, when you see the tennis racket wala shape, when you see 4 pairs of flagella, remember the story of the, how many of you remember from our YouTube session the story of the angry uncle, and then we said giardia, lamblia, GL, गिरता हुआ leaf was falling leaf motility. Of course, as I said, photo nahi diya tha. I've got you for reference that what were they trying to picturize. This is one more thing that I realized. This exam, they did not give path microcale at least. They did not give you too many pictures. They just described the photos. They wrote a description and that made your question longer, lengthier also, na? Because they started writing that, okay, there is a falling leaf motility with 4 pairs of flagella with tennis racket shape. So isse 2 sentences aur ho gaye, your length increases. If they would have directly given me this picture, I would have answered in 5 seconds, because photo dekh ke to I know they are talking about the angry old man, they are talking about giardia, but when I have to sit and read, automatically my timing increases, na? Then I can't solve the question in 10 seconds, 15 seconds, then I'll take 40, 45 seconds, and that is what made it very lengthy. But koi baat nahi, now pattern will change every time. Maybe this exam had too many images or too many written parts, maybe the next exam will have images. What I'm trying to tell you again and again is, don't feel that I have to start studying something new, या फिर हम एकदम से we will, you know, now from today onwards इतना depth में पूछा था तो I will study pathology for 100 hours, anatomy for 200 hours. नहीं, that is not the point. You still study the topics. देखो, giardia is not a new topic, ना? Topic तो वही है. Giardia has been coming since age, decades, right? The only thing is that the type of question has changed. The way of asking a question, pehle one liner tha, falling leaf motility seen in, then they gave image based. Now they've given in pura lengthy wala question, time based wala question. You need to start practicing your time management, that means. So as what I'm saying is again and again कि giardia पहले भी पढ़ना था, giardia आज भी पढ़ना है. पहले भी यही 4 points थे, आज भी यही 4 points है. Nothing has changed about it. What has changed is try to train your brain on how to solve lengthy questions, how not to get scared of situations, how not to run away from situations, right? Kuch topics, Dr. Shivani, will always be there. This I told you before the exam also. If you are going with that थॉट प्रोसेस दैट मैंने तो सब पढ़ लिया तो 300 में से 300 मुझे आता होगा, वो तो टॉपर को भी नहीं आता होगा, वो फैकल्टी को भी नहीं आता, वो एग्जामिनर को भी नहीं आता. एग्जामिनर ने भी probably has read it from some journal, from some recent advances. No one knows everything. So if you feel that अरे I have to studied all the videos and all the notes, I should know 300 on 300 topics. No, some 30-40 topics तो ऐसे लगेंगे कि अरे they are alien, they have come from some other world, some other planet, and that is okay. That is why it's a competitive exam and that is how medical profession is. उस पे नहीं focus करना. Your 250-260 topics still remain the same ना. 40 topics को out of syllabus रहने दो. That is okay. Otherwise topper will get 300 on 300. We will go under depression. We don't want that. So let some topics remain like that. Okay. Chalo. Moving on to the next one. This is a question again which I got this morning from one of the students asking me PEL, primary effusion lymphoma. Primary effusion lymphoma is not an FMG PYQ, it's a NEET PG PYQ. So NEET PG PYQ में primary effusion lymphoma has been asked a lot of times, and it is associated with what? The very famous, yes, HHV8, human herpes virus 8. So what we used to study for human herpes virus 8 is usually Kaposi sarcoma. Kaposi sarcoma is seen, also lymphomas mein primary effusion lymphoma is seen, and one more thing is seen, that is Castleman disease. Okay, so these are the three things that, okay, some of you are saying ma'am HPV bhi tha, kuch bhi ho option mein, ab fourth wala, whether it is HPV or some of you are saying Helicobacter was also there, theek hai, doesn't matter, I've got my answer. Primary effusion lymphoma is human herpes virus 8. Same wo Kaposi sarcoma wala virus causes primary effusion lymphoma. And how does the patient present? Lymphoma, matlab patient has cancer. Which cancer? Effusion, बहुत सारे effusions. Patient will come to you with pleural effusion. Patient will come to you with pericardial effusion. Patient will come to you with peritoneal effusion. So बहुत सारा effusion का history होगा, and that effusion will be nothing but a cancer. That is going to be a lymphoma. So this is also settled. Human herpes virus 8, this is again RR में ये है. This is if you feel कि मैम ये NEET PG PYQ था, so I should have read the main videos for it. नहीं, why I kept telling you बार बार RR पढ़ो, हर एक line पढ़ो, हर एक word पढ़ो, because this was there in the RR itself. We have studied it. So it's just that sometimes you read but सब कुछ याद नहीं आता exam में, right? But yeah, this is there which gets you down to the same point. एक ही source बार बार पढ़ो and try to solve different patterns of question. हमारे साथ ना what is the problem is we feel notes बहुत अलग अलग sources से पढ़ने चाहिए. I should read from 10 sources all the notes. No, notes one source, questions have to be done from multiple sources. We do ulta. We do notes of many sources, and questions ke time we act lazy and we only do questions of one Q bank or of one place and then we sit. No, it has to be the opposite. Notes of one place and question type, every type I have to do, from one-liners to PYQ to lengthy wala questions to image-based questions. That is what you actually have to do to be able to get a comfortable score in any competitive exam. Chalo, this one is done. We move forward. Kuch to tha where you must have remembered me. I think this is one place where you not only remembered me, but you also remembered my name. You also remembered the Telegram group. तो ये तो पक्का ठीक हुआ होगा ना. इसका तो +1 डेफिनेट. नो वन गेट्स इट रॉन्ग. पेंसिल शेप्ड मैक्रोकोनिडिया, अगेन इट वाज अ लेंथी क्वेश्चन. दिस इज द बज़वर्ड दैट आई गॉट. तो एटलीस्ट इसमें यू मस्ट हैव डन ओके, थैंक गॉड, कहीं तो मैम का कोई निमोनिक हमें काम आया. रिमेंबर वी हैड समथिंग कॉल्ड TME for Trichophyton Microsporum Epidermophyton, TME है ना. And for this we had learned PSC. So TME for Telegram, and PSC was Preeti Sharma channel. So what was the macroconidia? Pencil shaped, then we had spindle shaped, then we had club shaped. So TME PSC, this was asked. पेंसिल पूछा था तो क्लियर कट वी हैड टू मार्क ट्राइकोफाइटिन. ठीक है, तो ये वाला तो डायरेक्ट आया होगा. एटलीस्ट लाइक आई सेड, समवेयर इन द एग्जाम यू मस्ट हैव रिमेंबर्ड मी एंड देन यू मस्ट हैव प्रेड टू गॉड कि ऐसा 2-3 और क्वेश्चंस आ जाए तो मेरा थोड़ा सा बेटर हो जाएगा रिजल्ट, राइट. सो ऑफ कोर्स दिस इज समथिंग व्हिच वाज स्ट्रेट फॉरवर्ड. +1 फोटो नहीं था. हाँ, फोटोज टुडे आई हैव गॉट यू फोटोज ओनली के थोड़ा रेफरेंस के लिए. मेनली इट हैज ऑल कम एज इमेज, इट हैज come as written questions. Photos I've only got for you from point of view of correlation. That's it. ठीक है. चलो, there was another question that came. There were 2 questions in fact that came on hypersensitivity. Please confirm to me if these were the 2 questions. There was question 1, question 2. Question 1 was drug में many students are telling me penicillin was mentioned. So penicillin induced. Now many students have done this mistake, तो ध्यान से सुनना. You will say ma'am हम इतना excite हुए, drug सुना तो you had given us type 1 hypersensitivity के लिए you had given us a mnemonic ABCD. हमने ड्रग पढ़ा, हमने मार्क करा simple type 1 hypersensitivity reaction, but you also had to study next part na. Next part was what has happened because of the drug. Immune hemolytic anemia has happened because of the drug. Immune hemolytic anemia doesn't come under type 1 hypersensitivity. If you remember type 2 hypersensitivity, my blood group is Rh positive. My blood group is, remember this mnemonic we always used to study, my blood group is Rh positive. I was for immune hemolytic anemia. जिस भी reason से हुआ हो, ड्रग से हुआ हो, पॉइजन से हुआ हो, केमिकल से हुआ हो, whatever have may be the reason, if it is immune hemolytic anemia, then it has to come under type 2 hypersensitivity. So the answer for that was going to be type 2. Is that okay with everyone? So thoda sa many of you have made this silly mistake, just read drug and thought allergy hai to type 1 mark kara. ये नहीं करना. अच्छा, second one was lepramin test. Now just confirm for me, leprosy, many students told me ma'am leprosy का hypersensitivity was asked. Was it lepramin वाला skin test that was asked? Because if lepramin skin test was asked, then it is a type, जैसे Montus का skin test होता है, that is type 4 hypersensitivity. Leprosy का skin test है, that is type 4 hypersensitivity. Was that asked or was lepra reaction asked? Because दोनों में the answer is somewhere going to change. Lepra reaction था या lepramin था? Because if it is lepramin, I've told you your answer is gonna be skin test था. चलो, very good. हाँ, both are different questions only. Dr. Bhushan, I've mentioned ना, I've got them together because topic same है. But दोनों different questions थे. There was one question asking you about immune hemolytic anemia. Answer was 2. There was one question asking you about the lepramin वाला skin test. Very good. Skin, कोई भी skin test होगा. TB का skin test, if they ask you like the Montus test, or they ask you any other skin test on this planet, that is always gonna be granulomas, and skin tests hamesha type 4 hypersensitivity. So yes, this is something. Acha, they had mentioned 2 days also because it is read after 48 hours. Everything is going in phase. So this was one question. This was another question. Dono ke answers clear ho gaye. Everyone's got it right. I think I can move forward. Okay, again, this is a question where you have to help me because I don't know photo ya description kya tha. Whatever the description was, I will give you the answer as per that. So they said there is some traumatic, there's a farmer and there's a vegetative ulcer that has occurred in the eye. Okay. Dr. Abhi is saying that ma'am, this is a little maddening also. Pagal jaisa feel ho raha hai, hoga. Because you have abhi to there are two set of thoughts you will have. One set of thought is that, you know, this question was somewhat there, but I didn't get it right or I got it right. Wo wala ek thought hai. Some questions will be like, you will feel that, arey, was this even in the exam? That people are answering, you know, your friends are discussing and you have just zoned out. You got a blank mind. कुछ समझ ही नहीं आ रहा that was this even there? Was I in the same exam or have these people given a different exam and I went to a different exam only altogether? That thought will also come on a lot of questions and that happens to everyone. So my advice is that कल का दिन recalls देख लिया, आज भी recalls देख लो. After that, shut this recall story of your life and chill out for a while. You've already taken a lot of tension for the exam. Now don't sit down and take tension of recalls and recalls. Okay, एक बार देख लो, कहीं से भी एक बार recall देख लो. Very brutally, very honestly telling you, कहीं से भी हर subject का एक बार recall देख लो for your sanity, for your mental satisfaction. After that, shut this recall, shut off the notifications and relax for 1 week or 2 weeks till your exam results are out. Otherwise, you will possibly, if you've not gone mad till now, you will go mad by the end of 1 week. If you just keep on looking at what happened and, you know, if you stay in that zone, it is totally very, very bad for your mental health. Okay? Chalo, coming back, meanwhile, many of you have told me septate was mentioned. Okay, thank you for telling me that. Because if septate hyphae was mentioned, to ye to, come on, जैसे वो I am very possessive about that TME PSC वाला mnemonic, I am very, very possessive about this. ये पढ़ा था तो ये ठीक करके आना था, right? So please remember that if you get to see acute angle branching, if you get to see acute angle branching and septate hyphae, that is our mnemonic for aspergillus. So what is aspergillus? The way you write aspergillus, kitni baar we have studied this, है ना? ये तो please tell me a big yes that ये वाला तो ठीक करा था. A for acute angle branching and SPE for septate hyphae. This was, I don't know, picture था या नहीं था, but if it was written, it is very, very classical. So only, for example, Dr. Medical Life is saying, ma'am, only septate word was written. Branching कुछ नहीं लिखा था. ठीक है, चलेगा. Septate भी चलेगा. Septate है, that is also good enough. That is aspergillus because mucor is not going to be septate. Mucor is going to be aseptate. IBQ was not there. ठीक है, that is also okay. I don't need IBQ. अच्छा है, नहीं दिया था. Septate word was written. Septate मतलब aspergillus. Story खत्म. Question closed. No further confusion on this. Yes? Okay. Right. Now, Dr. Tausif, I'm wanting to tell this to you guys again and again. Stop comparing a lot of these things. पहले तो stop comparing your grand test marks with what happened yesterday. Different exams, different days, different questions, so different marks. As simple as that. Secondly, you can't even compare the level of the questions. The pattern jab change hota hai, or there's a shift in the subjects that is asked, then you can't go into that zone that this I was getting a 210 in my GT, तो अब मेरे को कैसे नहीं मिलेगा. You feel a lot of injustice has been done to you, but you can't work like that. This is a competitive exam. You will have to accept it in all spirit that that particular day they decided to change the pattern, and they can do that in the next exam and any exam after that also. You can't fight against that. You just need to mold and adapt to it, and you need to take it with that pinch of salt that ठीक है GT में 210 आया था, अभी अगर 180 भी आया, बस as long as 150 plus आ गया, I will have to be happy with that only. I don't have to just focus that what I was getting in my GT, I have to get the same mark. You can never put that kind of pressure on the examiner कि GT में तो इतना था तो अभी भी इतने marks देने पड़ेंगे. No, examiner is not at all bound to give you the same level of questions that you have studied for. Examiner is the king over here. You need to understand that upper hand हमेशा examiner का होता है. तो that day what the examiner wants to do, he wants to do, and no one can fight against it. The best is that you accept it, like I said, with a pinch of salt, and just pray that 150 plus होना चाहिए, because at this point of time that is all that you need. Anything above a 150 plus is going to get you the same certificate of a pass and a license, right? So right now this is what you're aiming for, and with this kind of a paper, honestly speaking, we should stop thinking about what is going to be my marks and my rank. No, with this kind of a paper, you have to pray to God with all humility and with best wishes for yourself that 150 pass kara dena. Bas, that is what you should be aiming for at this point of time. So stop praying that you should be getting the best of the score. Bas abhi kuch sab kuch itna unexpected hai that you should be praying that I should cross that 150 and this headache should be off my head once and for all, and then I'll see how to improve on my knowledge later on, right? Chalo. Let's move forward. There was a question which everyone was not happy about, because this is also a NEET PG PYQ, where they asked you regarding cholera toxin. अब हमने तो पढ़ा था cholera toxin causes rice water stools and all of that, and we were very, very confident. Even in your PYQ session, I told you cholera toxin increases cyclic AMP, and that is how it causes rice water stool. But they asked you something from NEET PG. NEET PG में बहुत famous question है. NEET PG वाले students तो will feel it is such a simple question, because NEET PG exam में इतनी बार आया है. And that is, where does it bind to? So all of you can see that cholera toxin is binding where? It is binding to the GM1 ganglioside, and that is the answer that you had to mark over here. So this is again something which, okay, there were other options like, I think GLUT was also one option, tyrosine kinase was also one option, but those are not the right answers. Right answers are GM1 ganglioside. Now again, as I said, that they took PYQs, but they got a little confused. PYQ FMG se nahi, unhone NEET PG se utha liya. That is why this question came, and that is why you must have been a little bothered about it, right? Let's move on to the next one. This very few, one or two students told me, and after that many students were like blank about it. Was this even a question, or was it just an imagination of a few students? Food poisoning पे एक question तो देखो हमेशा आता है. Either that question is associated with milk वाला products, or that question is associated with Chinese fried rice. So this they have given it many times earlier, है ना? तो milk वाले में we always used to mark Staphylococcus aureus. Chinese fried rice में we always used to mark Bacillus cereus, but this time they had asked for some oyster consumption. Basically they were asking about seafood consumption. Seafood wala consumption ke saath, what is it? Ocha, one more thing which I've got from Dr. Angita, she's saying that Kanagawa phenomena was also given. Okay, that makes my work a lot more easier. Kanagawa phenomena agar likha tha along with this seafood consumption, then of course we are going for nothing but Vibrio parahemolyticus, because Vibrio parahemolyticus is classically associated with seafood poisoning and Kanagawa phenomena. Again, this is something जो FMG PYQs में इतना commonly नहीं आया, but RR में पढ़ा था. You know, many students have written to me, ma'am, December exam के लिए now the pattern has changed. Should I start listening to? I have not listened to the full videos ever. अब last 4 months में पूरा videos दोबारा देखना है. I am still saying that your RR is your gold standard, but उस RR को तो बार बार पढ़ना पड़ेगा ना. Every time you read RR, it's going to be like a mystery box. Every time you read RR, you will see that something new is coming out of it because that RR is consolidated. उससे बार बार पढ़ोगे सारे questions solve होंगे. Even this is mentioned in the rapid revision that we have covered in the RR section. ये इतना डिटेल में भी दिया हुआ है, provided you read that with full dedication. Problem क्या है that from RR we ना for micro, especially with micro, we did not read this, Dr. Shivani, in your PYQs. I agree, because PYQs में कभी आया नहीं ना, that is why we did not study. But you open your RR section, I have taught you this, because over there I have made sure that 50 hours of micro is consolidated into 15 hours. But the problem is that with micro now we want chota, सबसे smallest possible. So earlier I used to teach micro for 20 hours, then I started teaching, students said मैम और छोटा crash course चाहिए 10 hours. Now they've come down to 2 hours कि मैम micro बस इतना पढ़ना है कि 2 hours में हो जाए, because micro is a dry subject and not everyone wants to study 10 to 15 hours for micro. But you saw this question was definitely something that required in-depth knowledge. वो in-depth knowledge के लिए for December students, I am still not saying कि बैठ के पूरा पढ़ो, पूरा 55 hours अब नया पढ़ना start कर दो, change your preparation. No, this is also there. This is also there in your rapid revision. So please उसे अच्छे से पढ़ो, उसे 2-3 बार minimum पढ़ो. That is when you will get a hang of all the things that you had. Dr. Neha, for seafood, crab होता तो अलग था ना. Paragonimus westermani first and foremost was not there over here, and secondly crab होता तो then this is something, then I would have thought of Paragonimus westermani, but not over here. Right? Okay. Yes, Dr. Mayur, and for the others, December exam students, RR को मतलब minimum 3 times video plus notes अच्छे से करना है. That is what will get you all these छोटा छोटा points also which many students miss. अगर सिर्फ PYQ करके जाओगे then it's not possible ना. PYQs you go to in the last 1 week. When do we do PYQs? बिल्कुल last के 1 day में 1 week में करना है. अभी से you don't say कि I will only study 2 hours of PYQs and then I expect कि मुझे सारे questions मिल जाएंगे. That is asking for too much from the examiner. That is not possible. Okay, so chalo, this is settled for everyone. I think we are done with the questions. I suppose, yes, I can see that it's over. Perfect. So yeah, we've settled the questions of path and micro, a total of 20. If I include selfish hoke thoda bahut medicine bhi, if we pull out into it, I can go up to 20 to 22, 23 questions that came, which is almost half of what we were expecting. हमने इतनी पढ़ाई करी थी पैथ माइक्रो की, we were expecting 40 questions तो हमारे बिल्कुल outright correct होने वाले हैं, वो उन्होंने half कर दिया. तो this time they have probably done a little bit of this thing. They've also saw कि ये लोग पैथ माइक्रो इतना YouTube sessions में इतना confidently answer करते हैं तो कम कर दो, right? Okay, someone's okay. Thank you, Dr. Disha, for answering, for letting me know. Vaginous, this no one told me. Vaginous granulomatosis पर there was an essay type question. So that is very simple. Vaginous granulomatosis में कहाँ कौन सा वाला ANCA होगा? World Cup WC. Vaginous granulomatosis में C ANCA positivity है. C ANCA primarily positive. Yes. So this is something that was there. Meanwhile, Dr. Rangita, thank you for letting me know, guys. These are questions which increases. मतलब then in that case we've increased above 20. This is not as little as we thought. Someone's also saying there was a question on Orientia, which again no one told me. A question on Streptococcus agalacti. Agalacti must have given you something like the CAMP test. CAMP test होगा या फिर some kind of meningitis probably must have been there. I'm assuming clinically meningitis होगा, CAMP test होगा. Right? Next, okay, Brunner's gland. This I thought, abhi I was seeing your anatomy session, I thought Brunner's gland ka histology you must have studied. That is why I did not include it. But yeah, that is settled. So a lot of other questions also came which I'm not getting to know. Iron deficiency anemia, everyone has told me, but kya question aaya? That is not there. What I usually expect is they will want to give you the serum iron and that profile because they want to know whether you can, diagnose this condition in our country. It's very, very common. But yeah, that is something that they would have given. So this is settled. Yes, let me know. I'm open to any other questions that are there. There was a question Dr. Niaz is saying of an HIV positive patient with diarrhea. And what is the stain that you will use? Usually HIV positive patient with diarrhea, we think of coccidian parasites, right? So Zn stain, yeah, acid fast stain is something that we would want to use, of course. Zn stain is something that would be there. Okay, rheumatic fever, Dr. Tausif, we've discussed, yes. Chalo, I think this is settled for all of us. Okay, 50-year-old with microcytic hypochromic anemia. Thank you for that recall. Yes, microcytic hypochromic can have that Sita mnemonic that was there, but in our country, obviously the primarily one that we will think of is going to be iron deficiency. Someone asked me that for HIV with diarrhea, why will we not go in first for past stain? We go in order of importance, right? HIV positive with diarrhea, the first family, I'm not saying it cannot be passed, but they are asking you, okay, sabse pehle kya karoge? What is the first thought that you should have in your mind? So the first thing I will have is Zn stain because coccidian parasites are going to definitely be there. Okay, pheochromocytoma पे question था, that is going to be discussed Dr. Abhi under medicine. Medicine में I've seen Deepak sir is going to discuss that with all of you. So yes, that is also, like I said na, कि अभी I've taken, because you have medicine recall today only, so I've taken the 2023 questions that came of path and micro. अगर selfish होके if I want, I can include medicine surgery also in it, and then I can proudly say that 30 questions came, but I don't want to do that for repetition for all of you. ठीक है? Yeah, one more question which students are telling me, Down syndrome. This is something which I did not know, that Down syndrome image was given of probably the hand. And of course, if they asked you trisomy 21, I mean, that can be the simplest question that they have possibly asked you over here. Okay. Akshay, Dr. Akshay, yes, paper kharab tha. I know we have this, go back to the first slide and we have discussed it. Paper was very bad in a lot of ways. I did not call it a recall of path and micro. I called it a recall of trauma, honestly speaking. But we need to move forward. We need to deal with it. We need to understand that what next can be done. Right? Okay, rickettsia question, Dr. Disha, I look into it. I've not seen what, probably the Insta DMs are also flooded at this point of time. So I'm gradually, whatever I could gather up till now by reading it individually, I've got it. But of course, any more questions that you recall, this comment section of this video will be open. Please usme add kar do, so that what I can do, I can prepare a final PDF for all of you. And this of course will be helpful for the December exam students. I can prepare a PDF. I'll wait for another 2-3 days so that more recalls come, proper questions pata lag jaye, framing, answers, and the length and the language I can get. And I'll make a PDF and then I'll circulate it to all of you. Meanwhile, any new questions that you want to add on to it, please in the comments or on Telegram group, you can please let us know. Obviously, as a goodwill gesture for your juniors that you're doing for the December exam students, right? Okay, Dr. Angita, okay, you've said OX19 and OX2 negative patient. Okay, so OX19, so this means something to do with the OX19 wheel Felix test. Na? So rickettsia family was basically asked over here. So I think as I've spoken to you guys, I can certainly say that there were not just 20-22 questions, there were approximately 30 questions that were there, but a lot are yet to be discovered. So many of you are saying that there was scrub typhus. Yes, Orientia and scrub typhus has been mentioned earlier also. Yes. So ठीक है, give me some more time. I believe that I still need to talk to a lot of you. At least 10 more questions I can somehow say that I can gather from you guys, but I'll need another day for doing that to be able to extract all the information, and I'll definitely get back with the next set of 10 questions also that we have, right? Okay, so I think we are now ready for also the next faculty to take over, that is
So hello friends. Hello friends. So we are starting a very important session for yesterday's exam. Okay, forensic medicine. Hello everyone. Hello everyone. Chalo, tell me one thing. Tell me one thing. How many questions? Hello. Good afternoon. Audio is not good. Audio is not there? मस्त क्वेश्चन थे. Audio is okay? Okay. चलो ये बताओ मेरे को, how many questions were from forensic medicine? Anyone? How many questions were from forensic medicine? All good. कितना क्वेश्चन था? डबल आवाज आ रही है? इको. अब now it's okay? इको. सब कह रहे हैं 5, 6, 8, 9, 10, है ना? डॉक्टर साहब, there were almost 16 to 17 question of forensic medicine. Resound आ रहा है? अभी भी इको आ रहा है? Voice is okay? Now it's okay. चलो. Again I am telling you that audio problem. There were 16 to 17 MCQ from forensic medicine. Okay? चलो start करते हैं. We are starting. Now antidote for benzodiazepine, and every question was from PrepLadder notes. Every question was PrepLadder notes. The first question is very simple. The antidote for benzodiazepine toxicity. Anyone? Yes, tell me. Antidote for benzodiazepine toxicity. Yes, it was a very clear-cut question. It was very simple question. It is flumazenil. और मैंने एक antidote का एक different आपको पूरा paper दिया था. In notes, I have made a different paper for antidote. The answer is flumazenil. The answer is flumazenil. Yes, dear. Second question. Simple. Number of permanent and temporary teeth in the 10-year-old child. Anyone? Friends, just remember, between 6 to 11 years of age, screen only half visible. Wait. Wait. Okay. So now it's okay, I think. Now, the number of permanent and temporary teeth in the 10-year-old child. In the 10-year-old child. Now, anyone, what is the answer? Give me the answer. Friends, the age for 6 to 11 years of age. So, 6 to 11 years of age, the number of total teeth are 24. So, doctor, first thing is there, it should be 24. It should be 24. Okay. Now most of the students are telling it's a 16 and 8. It's a wrong answer. Right answer is 20 permanent plus 4 temporary. 20 permanent and 4 temporary. Okay. And I told you like what happens. Yes. 16 and 8 and 8 and 16 both were there, no problem. But the answer is 20 and 4. Answer is 20 and 4. If 20 and 4 was not in option, if 20 and 4 is not in option, then you can pick 16 and 8. But sir, the best answer is this if this is given in option. Otherwise, the second best answer will be 16 and 8. Okay, dear? If 20 and 4 is not there, the best answer will be 16 and 8. Okay, the second best answer. Is it clear? Okay, if this is not in option. Is it clear? Okay, next. The medical termination of pregnancy can be done till 24 weeks. Now, the third question. देखो मैं आपको question count भी कर रहा हूँ कितने question आए थे. Now, anyone, what's your answer? Fetus malformation, we can go it after 24 week also. Okay. Now, what's your answer? Tell me. Rape, contraception failure. Contraception failure can be done up to 20 weeks. Okay. Yes. Now, the best answer is rape. Yes. For any incest case, any rape case, any vulnerable female, we can go for MTP up to 24 weeks. Fetus malformation can be done even after 24 weeks by the medical board. As I told you in the notes, very simple question was there. Minor likha tha, but minor is not the best option. Here the best option is rape. The reason is, who is minor? Minor kisko bolte hain? Minor is a child below 18 years of age. Here the consent will be given by parents. Here the consent will be given by parents. So it is not the best answer. The best answer is rape case. Okay. Third question is very simple. A 21-week married pregnant female was diagnosed with fetal malformation. Doctor sahab, yahan pe dhyan dena. What was this? It was 21 week. है ना? So it is a case of 20 to 24 week of MTP. Okay. Now whose consent is needed and how many doctor opinion is needed? Now here we all know the mother consent is needed and opinion of 2 doctors. If the pregnancy is below 20 week or up to 20 week, we require 1 doctor. Very, very simple question. Yes. FMG के लिए कैसे पढ़ना FMT में बताऊंगा, don't worry. But this is a very, I am telling you, like most of the student who just send me the like these questions, almost out of 17 and remember one thing, my dear friend, FMT is not a minor subject. Now it has become a major subject. Yes. Thank you. It has become a major subject. Patient died and relatives said he had tattoo mark. Very important MCQ. Doctor sir, there were many questions. These were NEET PYQ. And one of the questions which was NEET PYQ was this one. But autopsy, we were not able to detect in any tattoo. There was no tattoo. Which is the best location to check if he had tattoo? Yes, my dear friend. It is lymph node. It is lymph node. Few people are saying one option was vein, spleen, artery, liver, lymph node. The best answer is yes, even if the skin is given, the best answer is lymph node. And even this question comes in exam. 8 to 20 was there, but 8 to 20 is not an answer. Okay, don't worry. So lymph node, because we go for the biopsy till the lymph node level. So here answer is lymph node. मैं फिर कहता हूँ, forensic is 100% scoring subject. जिसने forensic में गलत किया ना, 16-17 question, even if you don't get in the major subject, ध्यान से देखो आप. This is a question number 5. Even if the skin is given, if the lymph node is given, the best answer will be. चलो मैं यहाँ पे skin लिख देता हूँ. Okay, this is okay. Spleen is not given, skin is given, doesn't matter. It's a lymph node biopsy is there. Regional lymph node biopsy. A gunshot was brought for the autopsy. The doctor noted firearm injury and the wound was stellate shape. Very simple question, sir. कितनी बार पढ़ाया मैंने? If it is a firearm injury, बोलो, stellate shape, busted wound. What will be your answer? Tell me, dear. Stellate shape, close shot, contact shot, near shot, distant shot. What is your answer? Yes, very simple question. It is contact shot, dear, not close shot. In close shot, it will be circular. In close shot, it will be circular. In near shot, it will be circular. And even in distant shot, it will be circular. The answer will be contact shot. कितना question हो गया दोस्तों? बताओ कितना number question हो गया? How many question done? बोलो कितना हो गया? 6 है ना? Number 6 done. चलो अभी देखो मजा आता है आगे. A police recovers a beheaded skull bone and relative of the missing person give the photograph. That's a very simple history. A photograph and the skull. It means here we are superimposing the skull bone in photograph for identification. Now anyone who can tell me the answer. Two sample can be analyzed by which technique? Fingerprint, DNA fingerprint, superimposition and chiloscopy. Yes, very simple question. As for superimposition, I told you very simple trick. We superimpose skull and photograph. Doesn't matter. Stellate is given, the tattooing and everything that was given, that is okay. The answer is superimposition. Yes, that was previous session was very helpful for you. Okay, done. A doctor was summoned. Kitna simple question tha. A doctor was summoned as a public witness to come and record his evidence. What is correct about this witness? Anyone? Doctor is an example because doctor makes medico-legal document. Doctor makes medico-legal document. Yes, very simple. Anyone who can tell me which is the answer? Oral evidence, common witness, expert witness. Very simple question. It was expert witness. Now, you were telling like almost 8 questions were there. 8 are already been done. 8 are already been done. अच्छा, आदिल बोल रहा है एडिनो कार्सिनोमा बोल रहा है कि लास्ट वीडियो बहुत हेल्पफुल था. दैट्स गुड. हाँ चलो, very important. Sir, identify the plant. Actually, in this question, there was given bell-shaped yellow flower, I think. And the person was consuming that flower seed. Bell-shaped flower, and that person was consuming that seed of the bell-shaped flower. Anyone who can tell me? This is yellow oleander. This is yellow oleander. Now, anyone? What is the botanical name of yellow oleander? I told you. Anyone? हाँ, ऐसा question ही नहीं था, मेरे को मालूम है. But the question was that a person is consuming the seeds of a yellow flower plant, bell-shaped plant. But sir, हाँ, photo was not there. Yes, I know the photo was not there. मेरे को भी मालूम है photo नहीं था बेटा. Datura was not given in option. That doesn't matter. The question is the yellow flower. The question is a yellow flower. हाँ, इमेज नहीं था. मेरे को मालूम, I know. मेरे को मालूम इमेज नहीं था. ये तो इमेज मैंने आपको समझाने के लिए किया. Anyone, tell me, what is the name of this yellow flower-shaped plant? It's a Cerebra thievaceae. It's a yellow oleander. What is Ricinus communis? It's a arundi. What is Datura? Everyone knows it's a thorn apple. Thorn apple. And Papaver somniferum is opium. Chalo, doesn't matter option the ya nahi the. Here the best answer is Cerebra thievaceae. Nerium odorum. If you get a question that Nerium odorum was one option, Nerium odorum is a pink oleander or white oleander. Nerium odorum is a pink oleander or white oleander. Nerium odorum was a pink oleander or white oleander. है ना, तो इसलिए don't get a confusion here. नीर क्या होता है? नीर पानी होता है white. हाँ, मैंने येलो देख के थीवेशिया मार दिया. बहुत बढ़िया काम किया तूने. Kill. That is Cerebra thievaceae. The question no हो गए. History of fall with hammer falling on the skull without helmet causes. Actually, the long question was given. Now, this is skull bone and a hammer. Anyone? I already told you hammer causes which fracture. Anyone? Tell me dear. Yellow mention tha. Adenocarcinoma is telling. It's very simple question. It is a depressed fracture. Yes. Gutter fracture is caused by bullet. Gutter fracture is caused by bullet. इसमें IBQ was given. The picture was given. The picture was given, X-ray was given, and there was a depression. Yes, image was given. But the hammer, देखो डॉक्टर साहब, मैं कई बार बोलता हूँ, I used to tell you कि कई बार पिक्चर नहीं देखनी होती. Hammer, history of fall is given, it's a depressed fracture. जिसने भी आपका फ्लैशबैक वीडियो देखा है सर, उसके सब सही होंगे. बिल्कुल सही बोल रहा है. Yes, बिल्कुल. देखो 10 क्वेश्चन हो गए हमारे. The RTA with EDH and hitting on the pterion. And डॉक्टर साहब, now there are 2 questions. The people are saying whether hitting on the pterion causes EDH. So people are saying there is one group is saying the pterion was in option after EDH. The one group of people are saying the pterion was option after EDH, and other people are saying the hitting on the pterion will lead rupture of which artery? That is middle meningeal artery. Yes, pterion was asked. So if the pterion was asked because EDH extradural hematoma, there is a temporoparietal reason. This one. Yes. Yes, pterion plus middle meningeal artery, that was given in option. That's a very simple question. It is a ADH by middle meningeal artery. Yes, pterion was the answer. If pterion is given, pterion was the answer. बोलो, कितने सवाल हो गए दोस्तों? बोलो, कितने सवाल हो गए? How many questions we have done? बोलो. I discussed this in FMT, the Tyrion, EDH, everything I discussed in FMT lecture, you can see. Okay, very, very important. Chalo. ये question थोड़ा tricky था. This question was little bit tricky. A drowning victim dead was brought for the autopsy, and on examination, multiple cuts are seen on the forearm flexor surface. Forearm flexor surface means this surface. Yes. हैंडसम डॉक्टर कह रहा आउट ऑफ 11 आई गॉट 7 राइट ओनली. कोई बात नहीं हैंडसम, अभी बहुत मौका मिलेगा तेरे को. अभी तो 11 हुए ना, अभी तो अपनी 17 तक जाना. शुभम कह रहा मेरा एक भी गलत नहीं हुआ एफएमटी का. हाँ, ये इमेज नहीं था. एक्चुअली द इमेज वाज, एक्चुअली वी कैन नॉट रिकलेक्ट दैट इमेज ना. नाउ टेल मी, आई एम आस्किंग वन क्वेश्चन. द इंजरी वाज सुपरफिशियल और डीप? फर्स्ट क्वेश्चन, इंजरी वाज सुपरफिशियल और डीप? ओके, ये कह रहे हैं द वुंड था वो भी कॉन्वेक्स टाइप. चलो ठीक है, वुंड था दैट वाज कॉन्वेक्स टाइप. ठीक है. हाँ, द इमेज, द कट वाज बिगर. If the cut was bigger and it was deep, I am giving you both explanation. If the cut was bigger and the wound was deep, then it would be defense wound. Because अब जब आप defense करते हो ना, there will be bigger cut. Okay? Then, if it is a superficial wound and multiple wound, then it will be self-inflicted wound. But if the deeper wound is given in option, the answer will be defense wound. If the deeper wound will be given in option, the answer will be defense wound. And if the superficial wound are there, only superficial wound are there, these are hesitational cut, these are probably self-inflicted wound. Okay? So ये तो multiple wounds were there. Yes. So here, if this is a deep cut, it's a defense wound. Otherwise, it would be a self-inflicted injury. That's a suicidal cut. Drowning was given. Drowning, तो आपको just to confuse you, drowning was given. Okay. Multiple lacerated deep wound was given. Then it's a defense wound. It's a defense wound. He is saying multiple lacerated wound are given. Then it's a defense wound. चलो ठीक है, done. आ जाओ next पे. A person purchased bottle of liquor. देसी दारू या शराब पी ली उसने. And consumed. After 1 hour, there was a pain in abdomen, vision loss, and gas disturbance. पहले तो बताओ which poisoning is this? Which poisoning is this? Tell me, dear. Tell me. Very simple. Which poisoning is this? The answer is ethyl alcohol. I know. Which poisoning is this? This is methanol poisoning. This was methanol poisoning. Yes, methyl alcohol. And Doctor, what is the antidote of methyl alcohol? Ethyl alcohol. Doctor, there was no fomepizole in the option. That's why the better answer is ethyl alcohol. Okay. And diazepam is not an antidote for that. The treatment of methanol, the best antidote is, Doctor, anyone who can tell me, methanol causes which tragedy? The methanol causes which tragedy? It causes which tragedy? Yes, the answer is ethanol. Flumazenil is for benzodiazepine, atropine is for organophosphorus. Naloxone किसका antidote? It is for opioid. तो 13 क्वेश्चन हो गए. हाउ मेनी क्वेश्चन डन? बोलो कितना क्वेश्चन हो गया? 13 क्वेश्चंस डन है ना. 100% स्कोरिंग सब्जेक्ट इज फोरेंसिक मेडिसिन. 100% स्कोरिंग सब्जेक्ट. कितना क्वेश्चन हो गया? 13. अभी 13 में से 13 कितने के राइट हो गए? कितनों के राइट हो गए 13 में से 13? सर मारा एफएमटी कोई मेजर से सब्जेक्ट से कम का है नहीं ना. चलो, naloxone is for this. In the exception of डॉक्टर ये क्वेश्चन आपको कंफ्यूज कर रहा था. In the exception of decreasing postmortem temperature is known as algar mortis. Okay, but sir, there is a postmortem caloricity graph for next 24 hours was asked. Anyone who can tell me what is the relation between temperature and time since death? Anyone? Which kind of curve we have? Anyone? It is which kind of curve we have? It is, what's the name of this curve? Anyone? What's the name of this curve? Anyone? It is a sigmoid curve. Okay. Doctor, sigmoid curve is also known as inverted S-shaped curve. Here S is not sigmoid, inverted S shape. You can see this is sigmoid curve. It is an inverted S shape curve. अभी रुको बेटा, अभी रुको. Now they are asking postmortem caloricity. ध्यान से सुनना. They are asking picture line सा था ऊपर से किया हुआ था. Okay. They are asking the postmortem caloricity, the graph. Now doctor, see, postmortem caloricity is a temperature which is high for 1 to 2 hours. Which is high for 1 to 2 hours. But sir, after 1 to 2 hours, here the question is asked about 24 hours. I am telling you here temperature is high for 1 to 2 hours in postmortem caloricity. But sir, for 24 hours, the curve will be followed in the same manner, my dear friend. It will be followed in the same manner. It will be high for 1 to 2 hours. It was not the graph. I am telling you, the curve will be which curve in the postmortem caloricity? Yes. Image nahi tha. I'm telling you this was not an image. They were asking the postmortem caloricity for next 24 hour will be which curve? Because it is high only, temperature is high only for 1 to 2 hours. Sirf 1 se 2 घंटे के लिए बढ़ता है. Then it is same. So my dear friend, then it will be same. So the curve of this will also be, anyone, can anyone give me the answer? हाँ चलो, ये कह रहा है डिसलरेशन भी एक ऑप्शन में था. Deceleration graph was also an option. कोई बात नहीं. But sir, इसका आंसर क्या होगा? What is your answer? What is the answer? Tell me. Even after 1 to 2 hours, what will be the answer? Tell me. मोनिका बोल रही है sigmoid. चलो मोनिका की सुन लेते हैं. It was decreasing sigmoid. चलो कुछ बोल रहे decreasing. Anyone? कासिफ ने बोला reverse sigmoid, healthy. But sir, ये इस क्वेश्चन में आप चकमा खा गए. डॉक्टर साहब मैं फिर बोल रहा हूं. Here temperature is on postmortem caloricity, temperature is only high for 1 to 2 hours. आपने चकमा खा लिया. The answer here will be same. The answer here will be same. It is sigmoid curve. Because इसने question क्या पूछा? Next 24 hours. अगर इसने if the question is asked for the 1 to 2 hour ना, then it could be like different answer. It will be reverse sigmoid. But sir, this question is for next 24 hours. The answer will be yes. 100% the answer will be sigmoid. Yes, Janu. वाह, बहुत बहुत बधाई हो. From your last flashback, I attempted all. चलो बहुत बहुत बधाई हो. बहुत अच्छे. चलो. A 10-year-old, ये तो बहुत simple question है. There he consumed iron tablet and brought in the emergency with pain, abdomen, GI bleeding, with lethargy. Preferred treatment of choice. Preferred treatment of choice. Tell me dear. Iron tablet. बाल पेनिसिलामीन एक्टिवेटेड चारकोल डेस्फेरोक्सामीन. इसमें तो बता दो यार, इसमें क्या ही सोच रहे हो इतना. Yes, the answer is desferoxamine. Desferoxamine. How many question done? बोलो. How many question done? हाँ, oral iron consumption doesn't matter. It's a desferoxamine is answer. Sir, a patient with chronic alcohol history presented with Goa. बहुत easy. Goa. पढ़ाया था मैंने. It's a chronic alcohol intoxication. It's a Goa, global confusion, ophthalmoplegia and ataxia. Which vitamin deficiency? Tell me dear. It is vitamin A. That is B1. B1 deficiency. कितना अच्छा करके आए वो पेपर. अब कोई कहता है ये पेपर टफ था. फॉरेंसिक में अभी तक कितने सवाल सही हुए आपके? आउट ऑफ 16 हाउ मेनी आर करेक्ट? किस किस के बोलो. इलेवन 12. अरे आलम के 16 आउट ऑफ 16. अमेजिंग वर्ल्ड फुल. भाई साहब आपका सिलेक्शन ही फॉरेंसिक करवाएगा. 12 11 11 11 B1 12. फिर भी ठीक है यार. 75% करेक्ट इज ओके. आउट ऑफ 16 12 इज ओके. तो बहुत अच्छी बात है. चलो देख लेते एक आध और कोई बचा हो तो. Doctor साहब, this I told you in the main lecture of this. Can anyone tell me what was the language of this question? Actually, I told you the trick in the main class. In seventh month, which bone ossifies? The answer is tell us. Okay. So, Doctor Saab, this was a question. A dead bone fetus was given. And the talus was ossified. This question was given. And what is the age of the fetus? The answer is 7 months. Janu, yes or no? हाँ, 3 to 5 month ऑप्शन में हो. अगर 3 to 5 month में ऑप्शन में हो तो भी आंसर नहीं है. बिकॉज आई टोल्ड यू द ट्रिक. आप देख लेना जावेद सर की ट्रिक्स में. 7th टेलस 7th मंथ इट्स अ टेलस. यस. हाँ, मैं क्या कह रहा हूं? टेलस ओसिफाइज एंड फ्यूजेज एट व्हाट एज इन द डेड बोन फीटस? द आंसर इज 7th month. दे आस्क टेलस प्रेजेंट एट व्हाट एज. हाँ, तो दैट्स अ या. चलो ये लास्ट क्वेश्चन वैसे ही दिस इज लिटिल बिट ऑफ फोरेंसिक मेडिसिन, आइडेंटिफाई द इमेज, बट मैं इसको फोरेंसिक का नहीं मानता, बट दे हैव गिवन मी, सो आई एडेड दिस वन. एनीवन, व्हाट इज दिस? What is this? It's a trichobazor. It's a trichobazor. So anyways, my dear friend, how almost 17 to 18 question you got from forensic medicine. Almost 17 to 18 you got from forensic medicine. And I think almost more than out of you, like more than 90% scored more than 12, I think. है ना? आउट ऑफ 18 14 करेक्ट, सीएस 15 सही हो गए नेहा. तो दोस्तों एक बात बता दूं मैं आपको, दिस इज द मोस्ट इंपॉर्टेंट सब्जेक्ट इफ यू सी द स्कोरिंग. मेजर हो गया, मेजर का भी बाप है ये. इवन इफ इट इज द 9th ऑप्शन, द आंसर फॉर टेलस ओसिफिकेशन, द आंसर विल बी 7th month. ओके, अरे बोलो दोस्तों. तो अपने फोरेंसिक के लिए हिप हिप हुर्रे, हिप हिप हुर्रे. प्रेप लेडर के सारे स्टूडेंट को मैं बोलता हूं, अपने सारे फोरेंसिक के वीडियोस देखने हैं. प्लीज डू सब्सक्राइब द चैनल, और है ना कॉन्फिडेंट रहना है आपको. हर एग्जाम में आप पास हो जाओगे. फुल करेक्ट एफएमटी. बोलो दोस्तों. चलो दोस्तों, मजे आ गए. थैंक यू एवरीवन, थैंक यू एवरीवन. चलो मस्ती करो. 17-18 क्वेश्चन फोरेंसिक के सही होना, इट्स अचीवमेंट. ओके, और बहुत इजी क्लासेस से आपने ये अचीवमेंट किया. सर आपके पर्सनल क्लासेस लिए थे, आप किसी क्लासेस लिए, अपना बहुत इंपॉर्टेंट प्लेटफॉर्म है ये, इसको ज्वाइन करो, आपके सारे क्वेश्चन सही हो जाएंगे. जामट सर अमर रहिए. चलो बाय बाय, टेक केयर, अपना ध्यान रखना. सेशन तो आधा घंटा.
Hello students, good afternoon, and I am Dr. Khushbu Mahajan. I am your dermatology faculty, and today I'll be discussing the FMGE questions that you had in your exams. So before I begin, I would like to stress that this is just a recall session. We may not have the exact questions, and that is why we are talking to you, so that you can provide us the actual questions, the actual options, and we can discuss them. And then subsequently the final questions will be uploaded on the PrepLadder app. Now, another request that I always make to my students is don't mark yourself based on the answers I provide you here. Because see, these are recall questions. They may not be the exact questions, they may not be the exact images, and they may not be the exact options. So I am sure you did your exam well over there. So just relax and let's discuss it in fun. You're free to pour in your comments. You are free to tell me if the question was different, image was different, or the options were different, or if there was a question which I'm not discussing here. So I would want maximum participation from all of your sides. So this is one of the questions that I have received. There is an image given of a skin lesion, and probably you were asked that which carcinoma can be the responsible for this, or which carcinoma can be the possible diagnosis. So before I proceed with my answer here, I would wait for your inputs to tell me if this was the approximate question, the exact question, was this the image, or what was it? So So I see that SCC was given in the option. There was malignant melanoma on the option, and probably the lesion was on the chest. Is that what it was? Okay, so if the image was something similar to this, I would say that the most probable carcinoma would be a malignant melanoma in this case. Now, I will just explain you briefly. If they were asking about BCC, they will give you an image which would look like a rodent ulcer and ulcerated nodular lesions with thready margins with telangiectasias on the margins, and usually the site would be face and mostly along the medial canthus of the eye or lateral ala of the nose, somewhere there, which I do not see anything here. So I think BCC was clear. And yes, you all are right. So you are telling me that this plastic nevus was given, it was looking like a nevus. Right. So if there was something which was looking like a pigmented lesion on the photo, if there was something which was pigmented and you were asked that which carcinoma it can lead to or which can be the possible carcinoma, then the answer would be malignant melanoma. There is no doubt, because we know that malignant melanoma has precursors, and as precursors it has atypical nevi, dysplastic nevi, junctional nevi, or even congenital melanocytic nevi, but it would mostly be a pigmented lesion. If they wanted to know about SCC, they would give you a lesion which was a little ulcerated, can be a little scaly lesion, but it would not be pigmented. So if in the image, I'm so sorry, any pigmented lesion was given and you were asked, then malignant melanoma would have been the perfect answer. So you're telling me that there was pigment. There seemed to be keratin pearls in the skin. So was there a histopathology which was given? Where were the keratin pearls mentioned? Was it in the option? Was it in the question? Or was it in the image? So I am, okay, I'm getting different options here. So Dance, I'll come back to the leprosy question. Thank you for telling me that. And I don't have the leprosy question, but maybe I'll discuss that. So first we will talk about this question. So you told me that there was on the chest, which carcinoma was not asked at all, okay? Okay, so there was no carcinoma. So probably you had been given a nevi, a dysplastic nevi. So they may have given you a pigmented image and asked you what it was. Keratin pearls, if it was given, is usually seen in squamous cell carcinoma. And that is a histopathological finding, not a clinical finding. So if somewhere in the histopath keratin pearls was given and you were asked that what is it a feature of, then you can write squamous cell carcinoma. However, if there was a pigmented lesion given and you were asked what it was, then it can be a dysplastic nevi or malignant melanoma. Okay, so I think we have different opinions on this question. So I guess I am sure whatever was the option, you marked it right. I'll again emphasize, if there was something pigmented, dysplastic nevi or malignant melanoma. If keratin pearls were there, then SCC was the answer. Probably there were two questions and we're getting confused here. So if someone can tell me the exact question, I'll be really, really happy on that. Then moving on to the next question till then. So there was a patient who had probably come to the OPD with itchy lesions in the groin, and there is some history of prolonged use of steroids. So what is the diagnosis? Okay, thank you so much. So no histopath was given, only image was given, and you were asked nevus, BCC and SCC, so that clarifies. Then you would mark either A plus dysplastic nevi or malignant melanoma. So we'll move on to the next question here. So patient came to the OPD with itchy lesions in the groin and history of prolonged steroid use. So there may be circular lesion, there may be a non-itchy lesion. If circular lesion was there and if use of steroids was mentioned, and if the options were all about tinea, then I think there was no confusion there. You will have to mark tinea incognito. Incognito or is a tinea incognito is the hidden mode. So here, because of prolonged use of steroids, if you do a KOH, you do not see fungus. So that is why it's called as tinea incognito. Fungus is hidden here. So this is tinea incognito, history of prolonged use of steroids with some itchy lesions in the groin. Okay, not groin probably, but that's okay. So any circular lesion, itchy lesion, annular lesion with history of steroid use, then you would say that it is tinea incognito, right? So I hope there was no confusion in this question. It was mentioned that topical steroids were used, and when steroids were used, it becomes tinea incognito, which is a form of tinea, which happens because of injudicious use of over-the-counter steroid creams or oral steroids, right? So that's okay, even if not groins were not given. But I think we are on the same page with this question. Something similar was given. Were there different options which were there? Dental option for tenure was 16. Sorry. So lesion was not in the groin, I get that, but was it something similar to this? A fungal infection with steroid use was the option. Right. So I think we will move on to the next question then, because we do not have much options here. So let's see the next question. Identify the condition in the image. So what is the condition in the image? Again, I will first wait for your options. What were the options? Was it the similar kind of image versus the similar options, or was there any other information which was provided in the question? Okay, so okay, so just to make your task easier, I will explain this thing here. So I am sure all the confusion would have been, if it was something similar, all the confusion would have been whether it is condyloma acuminata or condyloma lata, right? All right, same options, perfect. So now, if the image was something like this, where you could see verrucous lesions, little skin colored, too hyperpigmented verrucous lesions, and if in the question there was nothing mentioned, then you would mark condyloma acuminata. However, if the lesions were something similar to this, where their lesions were more moist, flattened, and looked like there is some oozing from them, they appeared soft, any of these, if this was the image, then condyloma lata would be the answer. So I am not sure what image was given to you. So if the image was this, then you would mark condyloma acuminata, which is a type of genital warts. And genital warts will present with verrucous appearance, slightly hyperpigmented lesions. It will not appear moist. It will not appear flattened like condyloma lata. So this is how they both look. And that is what I wanted to clarify here. So, okay, so I'm glad if I'm sure that you guys are clear about acuminata and lata, just that I am not sure what image was provided to you. So if you're very sure that it was an image of condyloma acuminata, something like this, then you would mark condyloma acuminata. However, if the image was something like this, where the lesions appears flat, as if they have been macerated, if they were moist, see, and both of them can extend to the anal area. So even if there was extension to the anal area, as some of you mentioned, it can be lata or acuminata. Okay, so I think all of you are telling me that it was acuminata, and I am sure that you know it well. So we will keep it here. So probably an image like this was given, and also last 2 years, FMGE, they have been asking about Buschke-Lowenstein and condyloma acuminata. So I think it was condyloma acuminata only, because this is their favorite question. And I think we discussed that whenever we discuss our recall questions or previous year questions. So I would give it to you all. You all are saying it was condyloma acuminata by image, and I think we settle down there. Right. The next question which I received was this: poor wound healing after a minor surgery is due to a deficiency of what vitamin? I'm waiting for your options, and if there is anything else in the question that you can tell me. Poor wound healing after a minor surgery is due to deficiency of what? So if this was the exact question, so we know that for healing we require collagen, and which is an important vitamin which helps us to form collagen, to remodel it. It is vitamin C. So if this was the exact question, these were the exact options, then the answer would be vitamin C. But I would want you to tell me if we had something else. Okay, so vitamin C was not there. So students, I've got two questions. I've got two different questions. One was this and the other was this. So let me discuss both of them together to clarify. So the other question which I got was this, that which of the following deficiencies associated with dermatitis, diarrhea and alopecia? So if this was also provided with poor wound healing, then obviously zinc would be the answer. We all know that zinc deficiency leads to ectodermatitis enteropathica, which is associated with dermatitis, diarrhea, and alopecia. And zinc definitely has a role in wound healing also. So if this was the question and these were the options, then zinc would have been the answer. So tell me more about it. So question, zinc was there with poor wound healing, zinc, alopecia, the gum bleeding wala. Okay. Okay, so I think there was one question on gum bleeding then. So if there was something about gum bleeding, some of you are telling me that there was something about gum bleeding. So if there was something about gum bleeding, what was the exact question? There, obviously, vitamin C would have been the answer. And if this was the question where poor wound healing due to minor surgery is there, again, vitamin C would be the answer. But if in the question they had mentioned dermatitis, diarrhea, and alopecia, we all know that zinc deficiency leads to ectodermatitis enteropathica, which can be acquired, which can be genetic, and that is due to zinc deficiency. The question, so I think most of you are telling me the question was related to zinc deficiency. So niacin deficiency leads to pellagra, and that is another disease, right? So there is dermatitis, there is diarrhea, and there is dementia. So if dermatitis, diarrhea, and dementia was mentioned, then you would think of niacin. But if it was alopecia, then it is, if this all these three features were there, then you would call it as niacin deficiency. But if it was dermatitis, diarrhea, and alopecia, then zinc would have been the answer. It was mentioned like the answer is present in the pancreas to stabilize insulin. Niacin was not in the option. Okay, so I think there is a lot of confusion about dermatology questions and we are getting all kinds of responses. Zinc deficiency. So I guess most of you are telling me that there was something related to zinc deficiency, and you all know dermatitis, diarrhea, and alopecia leads to zinc deficiency, is due to zinc deficiency. So zinc should have been the answer here. And yes, this can also lead to poor wound healing. So if poor wound healing was given in association with this, then again you would mark zinc as the answer. You would not mark vitamin C, but only poor wound healing in minor surgery, vitamin C would have been the answer. Okay. Right. So I have got only these questions from these students, and I would want to know more. Were there more questions? So one of you mentioned that there was a question on leprosy. Can you tell me what was that exact question? Also, if there were any other questions which you think were there, I would want to know about them. So I think there was this question where you had to tell the difference. They had given leprosy symptoms and you had to diagnose whether it was type 1 or type 2 leprosy and the hypersensitivity reaction. So probably they had given you a question. There was a question of psoriatic arthritis. Dr. Harsh, can you please elaborate on the question on psoriatic arthritis? So one question was probably on leprosy, where you had to differentiate between type 1 and type 2 reaction. So I'll quickly walk you through that so that you can tell me what were the options and what were it. So type 1 reaction is basically a type 4 hypersensitivity reaction, whereas type 2 is type 3 hypersensitivity reaction. If they asked you this, type 1 reaction also called as reversal reaction, and type 2 reaction is also called ENL. Type 1 is seen in upper spectrum and type 2 is seen in lower spectrum. Okay. Psoriasis was also been, and psoriatic arthritis, loss of temperature, pain. Uh, psoriatic arthritis question. You're all telling me that there was a question on psoriatic arthritis. Leprosy patient on penicillin developed allergic reaction. What is the type of hypersensitivity? Was this the question? Okay. So I would, so there were two leprosy questions probably. So if they had asked you between type 1 and type 2, so they would have given you either of these and the clinical features. So in type 1, the existing lesions, they become more red, they become edematous, they become painful, and there may be nerve tenderness or abscess. Whereas if they were talking about type 2 reaction, they would say new crops of lesions with fever, new crops of lesions with fever. So any of this may have been given. Now there was a question probably on psoriatic arthritis where you were given pencil and cup deformity, and where do you see this? So we know that pencil and cup deformity is seen in, so psoriatic arthritis is very commonly associated with psoriasis. So probably you were given an image of the back where you could see scaly erythematous lesions, and along with that penicillin cup deformity was given, and probably the answers were, was it pseudogout, psoriatic arthritis, or what? So if there were scaly lesions on the back with penicillin cup deformity, you can mark psoriatic arthritis. We know that psoriatic arthritis is a seronegative arthritis, and here you see various deformities because of osteochondritis, and penicillin cup deformity may be seen. Right. So then I think there was one is hypersensitivity and other is symptoms describing leprosy. So probably they asked you that there was loss of temperature, loss of pain and something, and they wanted to know what was the diagnosis, and there the leprosy was the answer. Was that the question? There was one photo of a boy which was appearing as acne, and in question it was written that brother also had the same condition. Did you confuse it with cutaneous angiofibromas that we see in tuberous sclerosis? Because tuberous sclerosis presents with cutaneous angiofibromas, they can look like acne and they can be present in siblings. So that's why the misnomer for cutaneous angiofibroma is adenoma sebaceum. So was that the question there? The answer would be tuberous sclerosis. Then there was something on Lepromin test. So Lepromin test, they might have asked you what is the type of hypersensitivity reaction. It is type 4 hypersensitivity reaction. Second, they can ask whether lepromin test is used to diagnose leprosy. No, it is not used to diagnose leprosy. It just tells me about the immune status of the patient. So that is why this test is almost obsolete now. So they can ask about the type of hypersensitivity reaction and whether it can be used as a diagnostic test. So no, lepromin test is not used as the diagnostic test, and it is a type 4 hypersensitivity reaction. There was one question probably on leonine facies. So you must have been given leonine facies and must have been told that there is loss of temperature, loss of pain, and the spectrum of leprosy may have been asked. So that would be LL Hansen or lepromatous leprosy. So if leonine facies was the image that was given for the leprosy, then probably they would have asked you what spectrum was it, and that would be LL Hansen. Okay. So varicella, so what was the exact question on varicella? Morbilliform. So what was there in the child? So leprosy face was given and you were asked how to diagnose. So the diagnosis of leprosy, you do not use lepromin test. For diagnosis of leprosy, you do a slit skin smear and you do a histopathology. These are the two tests that you use to diagnose leprosy. So if the question was on diagnosis of leprosy, then I'm sure they must have given either slit skin smear or Zeden staining and histopathology. How to diagnose in leonine facies madarosis was given in the other question. So yes, if how to diagnose in a leonine facies was given and you were asked how to diagnose, then obviously you will do Ziehl-Neelsen staining or slit skin smear, or you can do a biopsy. Any of these two options would have been there and you can mark that. So thank you for that question. I think that as facies must have been given with madarosis with lots of sensation, and you were asked that how do we diagnose it. Image of a boy with face lesion plus some other lesion which were visible on chest with history of same in the brother. Okay, and Monica, can you tell me what were the options which were there? So if there was a question on monkeypox, so yes, history of foreign trip, and they may have given you an EM-like lesions on the palms and soles, then probably monkeypox would have been the answer. Was it something like that? A male image came with chin was narrow and nodules, cheekbones were prominent, diagnosis may be asked. Okay. So probably you're talking about leonine facies, Ashley, and that would have that is what we have already discussed. If any of you remembers about morbilliform eruption or varicella that you guys are telling me, the question which was related to that, I would be willing to take that question because I think this leprosy question is more or less clear with us. Lepra-like face, acne, eruption. So morbilliform rash, varicella, acne were the options of an image. Okay, so you were probably given an image and you had to tell the diagnosis. Okay, so I think there was another question on monkeypox as I get it. So there was a foreign history of travel and there were rash which was given on hands and feet. So yes, that can be monkeypox, and we all have cases of monkeypox recently. So it is justifiable that they may be asking you this question. So image with hands and feet, vesicles and bullae or necrotic lesions with foreign trip travel. Yes, monkeypox would be the answer. Okay. A viral exanthem. I'm sure you're not, everybody has different opinions, but what I get it is that there was another question on viral what that viral exanthem was. So if the viral exanthem, if they had given a maculopapular rash, which was there on the trunk, and with that they may have given you associated fever, conjunctivitis, pneumonitis, then if the rash had vesicles, necrotic lesions, dewdrop and rose petal appearance, along with again fever and other symptoms, then varicella would become the answer. So measles and varicella, if they want to ask you to differentiate, measles would be maculopapular erythematous rash, and varicella would be ask you, they have probably given you an image of a viral exanthem and they wanted to know what was it exactly, right? So that's okay. Even if the image was not given features, I'm sure you would have answered that correctly. So one question was 3-year-old boy with cough, fever, conjunctivitis. Rash is never itchy. In viral exanthemes, rash is usually not itchy. Chickenpox may be itchy, but viral exanthemes can be totally non-itchy. So that's completely okay. Boy had fever, cough, redness. So had they mentioned where was the vesiculopapular rash? Because foreign trip travel is not relevant for chickenpox. Foreign trip travel is related to question. So if there was a child getting fever and cough,
the stream is lagging a lot. I do not take much time. It's like really lagging. And the keywords are cheating.
okay, fine. I'll do that. Okay. Okay, so I think we've discussed most of the questions. Thank you so much for all the inputs. And I'm sure you did your exam well, and you are all aware about the different options and the questions, which I believe is wonderful. And I'm sure you marked all your questions correctly. So all the best for your results. I'll wind up here. If there are more questions, put it in the in our group, right? And I'll be willing to take it there. So thank you. I'll wrap it up here, and thank you so much.
Good evening, everyone. If I'm audible and visible, please send your thumbs up in the chat box. Good evening, Rishu, Sampada, Mane, Abhijit, Manoj. Okay, guys, so let's start. Straightforward, we are going to start the questions. So first one is easy and repeat question. A patient came to OPD with history of burn wound. There is history of burn wound in the lower limb. His wound is given in the picture. Tell me what is the probable diagnosis. It is easiest question. Abhishek, Abhijit, tell me. Easiest question. So CS1429, you are absolutely correct. This is Marjolin's ulcer. All of you know that this Marjolin's ulcer, it's a low-grade squamous cell carcinoma. What is this? This is low-grade squamous cell carcinoma, and it is going to arise from scar. It is arising from scar. And you know that in scar, there is damaged arteries, veins are destroyed, lymphatics are destroyed, nerves are destroyed. So no vessels, there are no vessels. You know that there are no vessels. Clear? There are no nerves, there are no lymphatics. No nerves, no lymphatics. Clear, guys? That's why, simple question, Marjolin's ulcer, it is painful or painless? Easy question. Mithu Kumar, tell me. Marjolin's ulcer, it is painful or painless? Easy question. Yes. So obviously, okay, similar image was there. So Marjolin's ulcer, since nerves are destroyed, it is what? It is painless. Clear, guys? It is painless. Okay. Second, since no lymphatics are also destroyed, so there are no lymph node involvement, vessels are destroyed, that's why it is avascular tumor, relatively avascular, and this is slow growing. This is avascular and relatively slow growing. Clear, guys? So avascular, relatively slow growing. So what is the treatment here? First, how we make the diagnosis? Obviously, we make the diagnosis by biopsy. And what is the treatment? We go for wide local excision and we have to go for flap cover or flap closure. So correct answer is A, that is Marjolin's ulcer. Okay. Anybody wants to add something in the question? Okay. Meghrath Donald, he wants to say that, sir, ulcer was given in as elderly. Elderly had burn injury in elbow. So there was elderly patient, okay, elderly patient, and elderly patient was having burn injury in elbow. Elbow. Got treatment, but after years there was an ulcer in the burn place. Okay, so image was elbow and there was burn injury, doesn't matter. So here, what is the treatment? The treatment is, guys, here, the treatment is wide local excision, and obviously what's the diagnosis? It is Marjolin's ulcer. Thank you, Meghrath, for exact language. Next question. Elderly patient with dysphagia, halitosis, regurgitation. So any elderly patient comes with dysphagia, halitosis, regurgitation. What you have to think about? You have to think about, yes, you have to think about Zenker's diverticulum. So in the option pulsion diverticulum was mentioned. Can anybody improve? Anybody wants to improve the language of this question? Guys, Meghrath, adenocarcinoma, Sampada Mane. Anybody wants to improve the language of this question? Regurgitation mainly occurs during night. Patient had fever and went on developing like lung abscess. Very good. So if there is regurgitation, it was occurring during night. Clear, guys? Patient was having fever also. And what is the most common complication of Zenker's diverticulum? You know, most common complication of Zenker's diverticulum, that is lung abscess. That is lung abscess. Okay. So guys, can you tell me what were the other options? Adenocarcinoma, R, Meghrath. Yes. In bronchiectasis, regurgitation is not there. Meghrath, do you remember? Okay. Achalasia cardia was there. Carcinoma esophagus. There was achalasia cardia. Achalasia cardia. Similar feature can be there in achalasia cardia, but it is not seen in elderly. Carcinoma esophagus was there. What were the other options? Meghrath, Donald. What were the other options? Okay. Shubham Gupta wants to say that, sir, one option was GERD. Okay. One option was gastroesophageal reflux disease, right? And pulsion diverticulum was there. So correct answer is pulsion diverticulum. Guys, it's pulsion diverticulum. Obviously, that is what? Zenker's diverticulum, right? Next question, question number 3. The patient presents after Billroth 2 gastrectomy operation with dumping syndrome. What could be the initial management, right? Anybody wants to improve the language of this question? Meghrad Donald, okay. Malnutrition was also there. In dysphagia question, in diverticulum question, malnutrition was also there. There was malnutrition. Okay, okay, Meghrad. Now see this. Patient presents with Billroth 2 gastrectomy operation with dumping syndrome. What should be the initial management? Okay, second option was reverse Billroth 2 to Billroth 1. It was reverse Billroth 2 to Billroth 1. Okay. Anybody remembers the exact language of question and other options? Pathologist Sampada R. Insulin was also in the option. Okay. Insulin. Ru NY. Okay. Convert reverse Billroth 2 to Billroth 1 oblique Ru NY. Which one was there, guys? It was Ru NY or it was Billroth 1? Okay. And one option was, okay, elderly patient was there. There was elderly patient. And one option was symptomatic treatment. Symptomatic treatment. After 15 minutes of meal. Okay. So dumping syndrome means he was having early dumping. After 15 minutes of meals, he was having diarrhea. After 15 minutes of meals, patient was having diarrhea. Patient was having diarrhea. Okay. Okay, Dr. Meghrad Donald, very good. Very good, and thank you very much for the exact language of the question. Clear? In that case also, there was fever. Right. Now here, diarrhea after 20 minutes. Okay. After 20 minutes, there was diarrhea. After 20 minutes. Clear, guys? So this was a case of early dumping. Obviously, it's a case of dumping syndrome. So what's the management? Here, prevention is better than cure. So what? We have to go for dietary modification. So small frequent meals patient has to take, and patient has to decrease the carbohydrate intake. So patient has to decrease carbohydrate intake. Patient is should increase protein, and patient should increase the fat intake. Clear, guys? So correct answer for this question, in surgery is rarely required. So correct answer for this question, it is small frequent meals. Insulin, we should not give insulin because there is late dumping. Late dumping is because of excessive secretion of insulin, and that leads to reactive hypoglycemia. Clear? Reactive hypoglycemia. Monica wants to say, sir, PPI plus amoxicillin was one option. Raghuraj wants to say that insulin plus glucose was one option. Guys, can you tell me symptomatic treatment was there or not? PPI plus amoxicillin was there or not? Monica wants to say. CS1429, majority of patients who are having dumping syndrome, they improve after conservative management, after dietary modification. If patient is not improving after dietary modification, in that case we give octreotide, and you know that octreotide is universal switch off. Somatostatin is universal switch off, octreotide is better alternative, and majority of patients after either conservative management or octreotide intake, they improve. Surgery is rarely required, that's why. Okay. Okay, so PPI and amoxicillin was not there in option. Okay, guys, it was not there. Low fat diet. Okay, increased protein content. PPI was given in the one option. Symptomatic treatment was not there. Okay, guys, one of the option was low fat diet. No, we had to increase the fat content. It should be high protein, high fat, low carbohydrate. Okay. Okay, thank you, Abhishek. Thank you. So obviously the correct answer is small frequent meals increase the protein content. Okay, guys, it's famous repeat question. Identify the instrument given below. So this is Viris needle. This is the Viris needle, and you know it is used for creating pneumoperitoneum. Guys, this is Viris needle used for creating pneumoperitoneum. Simple. Okay, guys. Adenocarcinoma, everybody, Mithu Kumar, Dhruv Panchal, Abhishek Mishra, all of you are correct, guys, all of you are correct. Can anybody want to modify the language of this question? Guys, anyone wants to modify the language or modify the options? CO2 gas was asked. Dr. Adenocarcinoma, CO2 gas was asked. Yes, it is Viris needle. Rangita Sharma wants to say that her other options were optic, spinal needle, Duran needle. I think that was a separate question of ortho. Okay, Abhishek Mishra, can you tell me what was the question related to CO2? Related to carbon dioxide, what was the question? Can you tell me? Veena. Okay, yes, very good. Raghuraj Singh, in abdominal laparoscopy, which gas is used? Very good. In abdominal laparoscopy, which gas is used? So guys, you know which gas is used. So we use carbon dioxide. Clear? Can you tell me, Abhishek, what were the options? Can you tell me the options? Carbon dioxide. Rangita Sharma wants to say that, sir, gas used to create pneumoperitoneum. So in abdominal laparoscopy, which gas is used? Oblique, gas used in creating pneumoperitoneum. Oxygen nitrous oxide. Okay, oxygen nitrous oxide. And what was the fourth option, guys? Carbon dioxide. Okay, nitrogen also. So carbon dioxide, oxygen, nitrous oxide, nitrogen. Okay, Dhruv Panchal wants to say that which is used to inflate the abdomen for laparoscopy. Very good, Dhruv. This was the exact language. So it was CO2, oxygen, nitric oxide, and one option was helium. Okay, so correct answer is okay. One option was helium. So correct answer for this question, obviously, it is carbon dioxide. You know, guys, for creating pneumoperitoneum, we use carbon dioxide. Needle used is Viris needle. Very good. Anup, I'm very fine. How are you? Meghrat, very good. Meghrat, you are correct. Abhishek, you are also correct. Okay, guys, all of you are correct. Majority of you marked what? CO2, that's correct. Now, guys, question number 5. Identify the condition given in the image. So in the image, you can see patient is having what? Filariasis. Yes, helium was also there. Vishnu Gujarati, yes, helium was there. Now, guys, patient is having filariasis. Clear? So anybody wants to improve the language of this question? Anybody? Anybody wants to improve the language of this question? Shivani, Monica, Amit Kumar, all of you are correct. Answer is correct, guys. Anybody wants to improve the language of this question? Same. Jay Vyas. Okay. Dhruv Panchal wants to say that, sir, options were different. So can you tell me what were the options, guys? One was lymphatic filariasis. Okay. Filariasis, DVT, edema. Okay. It was filariasis, DVT, It was edema. Options were arterial, venous, lymphatic. Okay. So options were lymphatic, arterial, venous. Filariasis is due to arterial, lymphatic or venous. Okay. Arterial. What was the fourth option? Venous or lymphatic? So guys, obviously it is because of involvement of what? Lymphatic system. So this is lymphatic filariasis. This is lymphatic filariasis. Okay. Now guys, there was one question. Let me tell you, this question is asked in each and every paper. What? A case of pneumoperitoneum or perforation peritonitis in which you can see free gas under right dome of diaphragm. Here you can see there is free gas under right dome of diaphragm. So X-ray of patient with chronic acetaminophen use. Can anyone of you wants to improve the language of this question? Guys, can you tell me what was the exact language? Yes, Dhruv Panchal, Joel Rajan. Okay, so there was no question related to this X-ray perforation. Monica, Meghrat, this question was not there. Okay, so this was not there. Right, so let's proceed to next question. What will be the most probable tumor classification in patient with inflammatory breast cancer currently showing pudgy orange and 2/3 involvement? 2/3 of breast skin involvement. Pudgy orange with 2/3 of breast skin involvement. Okay guys, breast skin involvement. Clear? So can anybody tell me what was the exact language? Somebody wants to improve the language of this question? Same question? Very good. So guys, whenever there is inflammatory breast cancer, any patient who is having inflammatory breast cancer, that is T4D. And if only pudgy orange is there, that is T4B. T4B, that is pudgy orange. What is T4A? Whenever there is extension of chest wall. T4B, whenever there is ulceration, edema, satellite nodules or pudgy orange confined to same breast. What is T4C? Both T4A plus T4B, and you know T4D, it is inflammatory breast cancer. Okay guys, it was 1/3. Very good. So that is more than 1/3. That is the definition of inflammatory breast cancer. Okay guys, so correct answer for this question, it is T4. T4. Okay, somebody wants to say that, sir, inflammatory breast cancer was not mentioned. Only pudgy orange, more than 1/3 involvement. Clear? So whenever the inflammatory changes are involving more than 1/3 of breast skin, it is obviously inflammatory breast cancer. Doesn't matter guys, the answer is same, T4, T4. And if inflammatory breast cancer is given, it is T4D. Okay? Only pudgy orange, so it is T4, and in T4 it is T4B. Okay, Sunil wants to say that sir question same tha but recall करने में difficulty है. Doesn't matter guys. Okay, T4A, T4B options were T4A, T4B, T4C, T4D. Clear guys? So whenever, if only pudgy orange is there involving more than 1/3 of breast skin, this feature is not diagnostic of what? Inflammatory breast cancer. So in that case, what will you mark? If this kind of question is there where inflammatory breast cancer is not mentioned, in that case you are supposed to mark what? T4B. So correct answer is guys, it is T4B. And let me tell you, this question is asked almost each and every year in each and every paper. Pudgy orange. Sometimes they ask you what is the cause. It is because of lymphatic permeation of tumor cells. So lymphatic obstruction caused by tumor cells leading to cutaneous edema. Okay guys? Right. Now see the next question. Delayed wound healing after minor surgery is due to deficiency of. This question was there or not? Meghrath, adenocarcinoma, Lakshita, Sampada, Mane. Yes, delayed wound healing. This question was there or not? Because I have heard that some patient who is having alopecia, patient was having rashes. Mithu Kumar, this question was there? इतना easy नहीं था? Okay, so there was one question in which there was alopecia, there was rashes in gluteal region. Okay guys, okay, right? So see, if this question is there, only this question is there, delayed wound healing after minor surgery, then the answer would be vitamin C. But if patient is having rashes also, alopecia also, in those cases the correct answer would be zinc. Zinc. Yes, diarrhea, dermatitis, wound healing. Okay. Joel Rajan wants to say that ICU patients sudden breathlessness image shown option are pneumothorax. Guys, can you tell me what was that question related to pneumothorax? Pneumothorax question. There was one question related to pneumothorax. Okay, yes, we have that question. So guys, if anybody remembers that pneumothorax question, please message. Image shows collapsed lungs. Okay. Pneumothorax image was there in which lung was collapsed. Okay, Ashley. Right. Left-sided pneumothorax was there. Okay. If anybody remembers the exact language, please message. Now let's discuss the next question. Identify the shown procedure. So guys, you can see what is this? This is portal triad, and you know that what are the components of portal triad? This is portal vein, this is bile duct, and this is hepatic artery. This one is hepatic artery. Clear? So what is the name of this triad? Yes, this is looking like Mickey Mouse on ultrasound. So this is known as Mickey Mouse view. It is looking like Mickey Mouse on ultrasound. So this is Mickey Mouse view. So this is portal vein, this is bile duct, this is hepatic artery. So obviously guys, what is the procedure? This procedure is Pringles maneuver. By this Pringles maneuver, we are going to control the bleeding. So you know that we are going to compress portal vein and hepatic artery. So bleeding is controlled from portal vein and hepatic artery. Bleeding is not controlled from IVC and hepatic vein. Okay, Meghrath, can you tell me what was the exact question? Raghuraj Singh wants to say that sir, मेरे को लगा कि ये question, ये image आपने send की होगी. True, the same image is there in the notes and we discussed this. Okay, Andrabi, very good Andrabi, exact language. Very good. Right. One question, yes, we have that question. So guys, here correct answer is Pringles maneuver. Okay, now see this question, easy question. Patient with road traffic accident with bradycardia along with high BP. GCS checked came to be less than 8. Now can you tell me what is the correct answer here? Let me see who's the genius over here. What is the correct answer? GCS is less than 8. In this case, what should be the treatment? I mean, what should be the next step? Very good guys. Joel, Andrabi, Raghuraj. Yes. Guys, if patient GCS is less than 8, what? It's an indication for intubation. Clear? Whenever patient is having noisy breathing, patient is having facial trauma, GCS less than 8, patient, yes, who is not able to speak. So whenever we are suspecting airway obstruction or whenever we are suspecting the mental depression because of head injury, GCS less than 8, it's an indication for intubation. So correct answer is B, intubate and ventilate. Okay, one option was give saline. Gave saline. Guys, okay, GCS was 6. GCS was 6. GCS was 6. Adenocarcinoma, see, adenocarcinoma wants to ask, sir, purdy orange more than 2/3. Only purdy orange involving more than 2/3 doesn't become inflammatory. Clear? What? Apart from that, there should be erythema. There should be induration. Only presence of purdy orange doesn't make any cancer inflammatory breast cancer. Inflammatory changes should be involving more than 1/3 of breast skin, which include erythema. Only one feature should not be there. Erythema should be there. Okay? Right. See guys, if there is redness, erythema, induration, usually there is brani induration, then the correct answer would be T4D. If these features are not there, then correct answer would be T4B. Okay? Now guys, next question. Question number 11. Which of the following is not a layer of esophagus? So guys, you know that which layer is absent in esophagus? Okay, Ashley. Intubate and positive pressure ventilation. Okay. Intubate and positive pressure ventilation. Very good. Very good. So for this question, everybody is correct because everybody knows the correct answer. You know guys, which layer is absent? Serosa is absent in esophagus. There is no serosa in esophagus. Can anybody tell me which layers are absent in gallbladder? Tell me in the comment box. Let me see who's going to reply first. Which layer is absent in gallbladder? In gallbladder. No, serosa is there. Whenever there is intraoperative blood loss, we have to give what? We have to give crystalloids, usually ringer lactate. In gallbladder, there is absence of muscularis mucosa and submucosa. So, muscularis mucosa and submucosa, these two layers are absent. Okay guys, very good. So, next question. Question number 12. Easy question, I think it was discussed everywhere. So, can anybody tell me what was the exact language of this question? It was just like that, identify the following, or there was some language. Dreamer wants to say that, sir, there was one question on gastric cancer staging. Guys, can you tell me what was that question on gastric cancer staging? There was one question on gastric cancer staging. Yes, Dreamer, tell me. Okay, only identify the picture. So you know, all of you know that this is trichobezoar. This is trichobezoar. Rapunzel syndrome, whenever the hair reaches up to the duodenum, okay. Guys, whenever there is intraoperative blood loss, yes, we can give saline because it's a crystalloid. So saline should be given. Identify the options for gangrene stomach, trichobezoar. Okay, it was gangrene of stomach. Okay guys, what was the question on gastric cancer staging? Anybody can tell me? Meghrat, you are sending almost question with complete language, complete options. Very, very good. That's really great. And thank you very much. Okay guys, there was one question. Abhi wants to say that bismuth classification. What was the question on bismuth classification, guys? Can you tell me? Bismuth, Meghrat, do you remember what was the question related to bismuth classification? Okay, Meghrat, yes. For gastric cancer histopathological staging, who will we consider? Invasion, lymph node. So for histopathological staging in carcinoma stomach, yes, Depth of invasion is considered. Guys, it is based on depth of invasion. It is based on depth of invasion. Thank you, Megrat. Thank you very much. After that, Rangita wants to say, staging of intestinal cancer include depth of invasion, lymph node metastasis, size of tumor. Let me tell you guys, very easy to understand. From esophagus till rectum, these are GI malignancies, and in GI malignancies, staging is based on depth of invasion. It's not the size, it's the depth of invasion. Okay? Right, guys. Guys, can you tell me, Meghrat, can you tell me what was the question related to Bismuth classification? There was one question related to Bismuth classification. Yes. What was the question related to Bismuth classification? Ashish, correct. Depth of invasion ही था. Yes, depth of invasion ही है, and that's the correct answer. Poonam, you remember what was the question related to Bismuth classification? Okay, guys. So if you remember, please send me the options and please send me the language of question. Okay. Now, simple question. Easy, you can see here. This is malignant melanoma. You know that malignant melanoma, it is characterized by A, B, C, D, E. Asymmetry, border irregularity, color variation, diameter more than 6 mm, and evolution in size, shape and color. Hey Amigo wants to ask that, sir, your rapid revision is sufficient for December FMGE. Guys, you can crack 80 to 85% of the questions, but it is strongly recommended that first go through the main videos, because if you watch the main videos, you are not only going to solve surgery questions, you can solve important questions of in which there is overlap, radiology also, pathology also, medicine also. It's like thyroid chapter is there, GIT is there, so it's better watch important topics from main video. Okay, guys, so this is malignant melanoma. Okay, alcoholic chronic smoker who was having history of endometrial carcinoma. That must be a gyne question. MLMT classification. Okay, guys. ABCD2, yes, it is related to transient ischemic attack. That is medicine question. Okay. Okay, guys. So if sister is having endometrial cancer, now see, guys, if a patient is having endometrial cancer, apart from that, there is presence of polyp also. Imagine patient is having adenomatous polyp also. What happens? There is a condition known as HNPCC, hereditary non-polyposis colorectal cancer. The extra intestinal manifestations are EGO. EGO means there is endometrial cancer, there is gastric cancer, and there is ovarian cancer. Endometrial cancer, gastric cancer, ovarian cancer. Clear? So here, if there is presence of either patient is having bleeding PR or patient is having polyp, clear? So in that case, we can go for, yes, we can go for colonoscopy, or we can go for double contrast barium enema. Preferred is colonoscopy. Okay, Bhavjit Walia wants to ask that, sir, elderly with anemia and fatigue, protocol for screening of colon cancer include flexible sigmoidoscopy yearly, no 5 yearly, colonoscopy every 10 yearly, yearly fecal occult blood. Very good. Bhavjit, very good question. Very good. Guys, for screening of colorectal cancer, either we can go for FOBT, fecal occult blood testing annually, or flexible sigmoidoscopy every 5 yearly, or we can go for colonoscopy or double contrast barium enema every 10 years. Every 10 years. Yes. So every 10 years you can go for colonoscopy. That's the correct answer. Telephone-like instrument option was check thickness of artery vein thrombus localization. Okay, telephone-like, so that might be Doppler. Clear? And that might be Doppler for checking DVT. Okay, guys. Okay. Now see, guys, next question. A newborn child presents with complaints of bilious vomiting. Child was having bilious vomiting and abdominal distension. X-ray abdomen was done. What is the most probable diagnosis? So guys, you can see that this is one bubble. Here what you can see, in this image you can see this is one bubble and this is the second bubble. So this is double bubble, and double bubble it is seen in duodenal atresia. And where is the obstruction in duodenal atresia? Obstruction is distal to ampulla. Since obstruction is distal to ampulla, these patients are having bilious vomiting. The patient is having bilious vomiting. Clear? Okay, guys, bilious vomiting. So correct answer is here, duodenal atresia. What kind of vomiting occurs in hypertrophic pyloric stenosis? In hypertrophic pyloric stenosis, there is non-bilious vomiting. Non-bilious vomiting. Clear? In esophageal atresia, what happens? There is continuous drooling of saliva. What happens? Vomiting is not there. Okay, Rangita wants to say that imaging of choice for patient with elevated metanephrines. Whenever elevated metanephrines are there, investigation of choice is MRI. Guys, it is MRI. Clear? Whenever you are suspecting what? Suspecting pheochromocytoma, investigation of choice, it was MRI. Right? Okay, guys. Next. In a patient of aortic dissection, which of the following structure will be involved in hiccups? Now guys, hiccups is because of involvement of two nerves. Can you tell me most commonly which nerve? Hiccups, involvement of which nerve? Okay, ranula treatment was asked. Very good. If MRI was not there, then go for the CT. If MRI was not there, go for the CT. Hiccups, there in hiccups, there is involvement of phrenic nerve, and there is involvement of what? Vagus nerve. Most commonly it is involvement of phrenic nerve. Because of that there is hiccups. So the correct answer is A. Correct answer is A. Okay. So if pheochromocytoma question was there in which metanephrines were raised, we are suspecting pheochromocytoma, go for CT. CT. Now next question, guys, easy question. Patient with thyroid malignancy, serum calcitonin found to be very high. Which of the following is most likely scenario or most likely diagnosis? And you know that calcitonin is a marker for which tumor? It is a marker for medullary carcinoma thyroid. See, MIBG scan is a good investigation for localization, but this is for extra-adrenal pheochromocytoma. What? For extra-adrenal pheochromocytoma, MIBG is a good investigation for localization. But investigation of choice for extra-adrenal pheochromocytoma, that is MRI, and usually for pheochromocytoma, if MRI is not there in the option, what you have to go for? CT. Okay, guys, so here it is medullary. Anybody wants to add something in the language of this question? Anybody wants to add something in this language? Adenocarcinoma, Meghrath. Okay, most common type of thyroid cancer. Very good. Meghrath, thank you. That is obviously papillary carcinoma. Okay, Bhaujit Walia. Very good, Bhaujit. Bhaujit, you are sending me special questions. Thank you very much. Bhaujit wants to say that, sir, another breast cancer question. HER2 new negative. Histopathological examination given. Signet ring mentioned. Can you tell me what were the options, Bhaujit? Okay. So there was a case of thyroglossal cyst. What is the treatment of choice, guys? Obviously, it is cyst trunk operation. Guys, do you remember the exact language of question, Meghrath? Lobular carcinoma, okay. Ductal lobular. Mucinous variant was there because signet ring variety is seen in mucinous. Mucinous variant was there. Guys, for thyroglossal cyst, apart from cyst trunk operation, what were the other option? Mucinous, yes, mucinous variety. If there is mucinous breast cancer, in that case what happens? The mucus or mucin is going to push the nucleus to one side and there is signet ring variety. E-cadherin, very good. Adenocarcinoma, you remember what was the exact question related to E-cadherin? E-cadherin was absent. Okay, Dhruv, very good Dhruv. Indian file pattern. This question was asked in lobular carcinoma. Indian file pattern is seen in. This question was asked, guys, or not? Indian file pattern, it is seen in lobular carcinoma. Lobular carcinoma. This question was asked or not? Okay. Vaideshwari Divya wants to say that, sir, hemithyroidectomy, total thyroidectomy, subtotal thyroidectomy. Okay. Hemithyroidectomy, total thyroidectomy, subtotal. Thank you very much. Okay. Aravindhan wants to say that, sir, 6-year-old boy, midline swelling. 6 years old boy, there was midline swelling. Midline swelling moves up on protrusion of tongue. Midline swelling moves up on protrusion of tongue. Moves up on protrusion of tongue. Very good, guys. Very good. Protrusion of tongue. Clear? In this case, what is the treatment of choice? Obviously, yes, it is cyst trunk operation. Very good. Everybody is correct, guys. Everybody. Okay, Dhruv Panchal wants to say that, sir, there was another question related to papillary carcinoma thyroid and option arises from parafollicular C cells. Papillary carcinoma thyroid arises from parafollicular C cells. That's wrong. Do you remember the other options? Arises from para, it's all except. Arises from parafollicular C cells. Guys, parafollicular C cells. Clear? You know that. Obviously, it's the medullary carcinoma thyroid which arises from parafollicular C cells. Okay? Yes. So, incorrect pucha tha, that's why this is the correct answer. Now, this was the question, guys. Most common fluid preferred during minor surgery. So, if crystalloid and saline both are there, obviously we choose crystalloids. If crystalloid is not there, then you are supposed to choose saline. Crystalloid is there, choose crystalloid. If crystalloid is not there, in that case what? Choose. Okay, 98% survival. History of radiation exposure, very good. Here, there was 98% survival. There is history of radiation exposure, very good. History of radiation exposure. Okay, Bhaujit Walia, it was normal saline and balanced electrolyte solution. Okay, it was normal saline and balanced electrolyte solution. Balanced electrolyte solution. Okay, one question was on Doppler image based question, so might be from radiology. Guys, there was one question related to post radiation weight loss cause. Anybody remembers the exact question? Anybody remembers exact question? Fluid preferred in intraoperative blood loss. Is the fluid preferred in intraoperative blood loss? Intraoperative blood loss. post radiation weight loss around 6 kg. Okay, 6 kg due to recurrence of guys, can anybody tell me what was this question? Post radiation blood loss. Dhruv, you remember? Esophageal fibrosis. 6 kg in 3 months. 6 kg in 3 months. So obviously, GERD achalasia, chances are lesser that GERD or achalasia will be there. Guys, it is because of recurrence. It's because of recurrence. Yes, one question was there. Second malignancy, okay. Second malignancy is not that common, recurrence is common. See, it depends on the malignancy. Sometimes suppose if the pelvic malignancy is there and you are giving radiation, so obviously patient will not develop esophageal fibrosis. We have to look at where exactly the malignancy was located, right? On the basis of that you have to mark the question. Suppose location is not given, in that case you mark the recurrence. Recurrence, okay. Hypoproteinemia, okay guys. What was the other option? What were the other options? Hypoproteinemia. What were the other options? Okay, Thomas Ajit wants to ask that, sir, there was one question related to lucid interval treatment. There was one question related to lucid interval treatment. Okay guys, now Rangita is telling me the exact question. Patient with esophageal cancer, weight loss 6 months, what is the cause? Yes, if patient is having esophageal cancer and there is weight loss, yes, obviously it's because of recurrence. Obviously it's because of recurrence. Okay guys, now next question. Which of the following condition is depicted in the given CT? So guys, this question was there. Can you see the image? On both sides, this kind of enlarged suprarenal gland was there, or it was connected like this. If this kind of image is there, yes, this is congenital adrenal hyperplasia. This is congenital adrenal hyperplasia. Okay. Okay guys, so this is congenital adrenal hyperplasia. Do you remember the exact language of the question, Rangita? Do you remember the exact language of the question? Okay, it was unilateral enlarged congenital adrenal hyperplasia. It was unilateral. Yes, I know that emphysematous pyelonephritis was also there, and there was one question related to. Okay, now this question you can see guys, the patient is having what? Patient is having EDH. There is biconvex hyperdense lesion, you can see here, biconvex hyperdense lesion. So obviously this patient is having EDH. What is the treatment here? In this question, lucid interval was mentioned or not, guys? Tell me. In this question, lucid interval was mentioned or not? Craniotomy with evacuation. And what was the fourth option, guys? Conservative management. Okay, fourth option, conservative management. Okay, which of the following is the preferred treatment in this condition where lucid interval is positive? This was a trauma patient. Guys, this was a trauma patient. Okay, patient is getting better with time. Patient is getting better with time. Doesn't matter. Patient is getting better with time. We have to drain it. Okay, platelet related drug was mentioned. Right, guys? So obviously here the correct answer is what? The correct answer is obviously we go for craniotomy with evacuation. Rangita wants to say that, sir, midline shift was there. There was midline shift. Okay, lucid interval नहीं था but explanation था. Right, guys? Okay, so here craniotomy. Guys, there was one question related to pneumothorax which somebody was already sent me. There was this kind of question, and obviously road traffic accident with head injury. It was road traffic accident with head injury or because of hammer. This injury was because of hammer. Mannitol is given when ICT is raised. Okay, guys. Head injury with hammer. And obviously, whenever we are using hammer, patient will be having depressed skull fracture. So this is what? This is depressed skull fracture. Guys, you can see here. This is depressed skull fracture. Correct answer is C. Hammer from co-worker fall on his head. Okay, very good. Hammer from co-worker fell. Hammer from co-worker fell on the head. Fell on his head. Okay, very good, guys. This is depressed skull fracture. Guys, there was one question related to Clostridium perfringens. Anybody remembers that? Elderly patient with Clostridium perfringens. Okay, worker not wearing safety cap. Worker not wearing safety cap. Not wearing safety cap. Okay, guys, very good. Thank you. हेलमेट भी नहीं पहना था. डॉक्टर डेंगर, वेरी गुड, वेरी गुड. एल्डरली पेशेंट. ओके, एल्डरली डायबिटिक पेशेंट. यस, वैदेही, वेरी गुड. वैदेही, elderly diabetic patient. Clostridium perfringens was not mentioned. Necrotizing fasciitis image was given. There was necrotizing fasciitis image. Necrotizing fasciitis image was given. Okay, obviously blister, woody surface on touch. There was blister, presence of blister, and woody surface on touch. Woody surface on touch. Yes, guys. So see, elderly patient, if there is history of diabetes, so obviously these are the risk factors for necrotizing fasciitis. So here the correct answer would be necrotizing fasciitis. Guys, gas gangrene cellulitis necrotizing fasciitis. Anybody remembers the fourth option? Okay, yes, necrotizing fasciitis, it is extremely painful. Very good. It is extremely painful. One option was DVT. Okay, guys. Yes, Bhaujit, we have that question. That question is coming, in which patient was having pain and patient was having, ecchymosis around umbilicus and in lower abdomen. No. Immediately we are not giving blood. Guys, Nakul, whenever there is minor surgery and blood loss, you are not going to give the blood transfusion. We just give the fluid. Abortion questions are tackled in gynae. Anybody remembers that question related to carcinoma gallbladder? Yes? Nakul, Telugu, Wasim, Akanksha. Anybody remembers that question related to carcinoma gallbladder? Yes. Dye factory worker, very good. Rajanan, very good. Dye factory worker. And guys, you know that exposure to dyes, dye factory worker, it is going to increase the risk of transitional cell carcinoma. So dye factory worker and cystoscopic image of urinary bladder cancer. There was cystoscopy image of CA bladder. Very good. Very good. Yes, there was no transitional cell carcinoma, right? Guys, you know that dye factory, whenever there is exposure to dyes, it is going to increase the risk of transitional cell carcinoma. Now, okay, one option was benzidine. Abhi, invasion of wall in long history. If there is wall invasion, if there is invasion of wall, clear guys, in those cases what? You have to go for radical cystectomy. One option was intravesical BCG. Guys, do you remember what were the other options? There was benzidine exposure also. You know that benzidine, it is also a risk factor for transitional cell carcinoma. Okay, cystoscopy with removal of tumor, right? Cystoscopy with removal of tumor. Okay guys, TURP, radical cystectomy. Guys, in this case, whenever there is involvement of muscle, we go for radical cystectomy. If patient is having papillary tumor or whenever the stage is T1, in that case, we just go for TUR, transurethral resection. It is not TURP actually, it is TUR, transurethral resection. If wall is not invaded, if there is no invasion of wall, in that case you can go for transurethral resection. Plus, after transurethral resection, we have to give what? We have to give intravesical chemotherapy. Okay, 65 years old patient. Patient was 65 years old. Okay, varicose vein. For varicose vein, what is the investigation of choice? It is duplex. Now guys, can you tell me what was this question? Manhole injury with bulbar urethral injury. There is a question, manhole injury with bulbar urethral injury. What was this question? Anybody remembers? Okay, straddle injury was there and extravasation of urine. Very good. There was straddle injury with extravasation of urine. Okay. This is a repeat question. This question was asked in last session also. Straddle injury with extravasation of urine. Okay, right? So where is the location of leak where urine will be collected? So where urine will be collected? Okay guys, urine will be collected, right? So the question was where urine will be collected, or the question was like this, that in all of the following area urine will be collected except. Rangita, you are correct. Very good, Rangita. So obviously it will be collected in deep perineal pouch, superficial perineal pouch. Actually, it depends on the option. No, urine cannot continuously dribbling, guys. Whenever there is urethral injury, urine will not be dribbling, urine will be collected. Okay, deep perineal pouch tha. Okay, I will formulate because it's a repeat question, it was asked previously. Okay, next question guys. Kidney stones removed, patient presents with flank pain. Patient was having kidney stones removed, flank pain after 4 to 5 years with foreign body on imaging. What was this question? Vedeswari Divya, deep perineal space, ischiorectal, superficial perineal pouch. Very good. Except nahi tha. Okay. Right. Image showing DJ stent. Very good. There was image showing DJ stent. Guys, can you tell me what were the options? Management was asked. Yes, that's the correct. Alok Anand Ray, you are correct. We perform cystoscopy and removal of foreign body. Yes, so management, we perform cystoscopy with removal of foreign body. That foreign body is what? DJ stent. Cystoscopy with removal of foreign body. Removal of foreign body. Okay. Guys, what were the other options for this question? Vedeshwari, you remember? Pratik Mahala, Shubham Chandel, you remember? What were the other options for this question? Question number 27. Yes, there was DJ stent image, right? What were the options? Laparotomy and cystoscopic removal, okay? Laparotomy and cystoscopic removal. RGU, retrograde urethrogram. He was having fever also, okay? The patient was having fever also. Clear? So guys, for such cases we perform cystoscopy, and after cystoscopy we are going to take out that DJ stent, removal of the foreign body. Okay, leave the foreign body inside. Very good. Leave the foreign body inside. Leave the foreign body inside. Obviously we are not supposed to leave it because it is in source of infection. Patient is having pain, we have to remove it. Cystoscopic removal, rectourethral approach, okay? Retro urethral approach. Right guys, so I think this was the same question. Image of DJ stent. Investigation for assessing kidney function. There were two questions with DJ stent, or in this question only the question language was that which investigation is used for assessing renal perfusion or function. Best investigation to assess renal function. Best investigation to assess renal function. Okay, so there was no DJ stent question. One question, best investigation to assess renal function. It was renal perfusion. Best investigation to assess renal perfusion. So guys, if you want to assess renal perfusion, best, that's the gold standard, it is MAG3. Anybody remembers this question? Mercaptoacetylglycine, MAG3. DMSA, it is for morphology surface scar. Option was IV cystography. Okay guys, MAG3 was not there in option. DTPA scan was there or not? DTPA scan. See, if MAG3 is there, mark MAG3. If MAG3 is not there, go for DTPA scan. Clear guys? Go for DTPA scan. Okay, one option was CT urogram or CT urography. Clear? So if MAG3 was not there, mark DTPA scan. DTPA was not there. Then for perfusion, we can go for CT urography. If DTPA is not there, then go for CT urography. Okay. Now guys, this question 29. All of the following are correct about papillary carcinoma thyroid. So we already discussed what were the options, that it develops from parafollicular C cells. Next question was related to ranula. So what was the question? Treatment of ranula. Image was there or not? Treatment of ranula. There was image in the question or not? Shubham wants to say that questions were lengthy. See guys, lengthy questions means more information and the chances of marking correct answer increases. No image. Treatment of ranula. Now guys, swelling in the floor of mouth. Patient was having swelling in the floor of mouth, with swelling in floor of mouth. There was positive transillumination. There was cystic swelling with positive transillumination. Positive transillumination. Bluish red in color. The color was bluish red. So bluish red in color. Clear? 5 years duration. Very good. Rangita, very good. Most of the times Rangita is providing accurate information. Bhavjit, you are also providing accurate information. Very good. 5 years duration. So guys, what was there in the option? Marsupialization was there. In the option, marsupialization was there. Okay, option was ranula. So it was not the treatment, it was the diagnosis. It was the diagnosis, guys. So option was ranula. What were the other options, guys? Okay, what were the other options, guys? One was ranula. What were the other options? Anybody remembers? Diagnosis. Akanksha, do you remember the options? Rangita apart from ranula, dermoid cyst. Okay, very good. Dermoid cyst. Very good. What were the other options, guys? Other options? Akanksha, Gaurav, sublingual growth. Okay. Third option was sublingual growth. Sublingual abscess. Thyroglossal cyst was also there, guys. Abhi wants to say Quincy was there, or it was another question. No? Okay. Okay, guys. Next question. Lichtenstein repair of hernia. There was image given. What was the question? Which mesh is used? Alpana, Abhijit, Krishna Kumar, Naidu, Moonlight. Okay. Guys, Lichtenstein repair of hernia was given. Image based question was there. Which material? Okay. Image. Which material is used? Which material? For mesh. Clear, guys? Okay. So one was polypropylene, polyglycol, polyglycolic acid, polypropylene. What were the other options? polyacrylamide, polygalactin. Okay guys, so you know that which mesh we are going to use. We are using proline or polypropylene mesh, and the mesh is also used, also fixed with which suture, proline suture. So we are using proline suture and this polypropylene mesh. Okay, polydioxanone was there. Polygalactin, polydioxanone. Okay, next question. What is the likely diagnosis from the CT given below? So guys, you can easily make out that this is horseshoe kidney. This is clear-cut case of horseshoe kidney. Can you check the options? What were the options for this question? Okay, Abhijit, thank you very much, Abhijit. Thank you very much. What were the options for this horseshoe kidney? They gave two images. Okay, one IVP was also there. Okay, IVP image was also there. IVP and CT, two images. Right. Same options. Now guys, varicose vein, what is the investigation of choice? Duplex scan. Duplex scan. What were the other options, guys? Other options for varicose vein. डॉक्टर एडिनोकार्सिनोमा सर आपकी कृपा से सर्जरी तो अच्छा गया. एडिनोकार्सिनोमा वेरी गुड एंड कॉन्ग्रेचुलेशंस. Congratulations. Duplication of ureter. Okay. Plethysmography, one option was plethysmography. Another option was ultrasound. Ultrasound, plethysmography. Okay. Ashish Naidu MBBS. Guys, do you remember the fourth option? Fourth option. Okay, CT, MRI, duplex, plethysmography. Rangita, CT, MRI, duplex, plethysmography, and guys, you know the answer. What is the answer here? Duplex. Duplex. Okay, Dr. Alok Anand Ray, only two questions are wrong. Very good, very good. Right. Guys, diffuse esophageal spasm related question was there. Anybody remembers that? Diffuse esophageal spasm related question was there. Anybody remembers that? नहीं था. Thanks Rishu. Surgery was done. Surgery went well because of you. Thank you very much. ये question नहीं था. This question was not there. Okay guys, it was not there. There was one achalasia cardia case. Okay, Adele, do you remember that achalasia cardia case? You remember that achalasia cardia? What was that question related to achalasia cardia? Okay, there is vomiting in supine position. Vomiting, very good. Yes, it is clue for achalasia. Halitosis, regurgitation, Krebs. Yes, there can be, but halitosis, pointer for pulsion diverticulum. Regurgitation can be there. Any question related to dysphagia? Statement was related to dysphagia in achalasia cardia. Okay guys, if anybody remembers the question related to achalasia, please send that. Please send that. Okay, because the findings are suggestive of what? Pulsion diverticulum. Or yes, that is suggestive of Zenker's diverticulum. Now next question, chronic liver disease patient with history of hematemesis. Anybody wants to add something in the language of this question? Guys, anybody wants to add something in the language? One option was esophageal carcinoma. Very good. Esophageal carcinoma. What were the other options? Guys, other options. Chronic liver disease, history of hematemesis. What were the other options? Rangita, ये question नहीं था. Okay, this question was not there. Not there. Okay. Now, management of acute appendicitis. This question was there or not? Management of acute appendicitis. This question was there or not? Guys, Mallory Weiss abhi wants to say that हाँ ये था. Okay guys, appendicular lump, Oshner, lump was palpable. There was lump was palpable. What was the history? Lump palpable in right iliac fossa. Okay. There is pain in right iliac fossa. Pain in right iliac fossa. Lump in right iliac fossa. Okay. 5 days history of pain. Bhavjeet Walia, very good. Very good, Bhavjeet. Very good. So what we have to go for? Obviously, guys, we have to go for Oshner Sherin regime. Because it's a case of appendicular lump. So this patient should be managed conservatively by Oshner's Sherin regime. There is increased TLC count. Leukocyte count was there. Appendectomy, lap appendectomy. Alvarado regime. Alvarado, that is the score. Alvarado regime. Okay. Very good. Okay. So guys, obviously the correct answer is Oshner-Sherin regime. Oshner-Sherin regime. Okay. Next, anybody remembers question related to hypertrophic scar? There was one question related to hypertrophic scar. Yes guys, do you remember? Question related to hypertrophic scar. There was pain and fever also. No? Okay. Hypertrophic scar was not there. Okay. Next, maxillofacial trauma patient intubation of choice. This question was there or not? Maxillofacial trauma patient intubation of choice. Thank you, crazy doctor. Thank you very much. Yes. So guys, can you tell me what were the other options? Tracheostomy, endotracheal intubation. What were the other options? Guys, tell me what were the other options? Adenocarcinoma, yes, margolins हमने discuss कर लिया. We discussed laryngoscopy. Okay. Tracheostomy is correct, guys. Tracheostomy, Anoop, you are correct. Laryngoscopy. Mask ventilation. Sachin, thank you, Sachin. Thank you very much. Mask ventilation. Obviously, in this case, what's the problem? Whenever there is maxillofacial trauma, the emergency airway is needle cricothyroidotomy, but the definitive airway of choice, that is what? Tracheostomy. If maxillofacial trauma is not there, then for intubation, airway of choice is endotracheal intubation with cuffed ET tube. So here, patient is already in hospital. Maxillofacial trauma patient in hospital. Okay, it was laryngeal mask airway. Very good, Bhavjeet. Very good, Bhavjeet. LMA, orotracheal intubation was there. Not endotracheal, it was orotracheal. Clear? Very good. So correct answer is, obviously we go for, guys, what we go for? We go for here. Here we go for tracheostomy. That's the correct answer. That's the airway of choice. Okay, guys, that's the airway of choice. Okay, next question. Case of infection with hard woody texture. We already discussed that case. It was necrotizing fasciitis. Next question. Case of road traffic accident presented with EDH. Where will be impact of collision? This kind of question was there. Impact of collision, and obviously the correct answer is pterion. This question was there. Okay, Abhijit Manoj, very good. Yes. So can you tell me what was the fourth option? Here, what was the fourth option, guys? Bhavjit. Thank you, Bhavjit. There was one question related to suprameatal triangle. If you remember, please message the question. Suprameatal triangle question. So it's a yes, chocolate question. Very good. Suprameatal triangle. Okay, guys. So obviously it is pterion. Thank you, Bhavjit. Yes, I understood that it's option. Okay, chronic liver disease. Yeah, this was not there. Thoracentesis, site of needle insertion. There was one question, thoracentesis, site of needle insertion. Guys, this question was there. Upper border of lower rib. I hope everybody marked the correct answer. Yes. Anybody remembers other options? What were the other options? Mewarika, Ujita, Ashish. Anybody remembers the other options? Lower border of upper rib. Okay. There was lower border of upper rib. Okay, we will formulate. So upper border of lower rib, upper border of upper rib. Okay, we will formulate similarly. So lower border of lower rib, upper border of upper rib. Clear? So obviously, guys, you know the correct answer is upper border of lower rib. Okay, Abdul Nafai Apaili, nasopharyngeal intubation, oropharyngeal, laryngeal mask airway, tracheostomy. Then also the correct answer is tracheostomy. Middle of intercostal space. It's the middle of intercostal space. Obviously, it's not the middle of intercostal space. Okay, Ashley, very good, Ashley. There was a patient of trauma, had bleeding in the lungs. Management. Trauma patient with bleeding in the lungs. Guys, tell me what was this question? Trauma patient with bleeding in lungs. Bleeding in lungs. What was this question, guys? And what were the options? Okay, very good question. It was predictable question. There was 1800 ml blood loss in 1 hour. 1800 ml blood loss. Okay, guys. So whenever there is more than, here the blood loss is more than 1500 ml, it was chest tube, from chest tube. From chest tube. This is a case of blunt trauma or penetrating trauma. It was a case of blunt trauma or penetrating trauma. In 1 hour. In 1 hour. Yes, Rangita, you are absolutely correct. Management is thoracotomy. Management is thoracotomy. Guys, whenever there is blunt trauma and there is blood loss of more than 1500 ml, penetrating trauma more than 1000 ml of blood loss, it means some active vessel is bleeding. You have to perform thoracotomy. Guys, do you remember drain for next 6 hours? Urgent thoracentesis. Urgent thoracentesis. No. Drain for next 6 hours. Drain for, you guys are really amazing. This kind of recall was not possible because of your help, because the questions were lengthy. Thank you guys, thank you very much. And what were the other? Okay, road traffic accident patient was there. Road traffic accident patient, blunt trauma was there. Very good, guys. Thoracotomy. What, guys, do you remember the fourth option? Continue resuscitation. Okay, wait and watch. Wait and watch. Continue resuscitation. Continue resuscitation. Bhaujit, again Bhaujit is rocking here. Thoracotomy, inject hemostatic agent through chest tube, continue resuscitation for 4 hours. Thank you Bhaujit. You are really very, very helpful. Very helpful. Okay guys. Now, classical science and laboratory investigation of pheochromocytoma. Guys, can you please tell me what was that exact question related to pheochromocytoma? What was that exact question? Bhaujit, you remember? Because most of the times you are giving exactly the same options, same language. Bhaujit, but that's not correct. Because whenever, see, whenever continuously bleeding is there more than 200 ml for 3 hours, for consecutive 3 hours, or if after blunt trauma there is 1500 ml of blood is coming from chest tube, after penetrating trauma 1000 ml of blood is coming via chest tube. Okay. Okay guys, best imaging. The question was related to best imaging. Patient was having hypertension. Patient was having hypertension, headache, complaints of hypertension and headache. Headache. MIBG scan, MRI. High levels of metanephrine. Patient has episodic palpitations. Bhaujit wants to say that, sir, imaging of choice for system EB scan was there. MIBG, chest, CCT, chest, abdomen. MIBG, system EB, CCT, chest, CCT, abdomen. So if you have to choose among these, choose CCT, abdomen. Okay, MRI was not given. Okay, then choose CT. Metanephrines were high. There was high metanephrines. Okay, somebody wants to say that, sir, HIDA scan was also there in option. Guys, HIDA scan was there in option or not? Okay, Mevarika, yes, Asterion was there. I marked that Asterion. There was one question related to pheochromocytoma preoperative management. Very good, guys. What was that question? Preoperative management of pheochromocytoma. We are giving non-selective beta blocker. Preoperative management of pheochromocytoma. Do you remember the options, guys? CT, chest plus abdomen, one option was there. Okay, guys, that's great. So this is the correct answer. Preoperative treatment. Drug. Non-selective beta blocker. Yes, it is phenoxybenzamine. Yes, guys, it is phenoxybenzamine. Phenoxybenzamine. So option was alpha adrenergic blocker. Yes. Positive pressure ventilation. Alpha adrenergic blocker. Guys, what were the other options? Alpha adrenergic blocker. What were the other options, guys? Calcium channel blockers. Very good. Calcium channel blockers and beta blockers. Very good. Beta blockers. Okay, guys. So correct answer, obviously, it is alpha blockers. We gave what? Phenoxybenzamine. Yes. Next question, guys. Question number 44. Yes. See this. Patient presented with abdominal pain in emergency for 1 day. CT abdomen normal. Patient was hypotensive. Image is shown below. What is the diagnosis? And if you see this image carefully, what you can see here, you can see that there is ecchymosis around umbilicus. In this image, you can see that there is ecchymosis around this umbilicus. Here, ecchymosis around the flank, and here in the inguinal region. So in inguinal region, this is known as Fox sign. Ecchymosis around umbilicus, this is Cullen sign. Clear? So guys, the same image was there in the question. Okay, one option was fat necrosis, traumatic fat necrosis. One option was traumatic fat necrosis. Okay, chronic pancreatitis, necrotizing fasciitis. Okay, so chronic pancreatitis, necrotizing fasciitis. Okay guys, so obviously it's a classical case of acute pancreatitis. Here there is retroperitoneal hemorrhage, so bleeding occurs along the facial planes. Because of that, this kind of ecchymosis is there. Clear? Guys, if this image is there, go for acute pancreatitis, right? But it depends. If there is only involvement of perineum, only involvement of perineum scrotal skin, if that area is involved, in that case you have to think about necrotizing fasciitis. Blackening of scrotum. Okay, if there is blackening of scrotum, if blackening of scrotum is there, then in that case you have to go for necrotizing fasciitis. If typically ecchymosis is there, go for acute pancreatitis. But if perineal skin is involved, because perineal skin is not involved in acute pancreatitis. So if perineal skin is involved, in that case go for necrotizing fasciitis. Evident black, okay Rajika, so go for necrotizing fasciitis then. So guys, I explained both. If there is blackish discoloration of perineum, in that case go for necrotizing fasciitis. Okay, there was no Cullen sign, right? So this image was not there. There was necrosis or blackish discoloration of perineal skin. If there is blackish discoloration of perineal skin, in that case the correct answer would be what? Necrotizing fasciitis. So in that case the correct answer would be necrotizing fasciitis. Okay guys? No, it's not traumatic fat necrosis, guys. What happens? The amount of fat is very little in the scrotal skin. And another, Mehta wants to say that, sir, bulla was ruptured. So this is another hint for necrotizing fasciitis if there is rupture of bulla. And since CT is normal, in the image it is given that CT is normal. So if CT is normal, so it is going to rule out acute and chronic pancreatitis. So CT is normal, then it is going to rule out acute and chronic pancreatitis. Okay? Right. So if CT is normal, so obviously guys, here the answer becomes very clear. It is necrotizing fasciitis. Now this question is a clear cut case of emphysematous pyelonephritis, guys. Here you can see there is presence of air. Here you can notice that. Clear? So this is a clear cut case of emphysematous pyelonephritis. History, chills and rigor, acute pain in right flank. Investigation is shown below, where you are going to find the presence of gas around the kidney. So this is emphysematous pyelonephritis, and you know that what is the most common organism responsible? E. coli. It is the air producing organism, E. coli. Okay guys, there is another history. Diabetes mellitus history was there. It means again it is more common in the patients who are diabetic. Anybody can remember the age of patient? What was the age of patient? Age, Bhaujit, do you remember? What was the age of patient? Okay, approximately 40 years. Male or female? Okay, 45 years. Male, female. So 45 years, female. Okay, adenocarcinoma, love you too. Guys, there was one question, Wardin's tumor. Wardin's tumor. This question was there or not? Wardin's tumor is also called. With IUD, okay. With IUD, okay. Wardin's tumor question was there or not? No? Okay, right. After that, question, most common brain tumor in adults. This question was there or not? Most common brain tumor in adults. Swelling below ear lobule. There was swelling below ear lobule. Nerve supply. Okay, ENT question. Intraorbital tumor. It was not the brain tumor. This was intraocular. Okay. Intraocular. Okay. Intraocular. Okay, one question was related to Wilms tumor. Ashley, can you tell me what was that question related to Wilms tumor? Wilms tumor question. Can you tell me? What was the question related to Wilms tumor? Shubham Chandel, tell me what was the question, guys. Anybody remembers? एक बच्चा में Wilms tumor. Okay, child with Wilms tumor. What was the problem? 4 years old child, pain. Okay, 4 years old child. 4 years old child. There was pain in abdomen, pain and mass. Okay, there was intraocular tumor with proptosis. With proptosis. So if, okay. Guys, you tell me what was the question related to this Wilms tumor first. Okay, what were the options related to with this Wilms tumor? Options. What they ask in the question, they ask the diagnosis. He was young with pain. What they ask in the question, they ask the diagnosis. Shivani, Akanksha. Okay, diagnosis. So what were the options, guys? What were the options? One was Wilms tumor. What were the other options, guys? Shivani. What were the other option? Rajika, RCC. Okay, guys, RCC. Angiomyolipoma, very good. Neuroblastoma, Abhi, very good. Angiomyolipoma, angiomyolipoma, neuroblastoma, very good. Neuroblastoma. So it's a classical case of Wilms tumor, guys. Classical case of Wilms tumor. Generally, age is 2 to 4 years. Patient presents with mass. There is fever. There is hematuria. Pain is also there, but that is not the part of triad. Okay, right. Now, which of the following statement is correct about triage? There was one question related to triage. Guys, you remember the question related to triage? Triage. This question was there or not? Question related to triage. Yes? Okay, guys. So tell me, what was the question? Right. Now see the combination. Red. Red is immediate care is required. So this is not ambulatory. In red, immediate care is required. Black. Black is dead or moribund patient. So it's dead or moribund. Clear? Which patient is ambulatory? Green is ambulatory. Green is ambulatory. And delayed care for yellow. Delayed care because these patients are less critically injured. Okay. So what is the correct answer here? B. Less critically injured, so yellow. These patients are stable, these patient needs observation. Clear? So yellow. Rajika, very good, yellow. Okay. Guys, there was one question related to GCS. I remember 2-3 questions were there because students were telling me. So do you remember another question related to GCS? अभी रिकाल से मुझे नशे चढ़ रहे हैं, कोई बात नहीं. Doesn't matter guys, doesn't matter. Okay? No question? Right. Right? So these were the questions of surgery recall, guys. Anybody remembers any other question related to surgery? Because we recalled almost 50 questions. I think guys it's more than 50. Okay, one question about raccoon eyes. Can you tell me what was the question, guys, related to raccoon eyes? Question related to raccoon eyes. Tell me. Arvindhan, what was the question related to raccoon eyes? There was one question related to portal vein thrombosis. Do you remember, guys, what was the question related to portal vein thrombosis? Which layer of skull will present with raccoon eyes? Which layer of skull? Injury. Okay, which cranial fossa injury? The question was something like this. Which cranial fossa injury presents with raccoon eyes? Okay, location of injury in raccoon eyes. Location of injury. So guys, you know that it is seen in anterior cranial fossa fracture. What were the options, guys? You remember options for raccoon eyes? What were the options for raccoon eyes? Okay, yes, anterior cranial fossa fracture, middle cranial fossa, posterior cranial fossa. Okay, yes, Shubham, paper was integrated. Somebody is asking that, sir, there was one question related to breast abscess. Anybody remembers the question related to breast abscess? Bone aponeurotic layer. Anybody remembers the question related to breast abscess? No breast abscess. Okay, guys, any other question? Because now the question is 50 plus. The total recall is 50 plus. That's amazing. And it was not possible. Okay, Hadfield's operation. Mahima Kumar wants to say that, sir, Hadfield's operation question was there. Guys, Hadfield's operation was there. Hadfield's operation. Bloody nipple discharge. Option was okay. That's great. Bloody nipple discharge. Very good. Bloody nipple discharge. Clear? Most common cause of bloody nipple discharge. Yes, guys, most common cause of bloody nipple discharge, that is duct papilloma. So for this we go for microdocectomy. Here we go for microdocectomy. Another option was Hadfield's operation. Guys, do you remember other options? Do you remember other options? Microdocotomy was also there. Okay, microdocotomy. Okay, IV antibiotics. IV antibiotics. This is really great. This is really great recall, guys. Really great. Possible just because of, okay, incision plus antibiotic support. Incision plus antibiotic support. So we give incision plus antibiotic. Yes, single duct affected. Okay, there was single duct involvement. Single Duct involvement. Okay, guys, so it's more than 50 questions. Thank you very much. This session was really amazing, and I hope that you are going to crack this FMG exam with flying colors. Best of luck and all the best from the whole team PrepLadder. All the best for the results from the whole team. And very soon we are going to put the video. Let me recollect all questions with exact options. And Abhishek Mishra 6 wrong, but obviously 40 plus questions are correct. That's really very good score. Very good score. Okay. Thank you guys. Thank you very much, and stay with the session because some more recall sessions are there of other faculties. Till then, bye bye. Take care. Navrang Chaudhary 35, Abhi, very good. Gaurav Sani, very good guys, very good. 28, everybody is approximately 30 plus. Congratulations guys and good luck. Good luck.
Hello, guys. A very good evening to all of you. I hope and I pray for all of you that your exam, MC exam, went very well. I know you had a very long and tiring session with the general surgery teacher, but I will try to cut short this session for you. So you just have to relax and just see what are the questions I am telling you. If you have any questions from your side, you can also ask. I have got a few questions from the students, and in which I think out of those 5-6 questions, only one question which was there, which I found to be a bit tricky. And I personally feel that in that question, not enough information was given for you guys to choose the correct answer. But before moving on to that question, I'll try to solve the questions which I have in my hand right now. So the first question was from the muscle relaxants. I gave you an explanation about 2 drugs that undergo Hoffman degradation. And you all must be knowing that Hoffman degradation is a time-bound non-enzymatic degradation of the drugs of the muscle relaxants. That is, they do not get metabolized by liver or kidneys or by any other system. The mechanism of their degradation, if you want to say it simply, that the mechanism of atracurium and cis-atracurium for their degradation is not known. So in this scenario, the answer is very straightforward. that cis atracurium undergoes Hoffman degradation. The other option has to be atracurium, right? So these brothers and sisters, they undergo Hoffman degradation. Very simple question. Only two drugs which undergo Hoffman degradation are cis atracurium and atracurium. Now, guys, these are the questions which are not sure shot. We have just got these questions from you students only. So if you have any other option, if you have a differently formulated question, you can just tell me now and we can discuss those questions as well. Now, the next question was rather the most simplest of all. If you have read even the half of anesthesia, this was the first thing which I taught you in anesthesia. That was the pre-anesthetic care. And I told you that the Malampatti scoring system is an image-based question, and this can be asked directly. I guess the question which was asked, that they gave you this image and they asked you what this belongs to. So the answer straight away is Malampatti grading, that or the Malampatti scoring. They had given some other options as well. I don't know those options. If you have, you can just see it. But if this image was there, you don't have to go beyond anything, the MPC scoring, right? Now, guys, these were the two questions which I got in printed from you all. But I have a few questions in which the questions are not formulated. I'll just check it because the students have sent it to me. Now, there was a question about a patient who is in shock, a shock patient, right? A patient who is in shock. Now they asked you that what was the resuscitating fluid, right? They asked you about the resuscitating fluid. Now, guys, they I guess in the question they mentioned about a decreased heart rate and a fall in blood pressure. That was the main queries which were present in the question. Now, they didn't tell you anything about trauma in that. I suspect that they didn't tell you anything about trauma. So they, by trauma, I mean to say that there was not any history of blood loss. The patient was in, let's say, in hypovolemic shock, right? It was not majorly because of blood loss. So in those questions, I guess the options were normal saline, we had colloid, we had blood, and we had crystalloid. We had crystalloid, right? And in that crystalloid also, guys, they mentioned, I guess it was written as balanced crystalloid, right? Now, guys, let's keep this in mind. When they have not given anything in the option, in the question pertaining to any amount of blood loss, the blood option goes out, right? The blood option goes out. Colloid is a fluid which we give on later stages, right? The colloid is not the primary or the initial resuscitating fluid, right? So colloid again goes out of the option. Since normal saline consists of only sodium and chloride, it cannot be used as a first choice for any patient who is in shock. Now, what is a balanced crystalloid? Guys, they were basically trying to trick you. A balanced crystalloid is a ringer lactate. A balanced crystalloid is a ringer lactate. Now, why they have given a different option? Because they try to sort out, they want to take out the information from you that whether you know what a balanced crystalloid is. Now, I told you that the contents of ringer lactate, be it sodium, be it chloride, be it potassium, be it lactate, anything else, they are more or less in the physiological range which are present in a normal human body, right? So the answer to this question, if I am not wrong with the question, a patient who is in shock, has a decreased heart rate, has a decreased blood pressure with no history of blood loss, in those situations, balanced crystalloid solution has to be given. Guys, even if there was a blood loss, when the patient arrives in the ER, we cannot directly administer blood to that patient because we have to take the blood of that patient, go for cross-matching, and till the time we have to give the primary emergency treatment to that patient. And that is why we always give ringer lactate to resuscitate a patient who is in shock, right? Now, guys, let's move on to the next question. In that, it was given, the question was from ACLS, I guess. And they asked you which of the following drugs is not used in resuscitation. And from you guys, I have got a few options that it consisted of adrenaline, it consists of amiodarone, and one option was stating soda bicarb, right? Soda bicarb. So in the ACLS chapter, we talked about that we only have 2 drugs which we give in the ACLS. The difference between ACLS and BLS was that we do not give any drug in the BLS, but we give a few drugs in the ACLS column, and that is adrenaline and amiodarone. Yes, we have advanced airway devices and all those things are present in ACLS, but we do not give soda bicarb in ACLS. We do not give soda bicarb in ACLS. Guys, at the end of this discussion, if you have any query or if you have any other alternative or you have any other question or you have any discrepancy with these questions also, you can tell me, because these questions which I have got is, I know you all have tried so many questions. It's very difficult to memorize so many questions. But from the questions which I have got, I am telling you the best possible answer, which is correct for you guys. So in ACLS guidelines, we use adrenaline, amiodarone, and we do not use soda bicarb. So let's say pertaining to the questions, guys, these were the few questions which were basically a very straightforward question, right? These questions were very straightforward questions. The question which constantly bugged me throughout the day, because I got these questions from you students only, was regarding a case summary which was given, that there was a bicycle rider or a motor rider, I don't know what was that. He had an accident and he had a maxillofacial trauma. He had a maxillofacial trauma. Now, what is the method or the way to secure the airway of this patient? Now, guys, what I personally feel that this question was not formulated properly, right? Why? I will tell you why. Because in that question, let's have a look at maxillofacial fracture, right? Maxillofacial fracture. Now, guys, the options which I got from you people are, the first one was orotracheal intubation. Orotracheal intubation, right? The second one was nasotracheal intubation. The third one was a laryngeal mask airway. And the fourth one was tracheostomy. The fourth one was tracheostomy. Now, guys, why I want you all to have a look at this question is because the content of the question was not proper, right? Because if they just say that a maxillofacial fracture, what is the management? What is the next step in the airway management? Now, guys, whenever a patient has a maxillofacial fracture, we always suspect that the patient is having a cervical injury as well, right? And we all know that whenever we intubate a patient, we need to extend the neck extension has to be there, right? We have to manipulate the jaw of the patient as well. But if we extend the neck, flexion of the neck is there, then we are going to worsen the cervical fracture of that patient. Now, in this scenario, what I remember is that the student told me that the patient was already in the emergency room. That means the patient was already in the hospital. Now, if I'm intercepting the examiner properly, he doesn't want you to answer as orotracheal intubation, right? He doesn't want you to answer orotracheal intubation because that can be easily one of the choices. Now, guys, if a patient has a maxillofacial fracture, and if the base of skull is included, orotracheal intubation goes out of the column. If he does not, we can still try orotracheal intubation. Guys, I am telling you a very practical point of this question, but if I go inside the head of that examiner, I am sure he doesn't want you to answer orotracheal intubation. But if you go by higher standard textbooks of anesthesia, if a patient has a maxillofacial fracture, then and you know and you are sure about it that the patient does not have any skull fracture or the patient does not have any cervical injury, you can still go for orotracheal intubation. But in this question, I suspect that the orotracheal intubation answer is wrong, right? Now, out of these four options, LMA outrightly goes. LMA goes outrightly. It is not, LMA does not have a position that it can secure or it can have a definite airway securement, right? We all know that the supraglottic devices do not secure the airway, right? They do not secure the airway. Now, the discrepancy which has come amongst the students that they have basically marked either nasotracheal intubation or tracheostomy. Either nasotracheal intubation or tracheostomy. Now, guys, I'm again telling you, if I'm going inside the mind of that examiner properly, I would say that orotracheal intubation is the answer which the examiner is not looking for, right? LMA may be an easier option, which you can all check it out. Now, if you have checked out these two options, now the options which lie in front of you are nasotracheal intubation and tracheostomy. Now, guys, you have to keep this in mind. Yes, the tracheostomies can be done in an emergency setup as well. If a patient is in the ER, tracheostomy can be done over there. But it is an invasive procedure. We have to cut through the neck of the patient and then put a tube. Maybe we have enough time or not, because tracheostomy is still a time-taking procedure. Yes, the people who are, you can say, who are masters in tracheostomy, they can do it within 2-3 minutes. But the thing is, do we have so much time in a patient who needs emergency intubation, right? The patient can be full stomach also. I don't know what was the full question, but if a patient has met with a road traffic accident and then he has gone to have a maxillofacial fracture, then we are suspecting him as a full stomach as well, because we do not know what the patient had before, right? So that we cannot give long duration of positive pressure ventilation as well, because it will again lead to aspiration. It can lead to aspiration as well. Now, tracheostomy is an invasive procedure. Although it is a definitive procedure, but it is an invasive procedure. And depending on the condition of the hospital, depending on the staff which is present in the emergency department, nasotracheal intubation has to be the answer in this question. Now, why I'm saying this question was not correctly formulated, because if you see that the patient's oral cavity mobility is not there, that means he has very badly fractured his maxilla, his facial bones are fractured, but the cervical bone and the base of skull is intact. We have other options as well. That is fiber optic, guys. Fiber optic. I told you about fiber optic. Now, what is a fiber optic scope? It is as, let's say, it is not as thin as this pencil, but is not big and broad as a laryngoscope as well. Now, if we introduce the fiber optic through the mouth of the patient and we see the glottic opening, we can easily intubate the patient orotracheally as well. And then we can move on to have a tracheostomy, right? If we come to a solution that the patient might require a longer duration of ventilation, we can finally move on to tracheostomy as well. But orotracheal intubation can be done in this scenario as well. So again and again, I am telling you, don't get disheartened, guys, if you have done this question wrong. Yes, I would say if you have marked LMA, that is outrightly the wrong answer. The decision has to be made between three options, that is orotracheal intubation, nasotracheal intubation, and tracheostomy. Again, I am telling you that if the examiner has asked you this question, he doesn't want you to intubate the patient orotracheally, because he has straight away mentioned maxillofacial fracture. That means he is trying to avoid the orotracheal intubation, right? So we have to remove this option from this question as well. Now again, I'm telling you, nasotracheal intubation. Again, fiber optic can be used for orotracheal intubation, for nasotracheal intubation, for any kind of intubation. So that is why not a good question for you guys. But if I tell you, if I would have answered this question according to my knowledge of anesthesia, I would have marked nasotracheal intubation, because again, tracheostomy is an invasive procedure. We do not do that because the patient might regain consciousness. Let's say the patient needs to get operated and we operate the patient immediately. And let's say after 2 days of recovery, the patient is breathing properly of his or her own. Tracheostomy is required in those patients who are supposed to be or who are prone for long-term ventilation. So guys, if you have marked the nasotracheal intubation, I think that has to be the correct answer for you guys in this scenario. So I should say that amongst these 4 or 5 questions, if you have even mistaken this question, I would not ask you to just down your shoulders, guys, because the rest of the questions were straight away from the lectures only. Yes, I am a bit disappointed that they didn't ask much pertaining to the IV anesthetic agents, inhalation anesthetic agents, and the muscle relaxants. But as I told you that the exam pattern is changing day by day, and they are more concerned that you be well versed with the emergency situations, right? Like this question which we have, a patient with shock and all, MPC classification, what are the drugs you have to give in ACLS and BLS guidelines, right? And the straightforward question was of, yes, there was a question of Hoffman degradation. So I think they just mixed and matched everything, one from here, and one from there. So all in all, if you have done these questions correctly, I hope you will definitely go through your examination. I wish all the best for you guys. Guys, if you have any queries or any question in mind, just please tell me over here so that we can just rectify any of the doubts which you have over here. Guys, I'm open for all your questions.
So thank you, Dr. Sami sir, for a wonderful discussion. A very good evening, everyone. Good evening, everyone. Let me know in the chat box if you can hear me, you can see me. A very good evening, everyone. So happy to meet you, all of you, after the exam. So finally, the exam is over. So let us discuss some psychiatry questions. Good evening, everyone. Good evening. Right. So hope all of you are doing good. Hope all of you are doing good. So let us discuss. So you have done a lot of hard work in the past few months, and finally the exam is over. So it's time to relax and unwind yourself. Right. So we'll be taking up psychiatry questions. Right. Now is the voice. Okay. Good evening. Right. Speckov, just a nice name. Shweta, Rahul, good evening. Right. So let's analyze. So I'll just briefly analyze the paper of the questions of psychiatry. So what we could recall, a total of 13 questions I could recall. Good evening. Good evening. Now is the voice clear? Let me know. Now is the voice clear? Right. So just let me know if the voice is clear now. Right. There is voice is clear. Ashley is saying voice is clear. Right. So we could get few recalls. So again, I understand the paper was not easy, and despite the paper not being easy, we are able to get a good recall. So thank you to all of you for getting very good recall questions. So we'll be analyzing the psychiatry questions. Is it still breaking? Let me just check. Now let me know if the voice is clear. Now is it clear? Now is the voice clear? So what, yeah, it is not clear. Let me just check. Now, so we could get, right. So now is it clear? So all are saying now it's good, now it's fine, right? So let us discuss. So, again, we could analyze the psychiatry questions and we could see that, some of the topics from which the questions have come, again, they have repeated a lot of topics. Like we got questions from basic, 2 questions were there. In depression, again, there were 2 questions. Again, dementia topic was repeated, but again, it was a tricky question we'll discuss. Again, substance, they had a question. And as we always discuss, psychopharmacology again had a chunk of question in psychiatry. There was a tricky question, on Freud, we'll talk about that. And there was one image-based question. So few of the questions which I'll be discussing may have an overlap with other subjects, but I'm discussing here so that we can have an idea of all the questions. So again, as we said, these were some of the topics which were repeated. And again, as we say, these are topics which are repeating again and again. Right. So these were 2 tricky areas. We'll talk about these questions. One question on dementia and one question on Freud, which, again was tricky. Let us again, see. So overall, when I see the paper, again, there were some easy questions, but yes, there were some tricky questions as well and some difficult questions as well. So overall, I would say it was a moderate paper. It's not very easy. Okay, so it was a moderate paper. So let us discuss. So I'll be discussing these recall questions which we have got. Any changes, any options, you would think that it was not there, please let me know. So let us discuss the first question. So this is the first question which we had, all of the features of pseudo hallucination except. So please have a look at this question and let me know if these were the options. So the options were, it is vivid, not under voluntary control, occurs without stimulus, and perceived in outer or objective space. So this was the question, recall question we could get. Are the options correct? Let me know in the chat box, are the options correct? So pseudo hallucination, again, it's a concept we have discussed in perception. It's an important concept. Again, I would say fairly simple question. So just let me know if the options are correct. So what is the answer of this question? All are features, you have to tell except which of them is not a feature of pseudo hallucination. So we know pseudo hallucination and hallucinations, these are abnormalities of perception, and we know both of them are false perception without any real object. Very good. So yes, the options were vivid, voluntary, in objective space. Very good. So both of them are false perception without any real object. For example, a person is seeing something, it is not there, hearing something, it is not there. And both of them to the patient are very clear and vivid, and they are independent of the will of the patient. That means they are not under voluntary control of the patient. So both pseudo hallucination and hallucination have these characteristics. So what is the difference? What is the difference between them? So the difference is hallucination occurs in the outer objective space. So person is experiencing hallucination outside in the external space. While we have discussed, pseudo hallucination occurs inside the mind. So it occurs in the inner subjective space. This is one very important difference again, and they've asked this question. So what will be the answer of this question? So we know that pseudo hallucination is vivid. It is not under the voluntary control of the patient. It occurs without stimulus. Yes, there is no real object. It is perceived in the outer objective space. No, it is perceived in the inner subjective space. So this is the answer of this question. I hope all of you got this question correct. So this is the answer, right? Right. So again, I would say it was again a simple question. Let us talk about the next question. So let's come to this next question again from the basic. So the question was, a patient presents with sudden irresistible urge to take some action. Which of the following symptom is seen in the patient? So you have to identify the symptom. Again, a lot of such questions they are asking in the exam. So please see what will be the, are these options correct? Are these options correct? Let me know. So pseudo hallucination, I hope that question number 1 is clear. Let me know if the options you're thinking is not there. So just let me know. Very good. So it's a sudden irresistible urge to take action. What is that known as? Very good. That is impulse. So we have discussed, in impulse control disorders, we have discussed that what is an impulse? It is a sudden irresistible urge. So of course we know delusion, it's a disorder of thought. It's a false, fixed, firm idea or belief. Hallucination and pseudo hallucination we have already discussed. These are disorders of perception. So the answer here is impulse. So the answer here is impulse. Is it clear to everyone? The answer here is impulse. Right? Right. We'll just check about the connection. Now is it clear? Right. Now I think, now am I clear, audible and visible? Let me know in the chat box. All good, right? So this is the, right. Now is it good? Let me know. So this is the second question. I hope this is clear to everyone. The right answer of this question is impulse. So it's an impulse. We have discussed in impulse control disorder. Even when we are discussing schizophrenia, when made impulse, these are sudden urges to take some action. Okay, even in OCD, patient can have repetitive impulses. Is it clear to everyone? This is the second question. So I would say this was also a fairly easy question. I hope you all got this right. Right. So right, great. So now this is the third question. Which of the following is a key feature of depression? Was this the question? So because we got different versions of this question, was this the question, that which of the following is a key feature? Key feature, hoarding disorder, abhi A, it comes under obsessive compulsive and related disorder now. Okay, it is now put under the category of obsessive compulsive and related disorder. Right? Great. So this was the right answer, right question. And what were the options? The options are loss of appetite, loss of interest in pleasurable activity, suicidal thoughts, and low mood. Low mood. Is it clear? Right. Right. So let me know, are the options clear? These were the 4 options in the question. What are the key feature of depression? So tell me, what is the answer of this question? So we have already discussed, we always discuss depression is a mood disorder. Sleep disturbance, you are saying, okay, sleep disturbance was there. Sleep disturbance was also there. Okay. So we'll try to frame the question. Okay. Okay. So what is the correct answer? So basically it's a mood disorder. So which will be the key feature of this? The key feature of this will be low mood. Very good. The key feature will be low mood. So sleep disturbance was also there, but if you have to choose one, so we have discussed this in the symptoms of depression. We have talked about this, that these are the symptoms. We have talked about this with the mnemonic size caps, and we know that these are the 2 important symptoms: sad or depressed mood and decreased interest, that is anhedonia. But if you have to choose one, then it is sad mood. That is the key feature of depression. If low mood was not there in the option, okay, yes. So we are getting some. Right, so we got some version in which they said that the low mood was not there. If low mood is not there, so this will be the preferred answer. If low mood is not there, then the second best answer would be loss of interest in pleasurable activity, that is anhedonia. Is it clear to everyone? If low mood was not there in the option, then the second answer will be anhedonia. Yes, correct, very good. Yes, Vishnu, Dreamer, Ashley, Tejasvi, Abhi, very good. Yes. Is it clear to everyone? So if low mood is not there, then the second best answer will be loss of interest. Yeah. So speck of dust, yeah, just we have discussed, if low mood is not there, then the second best answer will be option B. So this was the next question. Let's talk about this again, a very straightforward question. Look at this question. Tell me if this was the language of the question. Right. So we'll try to answer if the options are different. So I'll try to give you the answer if the options are not the same as we are discussing. Is it right? Right. So 30-year-old female presents with symptoms of sadness, loss of interest, decreased sleep and appetite for 2 months. So they've given you the symptoms and they've also given you the diagnosis. The diagnosis the psychiatrist has made is of major depressive disorder. So the question is, which is the appropriate treatment to be started? Very good. So what is the answer? Again, I think it's a straightforward question. The patient is having major depressive disorder and they're asking you the drug of choice. They're asking you the drug of choice. Very good. So very good. Jithan, very good. Abhi, Siddharth, Dr. Abhishek, Rakesh, very good. The answer is very good. The answer is fluoxetine. We know the SSRIs are the drug of choice of depression. Very good. So this is, I think, again a straightforward question which came in the exam. Now again, this is a question we have been discussing. So in all our discussions, we have talked about this question, and now again this question has been asked in the exam. So tell me if this was the exact question. So Vishnu, illusion, you are saying that illusion tha, impulse nahi tha. So I'll have to check, because many students are saying that it was impulse was given. So I'll check, I'll get back to you. Okay. A female presents 5 days after her delivery with symptoms of low mood, irritability and decreased sleep. What is the likely diagnosis? Very good. So we have been talking about this, question again and again, that they are asking a lot of psychiatric abnormality related with pregnancy. So we have discussed this table again. So this is postpartum blues. So we know the symptoms have started within 5 days of delivery, and the symptoms in the question, again you can see they have been not very severe. Mild symptoms have been given. Transient symptoms of sadness, irritability, decreased sleep may be seen in postpartum blues. Very good. So the correct answer is very good. The correct answer is postpartum blues. This was a question which was asked last year in NEET PG in 2022, and again now they have asked in FMG in your exam. Very good. Is it clear? Very good. Usually when they will talk about depression, they will talk about symptoms such as, anhedonia, excessive guilt, suicidal thought. Those symptoms may be given, and they may give you a duration as well. Okay. So we know in postpartum blues, there is no specific treatment required. Reassurance is enough. Okay. Supportive management is required. So I hope the answer is clear to everyone. This is postpartum blues. Okay. Very good. The answer is postpartum blues. Manic depressive was in the option. Postpartum depression, even if it was manic depressive, then also, so let us say you're saying it was manic depressive illness was given, then also the answer will be depression plus psychosis. Again, that will not be there because no psychotic symptoms have been mentioned. Very good. So the answer remains postpartum blues. I hope this is clear to everyone. Let me know. So again, this question also very good. This question also, again they are repeating these questions. Again we have been discussing this. So again, I think this question also was fairly easy. Okay, great. Let's come to the next question. A patient developed sudden hypertensive episode. So now one psychopharmacology question. While taking wine, he is suffering from a psychiatric illness and he is on some medication. And they've said he has taken wine, developed hypertensive episode. Which drug is most likely to cause this? So what is the answer? Yeah, I agree. The question was not, some of the questions were not very easy. I agree. Right. So yes, it is cheese reaction. Very good. It is cheese reaction. And which is the drug? We're talking about? Which is the drug the patient is on? So Bhuvanesh, right. It is Dr. Abhishek, right. Okay. Right. So what is the drug? Right. So the drug is MAO inhibitors. Very good, Dr. Abhishek. Very good. Yes. All of you are correct. It is MAO inhibitors. So we know monoamine oxidase inhibitors, they can cause cheese reaction, that is tyramine induced hypertensive crisis. So just briefly, we have discussed in the video as well in the app. So just briefly I'll discuss. So people taking cheese, beer, fish, red wine, they contain tyramine, and tyramine is sympathetomimetic, which is metabolized in the GI tract. So when the person is taking MAO inhibitor, it inhibits tyramine metabolism. So basically tyramine come into the blood and it causes hypertensive crisis. And again, we use treatment alpha antagonists such as phentolamine may be used. So this is cheese reaction. Very good. So the answer of this question is option C, MAO inhibitors. Very good. Now let's come to the next question. Now look, this is fairly, again, it is not an easy question, I would agree. So let's look at this question. Which of the following dementia may present with Capgras syndrome? Were these the options? Please have a look. Okay, you're saying MAO inhibitors was not in the option. Okay. Okay, so right. So okay. So I'll get back to you. You're saying SSRIs, SNRI, TCA. Okay. Very good. So what will be the answer of this question? Again, I agree it's not a very easy question. They are asking again. So if you have to make a guess, we have been discussing, in our previous sessions, I've been talking about that there is one dementia which they are again asking a lot of questions. So if you have anybody guessed any answer in this? So which you have picked? What is the correct answer? The correct answer in this question is, again, I agree it's not very easy. Okay, you might have got it wrong. So the correct answer is, okay, Binswanger, yes. Okay, you are saying Yes, one of the option was Binswanger's disease. Again, it's a vascular dementia only. Okay. Okay. So let's keep that as well. So what is the correct answer? If to make a guess, we've been discussing this Lewy body dementia. So many times patients with Lewy body dementia may present with Capgras syndrome. We have discussed what is Capgras syndrome, in which patient believes that a close person has been replaced by a stranger. It may be seen in Lewy body dementia. It may be seen in other dementias such as Alzheimer's also, but it may be seen in Lewy body dementia. In fact, this, although I agree it's a difficult, we have, although in the main section videos of our app, we have, I've talked about this when I was discussing Lewy body disease. I was talking about Lewy body dementia. We talked about this, that Capgras syndrome may be seen in these patients. So the correct answer of this question is Lewy body dementia. Right, correct. So Lewy body dementia, we have talked about, it has 3 core features: fluctuating cognition, there is visual hallucination, and motor features of Parkinsonism. Even Capgras syndrome may be associated with Lewy body dementia. So the correct answer is D. Now let's come to the next question again. Fairly, I would say, again, it's a simple question. The topic again has been repeated. They're asking which of the following are side effects except. Let me know if this is the answer, if this is the options: hypothyroidism, diabetes insipidus, tremor, tardive dyskinesia. Are these the options? So let me know if these are the options. Very good. So the correct answer is, so we've been discussing, very good. So I hope all of you got this correct. Hypothyroidism can be seen with lithium, even hyperthyroidism can be seen. Diabetes insipidus can be seen, and in fact for that we give treatments such as thiazide diuretics, potassium sparing diuretics, which was asked previously in the FMGE exam. Tremors can also be seen, and we know, we have discussed a lot, the drug of choice is beta blockers such as propranolol. So these are all side effects which can be seen. Less likely is tardive dyskinesia, which is a side effect which is seen with antipsychotics. Very good. Very good. Yes, instead of diabetes insipidus, it was nephrogenic. Again, correct. So that can also be the option. It was nephrogenic. Okay. So we know nephrogenic side effects can occur. Okay. Polyuria and subsequently diabetes insipidus can occur. Very good. Is it clear to everyone? Right. Yes, exactly. Great. So I hope Hani, Durga, Abhishek, Abhi, Dr. Bhavan, Harendra, very good. So all of you have marked this correct. Now let's come to this again. It's a repeat question again and again. They're asking this topic. So let's again see this question. A patient of chronic alcoholism presents with symptoms of confusion, ophthalmoplegia and ataxia. What is the likely deficiency in the patient? So what is the correct answer? Can you tell me what is the diagnosis? What is the diagnosis? Very good. Dr. Abhishek, Bhuvanesh, very good. Dr. Metrorit, very good. Subhikesh, Diksha, Abhi, very good. All of you. Right. So we will, what is this? It is, again, we have talked about this. This is Wernicke's encephalopathy. Very good. This is Wernicke's encephalopathy. We have talked about this with the mnemonic Goa, global confusion, ophthalmoplegia and ataxia. And it occurs because of deficiency of vitamin B1, that is thiamine. Again, it's this topic they have been repeating again and again. So this is the answer. I hope all of you got this correct. Very good. Very good. Right. So there were some questions. I'm sure that, when you saw those questions, they were easy to answer in the exam. Right. So this we have discussed, beta. Wernicke's encephalopathy and Korsakoff syndrome can occur. They are alcohol-induced neurocognitive disorders. And for Wernicke's encephalopathy, global confusion, ophthalmoplegia and ataxia are the symptoms. And thiamine deficiency, vitamin B1, and treatment is thiamine. Is it clear to everyone? Very good. Yes. Right. Clear. Very good. Let's come to the next question. Again, this was, I would say, not an easy question. This question was tricky. A patient having stubbornness, frugality and rigidity, and according to Freud, psychosexual stages of development, fixation is seen at what stage in this patient? Tell me, was this the question? Tell me, was this the question? First of all, tell me question. It was like a clinical case. Okay, so you're saying in this question, the question was that to prevent it from going to Korsakoff, you are saying to prevent it from going to Korsakoff, what management you would do? Again, we know that Wernicke's is acute and Korsakoff is a chronic sequelae. So then also what you will do to prevent it from going to Korsakoff, you will give thiamine, right? Is it clear? I hope it is clear, Abhishek. What would be given? It would be, yes, it would be, right. So it would be thiamine only. Now this question, yes. So this was the exact question. Let me know. this question is exact. Okay, so we know that there is 5 psychosexual stages of development given by Freud, that is oral, anal, phallic, latent and genital. So according to Freud, everyone goes through these stages, but if there is arrest at a particular stage, there is fixation at a particular stage, there may be some abnormalities. For example, very good, if the person is fixated at oral stage, the person may develop schizophrenia, substance use disorder. So fixation at anal stage can lead to OCD and even obsessive compulsive personality disorder or its traits. So basically, so again, it's not a very easy question, I would say. So they're talking about some of the OCPD, obsessive compulsive personality traits. So the patient has developed stubbornness, frugality, rigidity. So the correct answer here is B, anal stage. The correct answer is B, anal stage. I hope it is clear. Again, it's okay if you've not got this correct. A difficult question, I would say, right? So this is the question. Now coming to the next question, now let me know what is the question here. A patient buys alcohol from a local shop and presents with symptoms of drowsiness, ataxia and blurred vision. Which of the following is the treatment? Great. Right. So Vishnu, great. Sometimes, you get questions right. Great. Right. Okay. So is this question, let me know. First tell me, was this the same exact question or were there any changes? Let me know. Was this the same question? And see the options as well. The options are naloxone, diazepam, flumazenil, ethyl alcohol. Okay, urethral stage was one of the options. Okay. Okay, so we'll still go with oral stage. 2 liters of liquor was mentioned. Okay, they mentioned the 2 liters. Okay. Okay, it was mentioned. Okay, so I mentioned that. Okay, abdominal pain also you're saying was mentioned, abdominal pain. So both flumazenil and ethyl alcohol, both the options were mentioned. Okay, Simbu. Okay, so basically, so oral, anal, these are stages, psychosexual stages which are been described by Freud. Okay, so if both the options were mentioned, then what will be the better answer? So what they are trying to say, so he got, from a local shop, it seems to be a case of methyl alcohol poisoning. So basically, when methanol is metabolized in the body to formaldehyde by alcohol dehydrogenase. Let us try to understand the concept first and then we'll come back to the question. So methanol is metabolized to formaldehyde and subsequently it is metabolized to formic acid. And these basically formaldehyde and formic acid, they produce symptoms such as GI distress, visual disturbances, loss of consciousness, coma, because they cause severe ascidosis, retinal damage to the patient. They are toxic for the patient and this leads to these symptoms. So the patient is having methanol poisoning. So in the treatment of methanol poisoning, so what we do is, in the treatment of methanol poisoning, we give IV fomepizole. So what does IV fomepizole do is, it inhibits alcohol dehydrogenase. So it does not allow methanol to further metabolize and prevent the occurrence of these toxicities. There is one more again, so preferred treatment would be fomepizole, but sometimes ethanol can be used as well, because ethanol also uses the same enzyme, alcohol dehydrogenase. So it also uses the same enzyme. It has higher affinity in fact for ADH, for this enzyme. So it's a competitive inhibitor. It's acting as a competitive inhibitor for the oxidation of methanol. So ethanol can also be used, but if both the options are given, then we would go with fomepizole. Now let's come back to this question. Now if both the options were given, then the answer would be, so flumazenil is there, then if fomepizole is also given, then the answer would be fomepizole. Okay, then the answer would be fomepizole. But if fomepizole is not given in the option, then the answer would be ethyl alcohol. Is it clear to everyone? So was fomepizole also given in the option? Let me know, was fomepizole also given in the option, or these were the correct options which we have discussed? Was not there. Very good. Then the answer would be ethyl alcohol. Very good. So is this clear to everyone? Then the answer would be ethyl alcohol. Correct? Is it clear to everyone, beta? Right. Fomepizole was not there. So then ethyl alcohol would be the answer. Very good. Now let's come back to the question. So this is another question. Which of the following is the treatment of benzodiazepine overdose? benzodiazepine overdose. So what? Please check the options. So the options are naloxone, atropine, flumazenil, and physostigmine. So basically, benzodiazepine, the receptor of benzodiazepines are located at the GABA A receptor, and they increase the frequency of GABA mediated chloride ion channel opening. So this is the action of benzodiazepine, and generally what is the treatment of benzodiazepine overdose? We use flumazenil. Which is the antagonist at the benzodiazepine receptor. So it reverses the CNS effects of benzodiazepine. So it's a straightforward question. So the answer is flumazenil. Is it clear to everyone? Very good. Is it clear to everyone? So these were some psychopharmacology questions which we are discussing. Now, last question. So last question in psychiatry. Now again, I'm discussing this question, although it is more of a surgery question this time. Although earlier we have discussed this question in the past. Earlier this question was more of psychiatry. But since this question, a similar question has been asked previously, and I'm sure we have discussed this question in the surgery discussion as well. So this was the question. Identify the image. So this image was given. So can you recognize this image was given in the question? And a similar question, a PYQ was also given, previously also that given a similar image. So there is the shape of the stomach, the mass of the hair has taken. So what is this? Very good. So this is trichobizoid. Very good. So this was the question. So since this was, previously asked, they had asked this question that a surgeon has taken out this mass of hair from the stomach of the patient, and to whom would you refer the patient to? So in that question, the answer was psychiatrist, because maybe the patient is having trichotillomania and he is swelling the hair and this mass is collected. So this is another question which I have discussed. Right. Second image is exactly there. Okay. This was, I think, previously also asked. So if you were saying that this was the exact image, then again, this is trichobizoid. Is it clear to everyone, beta? So we have discussed around 13 questions, and I would say around 8 to 9 questions were fairly easy, but yes, some of the questions were difficult, some of the language was difficult. So this was about psychiatry discussion. If there is any other question, if there is any other option, you can always message us. We'll try to get a better collection of the questions, and then we'll have that discussion. Okay. In the stages, we have oral stage, anal stage, phallic stage, there is latent stage, and then there is genital stage. So Freud said that every person goes through those stages, and if fixation occurs during those stages, then there may be some abnormality which may develop in the person. For example, in oral stage, the child gets gratification by taking everything through the oral route. In anal stage, the child gets gratification by through the anal area. So this was Freud's psychosexual stages of development. Not commonly we discuss these days, but again, it's a old question, and they have asked some trickiness. They've added some trickiness in that question. Okay, so that was the question. Which question the option were different? Which organ? Yeah, I agree. SK Sabhi, yes, I think yes. So if impulse was not there in the option, then we have to again recheck that question. Okay, so I'll get back to that question again. If we have again, I'll collect all the options again and we'll recheck. Yes, I agree. One, first was, difficult. Yes, I agree. Now, just few tips, those future examinees which are, seeing the discussion again. Concepts are very, very important, and PYQs or the topics, again, some of the topics have been repeated, not all, but some of the topics have been repeated in the question. Right. So, thank you everyone. Now, relax. The paper is done. We'll try to have, again, a better recall. We'll try to have a correction, if required, and we'll give you the questions again. Okay, impulse was there, I think. Okay, many are saying. Okay, right. So thank you everyone. Thank you. Relax, and all the very best for the result. Thank you everyone. Thank you guys. Thank you.
Good evening. A very good evening to all my dear students. How are you all? Tired? So much of information in such a small time, so many discussions and recall going on. And of course, lot of worry. Kaisa hua? Kaisa kiya? Kya hoga? Right? Okay, so let's relax. Yeah, good evening everyone. Can we focus on ophthalmology now? Okay. So ophthalmology, see, the purpose of discussion, I'm not going to make it too long. We are here to recall and try to find out what is the correct answer. And of course, to self-reflect whether we missed something or we have studied all the things and how to go about in the future as well, right? So that is the purpose of the recall here. Okay. No worries. Let's see. Let's hope for the best. Let's start with the first question in Ophtha. Sabhi, there is no need to be scared. What is done is done. Be a lion. Come on, let's focus on what was asked in ophthalmology. Okay, so we start with a disclaimer. We all know these are not exact questions and these are all based on recall, right? So the first question that I got was something like this. I will read it for you. A patient has a field defect where he cannot see on the left side from the left eye and left side from the right eye. So from both the eyes, same side he cannot see, right? So it becomes which type of field defect? And there was a preserved central vision. What have you answered here? Can you all answer this for me? Come on, let's talk. What have you answered? So if I write here, this is the left retina and right retina, or maybe this is the field of the left eye and the right eye. Let's say like this. Very rough diagram here. We are saying on the left side he cannot see, right? But we are also saying there's a central preserved vision, right? So what is this I have drawn? I hope this was the language of the question. This is what I got. Question was different. Okay, so can you share what was the question exactly? Anyone remembers what was the question? Okay, so one message is very, very clear here that we have to be thorough with neuro-ophthalmology. So whatever questions that you could all recall and share with me based on your ophthalmology, 2-3 questions, neuro-ophthalmology. Right eye left side is and the left eye right side and macula pairing. You have how can this be possible? So there has to be some mistake in your recall. Do you think so? If we are talking about visual field effect, let me discuss this first. Let us sort it out. It was left side of the right side, okay, if it is something like this, that you are saying this is the left, chalo, I'll draw it for you. You are saying it is opposite, right? You are saying something like this. It was left side of the left eye. Left eye ka left side is gone and right eye ka right side is gone. If this was the case, then this is heteronymous. If same side was gone, then it is homonymous hemianopia. Now you all have to decide what was asked. If it was left eye ka left side, right eye ka left side. Now it becomes your shaded part is the one which is gone, so it becomes a homonymous hemianopia of the left side. So that was the exact image. Which one? Okay. See, macula sparing, they cannot ask you in a heteronymous hemianopia general. Okay, we are learning about occipital lobe lesion where you get a macula sparing in is associated with homonymous hemianopia. You have learned in my lectures that it is due to blockage of posterior cerebral artery, right? Macular area is mainly supplied by middle cerebral. So if posterior cerebral artery is blocked, then the macula is spared. In that case, then we will have to have something like this picture. Macula sparing, it has to be like this. So maybe we are recalling something wrong there. And okay, so Manoranjithan, can you please tell me which one was the exact image, number 1 or number 2? Which one you are talking about? Okay, so if it was Dipanshu, nasal side of both eyes, again it will become heteronymous, isn't it? Okay. So in that case, if that is the case, then they are asking you about the heteronymous hemianopia. So just be very, very clear that you have to be very thorough with your visual field defects. Okay. So we have to be very, very careful with the visual field defects. Yeah. This is not the point. I'm not in a mood to revise and teach you the whole visual field effect. If you want, you can refer my earlier sessions on the YouTube. It is there. I have discussed in a lot of detail, and you all must be going through my video lectures. At the end, I'm going to just show you that, see, when we say it was difficult, it was difficult, it was difficult, let's really reflect. Was it taught in the class? If it was, then why it is difficult, right? So first of all, let's focus on the questions, and then I'm going to talk to you all about it. So ये तो पहला question था. That was about the visual field effect. Please be very, very thorough with this topic in the future as well. Okay, we come to the next. Though the confusion is still persisting, but this is what I get. And if it was homonymous with macular sparing, that could be the answer. If this is the language of the question. If you all say, no, this was not the language, then we conclude maybe they have been asking you a heteronymous hemianopia. Heteronymous hemianopias are mainly chiasmal lesions. The only lesions which are heteronymous are chiasmal lesions. ठीक है? चलो आगे बढ़ते हैं. Let's move ahead. Then this was a one-liner. So another message for you all, there will be clinical questions, but there will also be one-liners, always. Whether it is FMGE, whether it is INI-CET, whether it is NEET PG, in ophthalmology, one-liners, we cannot avoid. Okay. So what is the most common? So I generally teach you in the lectures about Qs and double Qs. That's nothing but those one-liners, right? So what is the most common intraocular tumor found in adults? So when you say intraocular tumor in adults, we all know, of course, there should have been one more word, whether it is primary intraocular, primary malignant intraocular. So if it is so, if we say primary malignant intraocular, let us add this and then try to understand. Then of course the answer becomes no. But hemangioma, Sabir, will be intraorbital, not ocular. Okay. So when it is saying intraocular, eye ke andar, not in the orbit, then in children we all know that we are talking about retinoblastoma, and in adults we are talking about, see, two options. One, choroidal melanoma. Whether metastasis was given or not, nobody is clarifying me with this, but both can be the answer. So primary is less common, otherwise metastasis is considered even more common in adults. So it could either be choroidal melanoma or it could be metastasis. Were both given or not, you all can tell me. Can you all enlighten me with this? अच्छा, अगर metastasis नहीं था तब तो और आसान हो गया ना. Then the answer is choroidal melanoma. So if metastasis was not the option, let's forget it. Then there is no confusion at all. So most common intraocular tumor in children, primary malignant. That word should have been there. Then it is the retinoblastoma. In adults, it is your choroidal melanoma. Okay. Don't say uveal melanoma. Uveal can be iris, ciliary body, and choroid. You have to specify choroidal melanoma. एक और चीज, sorry, एक और चीज, if it is intraorbital, one of you were mentioning about hemangioma. If it is intraorbital, then most common intraorbital, do you all know? Intraorbital tumor, most common malignant intraorbital, or is it benign? Again, that has to be taken care. If it is benign, then Sabir, hemangioma can be cavernous hemangioma. Okay. So if I talk about benign in adults, it is cavernous hemangioma, and in children, it is capillary hemangioma. For children, it becomes capillary hemangioma. If I talk about benign tumor. Okay. So for children, it is capillary hemangioma, and for adults, it is cavernous hemangioma. I think it's clear now. And malignant, do you all have all the idea about malignant? Let me rub this. It's becoming little. Let me rub this. Okay. Now, what about malignant intraorbital? Let's discuss that also. If it is intraorbital, and if we talk about malignancy, then for children, we will learn rhabdomyosarcoma, R and R, okay, retinoblastoma, rhabdomyosarcoma. And for adults, what do you know? Lymphoma, right? Then they have asked you which lymphoma? It is non-Hodgkin's lymphoma, B cell type. These are all different questions. Okay? So a little more information around it because one of you mentioned about hemangioma. So here the answer is clear cut. If there was no metastasis, we are going to answer choroidal melanoma. Okay. If the options that you all are giving me were neuroblastoma, rhabdomyosarcoma, retinoblastoma and melanoma, our answer will be melanoma because we are talking about asking, the question is about adults. Okay? No confusion? Right? Okay? Yeah. So if these are the options I'm getting now, all of you are listening, neuroblastoma, rhabdomyosarcoma, retinoblastoma and melanoma. So our answer is melanoma. I think it's a straightforward question, not much to discuss. Okay? We go to the next one. Okay, so this is a patient who is working in some iron factory and he's getting iron inside the eye. What is iron inside the eye known as? This is one of the simplest questions. Common sense. He is found to have some visual disturbance and iron deposits in the eye. So, what is it? Of course, siderosis bulbi. Did we not learn that siderosis bulbi will be presenting as? It starts as lens pigmentation. Then there is iris pigmentation, lens deposits, you can say, not pigmentation, let's say lens deposits, you know. So it will lens deposits, iron deposits on the lens. Then there is iris pigmentation, these deposits in the iris, they look pigmented. And finally, there will be retinal involvement, isn't it? And there is retinal involvement and degeneration. Okay? Electrolysis ki wajah se, now because of the electrolytic dissociation, it is actually interfering with the function of the retina. And this is a very important question. Let's learn this question at this point, that how do you monitor a siderosis? Intraocular foreign body, how do we monitor the siderosis? What is the damage going on? Then whether it is going fine or the damage is actually progressing, we look at serial electroretinogram. I have discussed everything in the class. Serial electroretinogram, what is generally affected is the B wave. Do you all remember this? So, electroretinogram has A wave and B wave, right? A is for rods and cones and B for bipolar and molescence. So, B for B, these B waves are affected and this is normal. This is a normal ERG I am showing you just for a quick revision. But in case of siderosis, it starts flattening, right? So, amplitude will be low or less. Okay? What about this question, all of you? Yeah, so it is siderosis. Why Kayser-Fleischer ring? Kayser-Fleischer ring is copper deposition on the Descemet's membrane of the cornea in patients of calcosis, which is nothing but copper inside the eye. है ना, दो चीज ही पढ़ते हैं. One is your sunflower cataract and Kayser-Fleischer ring, right? Okay. One more thing, if you all are in a mood to learn a little bit, I'm not sure, you're so saturated. So you should also know that what is Fleischer's ring, you know, that is iron deposition in patients of keratoconus. You should know the different iron depositions. I have covered in my lecture, just revise it for your further ventures. Okay? Yeah. We come to the next question. In which type of cataract, was this the question or not? First, you all have to guide me with this. So this is a question where they have asked you that where will you use these sutures? Tell me, where do you use the sutures? Everybody knows. Great, Aishwarya. Awesome. So, can you tell me? Happy to know that the PYQ videos were of so much help to you all. So, actually, the things are the same. Only thing their way of asking can be a little tricky. You have to be thorough with the subject. So, I don't understand what you all are talking about here. The question in this case I am getting is, in which type of cataract surgery is suturing done with nylon 10-0 commonly performed? Was this the question? Okay, this is SICS or a manual incision. This is SICS only. So, of course, we know that suturing will be done in ECC and suturing is done in ICC. Right? Baki mein, we generally don't use any sutures, we give self-sealing insertion. This was one of the most basic question one could have asked if this was the case. Isn't it? Do we use sutures here? No. Okay, if the question says for hard cataract, we all know that it is very challenging to do phaco in a hard cataract, right? So again, this could be the, and I think it just came to my mind, I haven't written the question, but was this asked that what is the dye used during cataract surgery or in the anterior chamber, something like this? There was a question. So I hope you all know when there's an over mature or hyper mature cataract and you cannot see the capsule, which dye do you use to stain it? It is trypan blue. Okay? So trypan blue. This is how we stain the anterior capsule. I'm not sure whether this was your question or not. It came to me flying somewhere. Maybe this was also asked. Yeah. So if that was the question, why are we using any dye in the anterior chamber? That's only during cataract surgery. You cannot see the anterior capsule. How will you do the capsulotomy and how will you do the capsulorhexis? For that, you use the dye and that is your trypan blue. Okay? So that amounts to around one more question in your record. You should note it down. This was also there. I haven't written it as a question here, but I remember this was asked. Good. So, and what was the question? Can you also tell me, it was this only, na, that where this is commonly performed or sutures are used? If that was the case, in that case, I don't think anybody has any confusion about this. Okay? Okay. Good. We come to the next question. So this was a patient, I don't know whether this was the image or not, but just for helping you all out, I have included this image. A patient of HIV with low CD4 count presented with the following. What is the treatment of choice? We all know what is the most common opportunist infection in HIV. Most common opportunist infection we all know is CMV retinitis, right? And in CMV retinitis, what do you know here? What are you looking at? इसको क्या बुलाते हैं? इतनी सारे जो hemorrhage है and these are exudates. So this is what is sauce and cheese retinopathy, right? So this is your sauce and cheese retinopathy. So was this the image? Okay, if the pizza pie or the margherita pizza look is little different from what this image is. But anyway, both are feature of your CMV retinitis. Okay? So CMV retinitis was given, and what is the treatment of choice? I think we all know it is intravitreal injection of ganciclovir. So this should be the answer. There is no confusion in this. Everybody has answered this? Yes, Devasi, that was correct. It was ganciclovir only. You chose the correct. Okay, even if it was any other option, Subramaniam, like trimazole or anything, but you know that ultimately we are talking about antivirals here, and therefore we should be answering ganciclovir for CMV especially, right? Okay. Now I could discuss more questions around HIV, but let's move further for the next. Let's control here. We have to just recall things, right? Then we come to this one. I think this was also your question. Oil droplet reflex or oil droplet cataract is a feature of, this is the easiest question you could get in ophthalmology, guys. So what is oil? I don't have the options here, so I have written only one. So ganciclovir is the one which can be given intravitreally, and we should choose that as the treatment of choice for CMV. Okay? Yeah, so we all know that oil droplet, so this is your oil droplet cataract. I just included the image to remind you all what is oil droplet. Oil droplet reflex also looks something like this. I hope you all know all the oils. I have taught you all the oils in the lecture. One is oil droplet cataract, which is seen in galactosemia. Okay, can you all tell me one thing? Which enzymes deficiency in galactosemia can lead to oil droplet? Not every enzyme deficiency. Galactokinase deficiency causes lamellar cataract, and it is mainly G-put deficiency which is going. What is G-put? Galactose phosphouridal transferase. Iski deficiency se what do you get is your galactosemia. Okay? What do you get is, oil droplet cataract. Okay? In galactosemia. Yeah, very good. So, and if it is a galactokinase, then we get a lamellar cataract. You can add this to your knowledge if you have forgotten. That in galactokinase deficiency, okay, then what you get here is lamellar cataract. Okay, all of you, can you answer me? Where do you get oil droplet reflex? We get in keratoconus. वो तो ठीक है. On how do you see this reflex? Please don't forget, it is distant direct ophthalmoscopy. By distant direct ophthalmoscopy. ठीक है? And one more thing, should I write it here? What about oil droplet, oil globule? The third oil is oil globule reflex. Answer me this one before I move further. Tell me. Diksha, keratoconus, very good. And oil globule reflex. चलो फिर next question पे चलते हैं, जल्दी से बताओ. Oil globule reflex, we will say anterior lenticonus. Okay. From how do you see it? We see it under slit lamp. I've shown you all these images in my lectures. Just have a look at it. Okay, we come to the next. So was this a question here where they had asked you that what drug are you going to use for a child? So what is the choice of cycloplegics in children of less than 8 years? It is always the strongest, atropine. They can ask you drop or ointment. It is always ointment. Drop, why? Because it stays for a longer time. How much percentage? 1%. So it is 1% atropine ointment, which is, and this also has to be given thrice a day for 3 days if you want a complete cycloplegia. Okay. So, right? Okay. I'm coming to the papilledema question, Akif. Just look thoda sa. Okay. So, atropine ointment 1%. Okay. Yes. So, we want a complete cycloplegia. No accommodation should be exerted, and then you are going to find out the refractive error in this patient. Okay. Was this also a question here where they had asked you the question on abnormal pupillary reflexes, that light reflex is absent, near reflex is present? No, it's not 5 years, Dr. Saurabh. It is 8 years, 7 to 8 years preferred choice. Though practically it is not so easy to keep giving atropine, but theoretically when you are answering, you have to answer according to that. Not 5 years. Okay. We'll answer. If you said 7, I would have agreed with you, because some places it is 7 years, some places it is 8 years, but not 5 years. Okay. So less than that, we have to always give atropine. Okay. Marcus gun pupil was asked, Debasi? Now, Manisha, tropicamide you will not give, na? It is the shortest and is not that we have to give the strongest drug. That is why strongest cycloplegic children mein to wahi prefer karte hain. That is why we should answer atropine. Right? Okay. No, now if it was was it this light reflex absent, accommodation reflex present? Was this described or not? If yes, we all know ARP is accommodation. This you can use it as a mnemonic. Accommodation reflex present. So accommodation reflex is present, light reflex is absent. We are talking about Argyll-Robertson pupil. Argyll-Robertson pupil is also known as light. So this term is mainly used when it is due to neurosyphilis, right? When it is due to neurosyphilis. इसके अलावा what do you call it? We call it light near dissociation. नहीं तो broadly इसको हम बुलाएंगे light near dissociation. Okay, light is gone. Always light is gone. Remember that. This was again a simple question. I won't say it is a difficult question. Okay, so I think there's one more question here. Patient's down gaze palsy question. So Jay, you will have to actually remember. You can just message me if you remember the question. Okay, if the option was something like Argyll-Robertson pupil, what is present, what is absent, please don't forget batti hamesha gol hoti. It's always the light reflex which goes. Remember in any way which is comfortable to you. Otherwise, this is the mnemonic to learn. Accommodation reflex is present, light reflex is absent. Okay, so no confusions. That was a smart way of asking. Right, Manu Ranjithan? Yeah, okay. Okay. Up gaze mentioned in the option means, up gaze means what was the option there? Okay, it could be Perinaud syndrome where there is a vertical gaze palsy, right? With light near dissociation. Yes, all the features of Perinaud could also be one of the option. Okay, Rangita. Right. So in Perinaud again there is a vertical gaze palsy, isn't it? Yeah, and which type of nystagmus there is? That is the retraction nystagmus, right? Okay, Jay, which muscle is not working as the patient isn't able to see down? So what are the muscles which depress your eyes? What are the muscles which depress your eyes? Tell me. If the patient is not able to see down, what are the muscles? Inferior rectus and superior oblique, right? So it will all depend what was the language of the question and what they are trying to ask. You have to think in that line. Yeah, there's lid retraction, Abhishek. Very good. Yeah. Yes, that I'm going to come to that question again. So if we have levo depression wala question is this, I think. What is the yoke muscle working for levo depression? Isn't it? So we have learnt about yoke muscles. Do you want me to discuss this? Yoke muscles are contralateral synergists. Okay? Two muscles of different type which are working together. Right? So when you look to the right, what are the yoke muscles? It is right lateral, left medial. When you look to the left, it is left lateral, right medial. Now, what do you mean by dextro elevation? Towards the right and up. This is dextro depression, this is levo elevation, this is levo depression. How do we answer this question? If we are very, very clear about one important thing, in an outward deviated eye, action of elevation and depression is of recti. If you are still not clear, please make a box and note this down. Right? That in an outward deviated eye, action of elevation and depression is of recti, right? So when we are talking about levo depression, very, very simple, divide the question into two parts, levo depression. First of all, depression, what are the muscles which depress your eye? Inferior rectus, superior oblique. Levo means which eye is outward? Left side is outward. Outward eye में क्या काम करता है? You have just written recti. So it becomes left inferior rectus and right superior oblique. Easy hai? You want to do it for some other gaze? Let's do it for dextro elevation. Again, solve it with me. Dextro elevation. What are the muscles working for elevation? Superior rectus, inferior oblique. So I write here superior rectus, inferior oblique. These were the two muscles working. Now in dextro elevation, which eye is outward? This time right. So right eye, outward eye में क्या काम करता है? Recti. Inward में oblique. So it will be right superior rectus, left inferior oblique. ठीक है? So and if you ध्यान से देखो, every word is opposite. Left का right, inferior superior, recti oblique. So you should be very, very quickly able to answer these questions. ठीक है? So and everybody remembers ना, जो I had taught you about the gazes. This one, this diagram, the same, this is the right side of the patient and this is the left side. If you're looking to the right, it becomes right lateral rectus and left medial rectus. And we're saying the same thing but in a diagrammatic form. So it will depend. Again, we are talking about dextro elevation, dextro depression, levo elevation, levo. But I think I have simplified that even more further, simpler than the diagram. Okay? So they must say it is always the opposite. It is the temporal fibers which are gone will give you the nasal field effect. Nasal fibers gone will give you temporal field. Right? Okay, we come to the next question. ठीक है, यही question था ना? They will see what is the meaning of levo depression. I hope now you know na. Levo is left. Depression means left side ऐसे देखना. This is what is levo elevation. This is levo depression. This is dextro elevation, dextro depression. Chalo, we come to the next thing they had asked you was about, I think, some grading of hypertensive retinopathy. So you all should remember your Keith Wagner grading. Was the question asked here and what was the question, anyone? Keith Wagner grading, was it the question? Can you all help me with that? Okay, Rishu, if there were hemorrhages and cotton wool spots, what is the grading? If I simplify and only go for the hypertensive retinopathy, because the grading of atherosclerosis comes side by side, but if I go for hypertensive, we all should know that this one is generalized attenuation of arteries, right? And then This becomes focal spars, AV nipping and all the findings of AV nipping. Then third becomes your hemorrhages, all the features. So 2 is all the features of 1 along with that. What is grade 3? All the features of 2 along with that, hemorrhages and exudates. And grade 4 is all the feature of 3 along with that, papilledema. Right? So what will you answer here? It is grade 3 hypertensive retinopathy. तो वो तो आर्टियल एटेन्युएशन तो रहेगा ही ना. आर्टियल एटेन्युएशन 1 एड ऑन है, जो 1 है वो 1 तो हो गया, 2 is 1 and 2, 3 is all the features with hemorrhages and exudates. Okay, so it becomes 2. So when you are talking about copper wiring or silver wiring or Bonnet sign, gun sign, these are atherosclerotic changes, right? So did they ask you about the Salus sign, gun sign, Bonnet sign? Salus sign is grade 2, gun sign, Bonnet sign comes in grade 3. Just keep in mind. Okay, just revise the lecture. So exact question I'm still not able to get. That what was exactly asked? Was it about the grading, which grade or of hypertensive retinopathy? So if there are hemorrhages and exudates, I don't think there should be any confusion. It is grade 3. Okay? Okay. Yeah, one of you were talking about, there was a question on papilledema, and I think there are 1 or 2 more questions. That means around 13 to 15 questions must have been asked from ophthalmology here. So it's an important part is covered in ophthalmology. We have substantial good number of the questions here, right? So 1 or 2 I haven't mentioned. So what was the question on papilledema, all of you? You marked retinitis pigmentosa for what? Arterial attenuation. And this hypertensive retinopathy पूछा था ना Jay? No Jay, but in retinitis pigmentosa there should be a triad of pale waxy disc, bony spicules and attenuation of arteries. Okay? If they are asking about copper wiring, if they are asking about other features and there is hemorrhages and exudates, we will not answer retinitis pigmentosa. We are talking about hypertensive retinopathy. Okay? Okay, I don't think what was, I'm not very sure what was the question on papilledema. Can anyone of you share with me? Was it about transient blurring of vision? Please remember, when you talk about diminution of vision, that is in mainly neuritis, right? That is in optic nerve disease. Papilledema is edema around the disc. You may get initial some transient disturbance of vision, but later on in the stage of papilledema, vision is not affected. It is only when the nerve fibers are further damaged and there is optic atrophy that the visual acuity will come down. Okay? Keep this in mind. And this is not called, what is amaurosis fugax is very different. We shouldn't include papilledema as a cause of amaurosis fugax. Amaurosis fugax is generally your transient loss of vision in a curtain-like manner. Right? So do we all remember that? What was amaurosis fugax? It is transient loss of vision in a curtain-like manner. So here the causes could be transient ischemic attacks, it could be carotid artery disease, right? It could be arthritic AION, anti-ischemic optic neuropathy. So it's mainly a feature of neuritis. It can even be uremia, right? So these are some causes of amaurosis fugax. Central retinal artery occlusion as well, but not in papilledema. This is just a transient disturbance of vision. Yeah, so this only transient disturbance of vision is not helping me to, how should I place this question here, but yes, you will not get a definitive diminished visual acuity. This transient disturbance of vision also comes back in papilledema, it becomes normal. As I told you, unless and until it is chronic and it is leading to optic atrophy. Keep that in mind. Okay? So there was one question on your trypan blue dye and one you all were saying about down gaze palsy. So I think around 12 to 13 questions in ophthalmology. Anything you want to ask? See, I want to show you something here. Everything, I don't want to put you all in a panic. Okay, the paper was very difficult and we could not solve it. Let's have a look. What has not been discussed? Everything is discussed in your lectures. If you are attending the video lectures, everything is discussed. The macular sparing, homonymous hemianopia, nicely discussed. We talk about most common intraocular malignant tumor, right? We are talking about ARP, Argyll-Robertson pupil. There is not even I don't find even a single topic which was not covered in your lecture. Talking about siderosis, here are the features. Talking about ECC with PCIOL, CMV retinitis, right? Oil droplet cataract, right? Cycloplegic, we use atropine, right? We are talking about dextro elevation or levo depression. Okay? If just trying to help you out here that there's no need to panic, everything is with you, you just have to study hypertensive retinopathy and the grading. So every single topic, disc edema, papilledema, right? So every single topic has been covered in your class. You are just supposed to be smart enough to imbibe the knowledge and apply it nicely on your questions. So practice more and more clinical questions, right? You have got all the facility that in your PrepLadder app as well. So any lengthy question, Sabir, always go to one very important tip here. As I have, look at my just last session where I just talked about lengthy questions. First read the last line of that question, read the options, then read all the question. It will save a lot of your time because you will know how you have to read the question, what they are trying to ask you. Okay? Yeah. Yeah, it must be tricky. I know that. Okay, the name is interesting, gorgeous girl. Okay, so iron foreign body is causing siderosis, which is leading to lens pigmentation, iris pigmentation, and finally it is leading to retinal changes. These are the three main things that is seen in siderosis. Okay? Jay, ऐसा करते हैं इसको ना, just we will talk it, just DM me, we'll talk about it. So you all have to be at the pre-PG level because that is your next step, isn't it? So it's okay. Okay, did they ask Dr. Saurabh about the orbital varices? So that is one of the only causes of intermittent proptosis, if that was the question. Yes, very good. In that case, any tumor increasing with Vaselva means intermittent proptosis. Then we have to answer orbital varix. So that means around 15 questions in ophthalm. This is what. Okay, I'm waiting. Tell me which question. So this is correct, Rangita. Isme na proptosis with tumor increasing Vaselva, we will answer varices. Is anyone looking at my thought for the day also? I'm just talking about questions. So stop thinking, just relax. Okay, know what is right and wrong and just wait. This is the time for you to just breathe and relax. Okay, don't be so hard on yourselves. Don't panic. जो कर्म करना था कर लिया, फल की चिंता मत करो. There is no need to worry so much. Whatever will come, face it strongly, face it bravely, right? And you all are going to do very well. Don't worry. Right? Any Jay, which question you said, ma'am? रुक जाओ, एक और question है. Jay, this is not helping. I would need the question. Any damage to the ear? Vaishnavi, Dr. Vaishnavi is going to take that. हाँ, so proptosis improving with Vaselva. Improving क्या? Deteriorating. Improving नहीं होगा. Increasing with the Vaselva. Right? Then you have to answer orbital varix. Acha, there was a question on cornea preservatives also. Okay, so cornea preservative, you want me to revise that? Just wait, I'll just find some. So cornea preservative, we know na, short term storage and intermediate term storage and long term storage. Would you like to revise that in your video lectures yourself? What was the question there? Which was short term? Did they ask about MK medium, McCarry-Kaufman medium? Rangita, was it McCarry-Kaufman MK medium? So MK medium is again used for your preserving the cornea. When you are, that is, we are talking about keratoplasty, you are going to take the donor cornea, and that donor cornea has to be used for the grafting, right? But before that, you have to store that. Once you have taken out from the cadaver, how do you store? So that is what you learn. There can be short-term storage, which is only for 2 days, which is done in your moist chamber. But if it is intermediate, it is around 2 weeks. So there are different media where you can store it, like MK media and different Lysol. I don't think they've asked you at your level about these, but G-Sol, K-Sol, these are all different media. You will have to learn this anyway for your NEET PG. So I think McCarry-Kaufman is one thing they ask you, and this is again used for this intermediate storage of cornea. ठीक है रंगीता, ना got it? So यूज समझ आ गया? जब आपने डोनर कॉर्निया निकाला उसको कहीं आपको स्टोर करना है. Black eye is generally ecchymosis, na? The subcutaneous ecchymosis, na? Hemorrhage around the eye. This is due to the blunt trauma, mainly seen in blowout fractures. Yeah, Saurabh, all the best. Keep working hard. Take all these video lectures should be taken seriously, or just attend the classes. That is very important, as I just showed you with all my pics, that everything that was asked has been covered. Even the things which you are just telling me has been covered in my lectures. You just have to seriously attend the lectures and study nicely. I don't want to panic you all. बहुत difficult. Everything is there with you. You have to be just smart enough to learn nicely and to apply that in your questions nicely. Okay? Raccoon eyes ka, what were the raccoon eyes are mainly fracture base of skull because they're bilateral. It is not related to blowout fracture. Raccoon eyes or panda eyes, the term which is given mainly fracture base of skull. Yes, so McCarry-Kaufman, this is what I have written for you all. This is for storing of the cornea, corneal graft. ठीक है? Are you all satisfied? Yeah, so that becomes raccoon eyes, as I told you. It is mainly, we are talking about fracture base of skull. Yes. Dipinda, if you found Ophtha tough, don't worry. I'm here to make it easy for you. Just relax. See, it's all in the mind. The more you will say tough, it will just hamper your learning. Okay, everything is there with you. Just we will learn together, and you are going to be through it. Don't worry at all. It is my responsibility to make it easy and very interesting for you all. Thank you so much. Ecchymosis around the eyes, this is all subcutaneous hemorrhage, na? Okay, Ravitejita, you are talking about a question. What dye used to visualize? Options were fluorescent. Visualize what? Visualize what? Dye used for, I got one question that what is the dye you can use for the antechamber for staining of the capsule? That is trypan blue. But what are you asking? Where do you use the fluorescein dye? Everybody knows, na? We are then in angiography in indocyanine green again in angiography, right? Do you all know in antechamber you can even use ICG, both trypan blue and ICG, but trypan blue is given, mark that. Right? Anterior capsule, you should first mark always trypan blue only. Dr. Saurabh, these are viral conjunctivitis, self-limiting, nothing can be done. You have to bear it, right? Just go for some antibiotics to prevent any secondary infection. I think now you all are out of questions, so you are asking here and there. Huh? So we should end the session and go for the next subject then. Why to waste time? Can we leave? I want a thumbs up from you all. Shall we leave now? Shall we end here? Any other question you all have in mind? Even if you miss, your teacher is not away, right? You can always message me. I'm going to answer you. Yes, fluorescein can be used in keratitis. It can be used even for your BUT test, breakup time test and everything. Yes. Yeah. Thank you so very much. Stay blessed, all of you, and keep smiling. And don't forget the thought for the day that I mentioned. It's all in your thoughts. Just be the master of your mind. Calm down, relax. Just just don't while away this time worrying. Okay, this is the time you can afford to just chill. So just enjoy the time. Just wait and enjoy. Right? Yeah. Stay blessed, all of you. Thank you so much.
Hello. I hope I am audible to you, all of you. Just let me know whether I am audible to all of you or not. We'll start the session shortly. Yeah, I'm just waiting for your reply. Yeah. Audible, visible, everything is clear. Yeah, great. So I hope all of you are doing good and exam was good. So in this physiology session, there are a couple of questions and I believe all of you have done great in physiology per se, right? Okay, so we are going to start the session, right? So in physiology, as I told, there are almost there are almost 8 to 9 questions are there. So we'll discuss those questions with their answer, correct answer, in a quick fashion, because I'm not going to discuss much detail about the answer of the question, because all of you are not in a mood to listen the discussion at this point, because you want to only listen what is the correct answer of all those questions, right? So in this way, we are going to discuss all the MCQs and their proper answer. Fine. So we are starting the session directly. I hope everything is good at your end, right? Okay, sure. So first question, this is a very old question and this is a very common question. I think all of you have done correct answer in this question. So please tell me, thyroid hormone has which kind of receptor? This was the MCQ, thyroid hormone act via which kind of receptor, right? And I believe all of you have done correct answer in this question at least. So I believe you have marked nuclear receptor. Because all of you know there are certain controversy regarding the receptors of the steroid hormone, particularly estrogen, progesterone, testosterone. So I'm not going to enter into the detailed discussion of those, but I believe that there is no confusion, there is no controversy regarding the thyroid hormone receptor. Thyroid hormone receptor is always located inside the nucleus. So the first questions, the answer is very, very easy. Thyroid hormone act via which receptor? Nuclear receptor. Done? Okay. So now we are going to the next question. So next question, the stem of the question was like this, I believe. So two medical students are planning for a trip to high altitude. They want to study the effect of acclimatization in high altitude condition. So all of you know that whenever you ascend to high altitude, there are certain changes inside your body. There are certain changes in your cardiovascular system. There are certain changes in the respiratory system, inside your blood system and all. So all these changes which are happening inside your body, those are known as the acclimatization. Now look at the question, which of the following is not seen in high altitude during acclimatization? And again, this is a very, very easy question. Why easy? Because all of you know that whenever you are ascending into a high altitude condition, what will happen? In high altitude condition, there will be hypoxia inside your body, hypoxia. And this hypoxia is a stimulation for the chemoreceptors of your body. And whenever you stimulate the chemoreceptor, what will happen? Your ventilation, that is the inspiration and expiration, your ventilation is going to be increased, right? So that way, this hyperventilation is going to be seen in high altitude condition, not the hypoventilation, right? So the question is, which of the following is not seen in? So obviously, the answer will be hypoventilation. So options were different. So if you could recall other options, so I can tell you what will be the correct answer. But if the hypoventilation is there in the choices, then it is certainly going to be the wrong, because it is not going to seen in high altitude condition, high altitude acclimatization. Always there will be hyperventilation. Other options that have been given here, polycythemia and increased hemoglobin. This is due to the increased stimulation of the erythropoietin secretion. Why not C? Increase in myoglobin. Yes. So whenever your body is getting less oxygen, right? Your muscle is getting less oxygen. So what will your muscle do to compensate for this low oxygen in the atmosphere? Your muscle will try to deliver or extract more oxygen from the blood. So that way, increase in myoglobin has to be there inside the muscle cell. Not only that, there will be increase in number of mitochondria inside the muscle cells. There will be increase in cytochrome oxidase enzyme inside the mitochondria also. So these are the changes which are going to happen inside the muscles. Number one, there will be increased number of capillary, there will be increased number of myoglobin, there will be increased number of mitochondria, there will be increased number of cytochrome oxidase enzyme inside the muscles. So all these things are going to happen in high altitude condition, but hypoventilation is not going to be seen. There must be hyperventilation. Achha, it was hyperventilation. So if it is hyperventilation, then you have to recall that what are the other options, right? Okay. I choose see increase in myoglobin, it will be seen. It will be seen. Hypoventilation, if it is there, then hypoventilation is going to be your answer. But increase myoglobin, increase capillary, that is known as the angiogenesis inside the muscle. Increase mitochondria, increase cytochrome oxidase, all those are going to be seen in high altitude condition, right? Okay. Increase RBC was there. Hello, yes. So increase RBC, so this is polycythemia or increase RBC, increase hemoglobin. This is two similar option. There may be a different option between this A and B. You can check or you can recall. If you could recall, please let me load data later on, because here I believe that both of these A and B options are looking similar here. Increase hemoglobin, polycythemia. Capillary was also there, increased capillary. Yes, that must be there. I hope in between these two, increased capillary was also there. But anyway, there is no confusion in the answer. If hypoventilation was in the choices, then hypoventilation is not going to be seen in acclimatized person. Other options, I believe, they are true here, right? So this is the answer of the second question. Rest of the same, right? Option was decreased pulmonary ventilation. Great. So hypoventilation or decreased pulmonary ventilation, both will be the same. So that is going to be your answer. That decreased ventilation is not going to be same. Increased ventilation is going to be same. Hypoventilation is not going to be seen. Hyperventilation is going to be seen, right? Right. So this is the answer of the second question. Now coming to the third question, which of the following has GLUT2? Now this is one important question. I believe what is the answer? If RBC number is increasing, so how RBC number will increase without the synthesis of hemoglobin if your iron content of the body is normal? RBC is produced from the bone marrow now. So during the development of the RBC, right? So it has to take hemoglobin inside it, right? So erythropoietin is stimulating the stem cell series of the RBC. So it has to take hemoglobin. So hemoglobin has to be increased. And that's why the physiological polycythemia is seen in the high altitude condition, right? So that is not going to be answer. Dr. Rahman, I'm sorry, but both will be seen, right? Okay. So now tell me the answer of this question. So D. Okay. So small intestine also has GLUT2, kidney also has GLUT2, liver also has GLUT2. But there is a catch in this question. This is not that much easy question. What do you think of? Okay. Brain, GLUT1 is there, GLUT3 is there, GLUT5 is there, but GLUT2, brain, rare. Okay, there may be some study which can isolate GLUT2 in the brain also, but that's not the primary location. Now look at small intestine, kidney, liver. All three locations has GLUT2. If you open up any literature, any books, it will be given. But there is a catch. Whenever we say that GLUT2 is located in which area, then you have to look at the apical membrane of the cell or the luminal membrane of the cell. Now look at the level of small intestine, suppose this is the small intestinal cell and this is the luminal side. This is the luminal side. You know what is the glucose transporter located in the luminal side of the intestinal epithelium? Very famous question. It has been asked multiple times. It is not the GLUT. It is the sodium glucose transporter. That is SGLT. Getting my point? So if the intestinal epithelium, the major glucose transporter is the SGLT, not the GLUT. That is SGLT1. And on the basolateral aspect, yes, there is a GLUT and this is GLUT2. And this is GLUT2, right? So obviously, intestinal epithelium is also containing the GLUT2. Now, look at the kidney. So this is the intestinal epithelium. Now, coming to this black color diagram, this is kidney. Similar kind of scenario. The SGLT is located in the luminal side. So it is transporting sodium along with glucose. And the basolateral aspect of the membrane is also containing the GLUT2 for glucose transporter. But here, you know, the SGLT2 is the main glucose transporter. So here is the SGLT2, although one is also there, and at the level of intestine, it is only the one. This is the thing we used to read again and again. And on the basolateral aspect, GLUT is also there. So GLUT is also present in the intestinal epithelium cell also, kidney also. But that is not the answer here. So if you look at the liver cell, so suppose this is the liver cell. This is the apical membrane of the liver cell. And this is the basolateral membrane of the liver cell. And you know, the GLUT2 is present on both the membranes. So GLUT2 is present in both the membrane. That's why you look at literature, you look at book, it is written that liver is the primary location of GLUT2. Although you are thinking that GLUT2, it's pancreatic beta cell. Yes, it is also there. But that does not mean GLUT is not there in the liver. Liver has to take glucose from the blood and liver has to release glucose into the blood. So whenever the glucose is taken up from the blood, this GLUT2 is going to help. And whenever liver is releasing the GLUT into the blood, again, it has to take one GLUT, and that is GLUT2, GLUT2, GLUT2. Means it is the liver which primarily contains GLUT2 on both the apical membrane as well as the basolateral membrane. But I told you in my classes repeatedly that whenever they are asking questions about GLUT or glucose transporter, you have to answer the luminal membrane or apical membrane mainly. So even if you think of the luminal membrane or apical membrane, this GLUT2 is present on the basolateral membrane in intestinal epithelium as well as in the kidney epithelium. So these are not going to be your answer. The answer of choice here is liver, liver, liver. Getting my question? Okay. So which GLUT2 is located in which of the following? The answer will be liver. Question was different. Basolateral glut they were asking? No, 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 no. Contraluminal side of the intestine? So this is the answer, glut 2. Okay, contralateral membrane mein, okay. So luminal membrane and contraluminal membrane will have glut 2 in intestine also as well as in kidney also. Okay, so yes, it is present in excess of glut. Okay, anything else you are recalling in this question? Transporter present in the basal membrane of intestinal cell. This was the question? The glucose transporter present on the basolateral membrane of the intestinal cell, then the question is altogether different. Whatever I have written here. Okay. Could anybody recall? The question was intestinal epithelium. They were asking that what glucose transporter present on the basolateral membrane of the intestine. Then this is a whole altogether new questions. Okay. Here we are discussing that GLUT2 is present on which of the following? If this is the question, then your answer is liver among these choices. But if the question is glucose transporter present on basolateral or contraluminal membrane of the intestinal epithelium cell, then again your answer is going to be GLUT2. Getting my point? Now you decide among yourselves that what was the actual questions. But even if they're asking that intestinal epithelium or kidney epithelium cell, what is the basolateral transporter or what is the contraluminal transporter for glucose? His answer is GLUT2. Okay, luminal transporter hoga, so SGLT is the answer. Okay, so anyway, so if it is a contralateral, then it is a different question. Different question answer kya hoga? GLUT2 will be the answer. But if the question was GLUT2 is present on which of the following among these options, then we are going to mark liver. Okay, so please try to recall a little bit more. If you are getting any good recall, so please do share. Okay, I'll update the question. Fine. Okay, so now we are moving on to the next question. So question number 4. In the adjacent graph, phase 1 represent which of the following property? So this is a cystometrogram. It is depicting that whenever urine is entering inside the urinary bladder, suppose urine is entering inside the urinary bladder more and more, urine is coming into the urinary bladder. So whenever urine is entering inside the urinary bladder, initially, at the initial part, what will happen? There will be increase in pressure in the urinary bladder. That is 1A. Okay. So 1A represent filling of the urinary bladder. Urine is coming and bladder is expanding. Pressure is also rising. Now, if you look at the 1B, the question part, the 1B, here what you are finding out, more and more urine is entering into the urinary bladder. Urinary bladder is expanding, but the intravesicular pressure is not rising much, right? So urinary bladder is expanding. The radius of the urinary bladder is expanding. It is stretched, but intravesicular pressure is not rising much. We all know that this is the application of the Laplace law. P is equal to twice T by R. So tension is rising inside the urinary bladder. Radius is also increasing inside the urinary bladder. But the intravesicular pressure within this urinary bladder is not changing. Now this time they are not asking which law is applicable here. They are asking which of the following property. Now look at elasticity is the property of returning to the original condition. So if you expand the urinary bladder and then you release, urinary bladder is recoiling to the original condition. That is elasticity. So it is not depicting here. It is saying that whenever the urinary bladder is stretched, it is accommodating the pressure inside the bladder so that the pressure is not rising much. You know that we can hold our urine for long time. Okay, मान लो थोड़ा सा ज़्यादा pressure आ गया, हम लोग क्या करते हैं? थोड़ा सा इधर-उधर करते हैं, उससे adjust कर लेते हैं. So what is happening? Urinary bladder is adjusting the pressure by changing its shape. By changing its shape. This is one of the property of the smooth muscle. That smooth muscle changes its shape in terms of stretch. So whenever it stretch, it changes its shape. उस actual stretch condition में जाके stop हो जाता है, shape changes हो जाता है. This shape changing property of the smooth muscle is known as the plasticity property of the smooth muscle. Getting my point? So 1B area Here, the Laplace law is applicable, and the Laplace law is nothing but the urinary bladder is already stretched and it is adjusting its shape to maintain the pressure normal. Okay. So this is typical of plasticity property. Now, whenever your urinary blood is filled with 400 ml of urine, मैंने अभी बोल रहा था कि if the urine is filling in the bladder, we can adjust for some point of time. But how long? There will be a point where the urinary bladder is filled with 400 ml of urine, and at that condition, you has to urinate. You has to micturate. Otherwise, क्या होगा? वो तो आपको पता है क्या हो जाएगा, ठीक है? So that is the condition when the urinary bladder will start contraction, and whenever the contraction is happening, pressure within the urinary bladder will be very, very high, and micturition will start. So this is the phase which is depicting the contractility property of the urinary blood. That is the 2. Phase 2 is depicting the contractility property of the urinary bladder, and 1B is describing the plasticity property of the urinary bladder. Getting my point? So I hope there is no confusion in this question. Plasticity is a property that you have to remember here. Okay? Okay. Chalo. So answer is plasticity, obviously B. Okay? Right. Next question. So identify the hormone A and B giving negative feedback on hypothalamo-pituitary axis. Now, I believe this was the image. And if this is the image, first thing that I'm noting down here, one side is there is Leydig cell, and on the other side, there is Sertoli cell. Now, even if you know only one thing here, you will be able to answer. Leydig cell, what we read, even in the single liner discussion, I have told you that Leydig cell produce what? Testosterone. And this testosterone is going to give negative feedback at the level of pituitary for the production of LH, right? So A is your testosterone, right? So A is my testosterone. Now I'm finding out apart from this testosterone, there is inhibin also, there is dihydroepiandrosterone is also there, right? Dihydroandrogen is also there. But all of you know that that is not going to answer because this Sertoli cell produce one product that is known as the inhibin. Inhibin, and this inhibin is going to inhibit the FSH production from anterior pituitary. So this B is inhibin and A is testosterone. So this B is going to be my answer in this question, right? Again, an image-based question. Yes, this question is a little bit, you can say, tougher. But even if you look at the Leydig cell, testosterone, you'll be able to answer this question correctly. Fine? Okay. Anything else in this question you want to recall or you want to add something here? Okay. Now, next question. So, question number 6. On injection of irritant substances, bradycardia, right? Look at bradycardia, hypotension, and apnea develop in a person, right? These represent which of the following reflexes. And this is one of the common topic which they generally ask in NEET or INI-CET type of examination, right? And what you have read that this Cushing reflex is hypertension, tachycardia, right? So in Cushing reflex, there is hypertension, there is bradycardia, sorry. Heart rate will decrease, increase hypertension, right? So hypertension is there and bradycardia is there in Cushing reflex, right? Bain-Vij reflex, what do you know? Whenever your blood volume is increased or whenever the fluid volume inside the body is increased, the heart rate increases. But Bain-Vij reflex had not much effect on blood pressure. So Bain-Vij reflex selectively increases the heart rate. It has not much effect on blood pressure. But tachycardia is the main feature of Bain-Vij reflex, right? So in Cushing reflex, there may be respiratory alteration. There may be irregular ventilation in Cushing reflex also. Irregular ventilation can also be seen in case of Cushing reflex. Okay. So if you think of this apnea, is it going to happen in Cushing reflex? Maybe in the later on. But hypertension is given, so it cannot be Cushing reflex. So it is the Bejol-Jeris reflex that is going to be my answer here. So all of you know Bejol-Jeris reflex means whenever certain kind of chemicals or certain kind of irritants like serotonin, 5-hydroxyserotonin or capsaicin. Okay, this kind of chemicals, if it is present in the left coronary artery, then what is going to happen? There will be decrease in blood pressure, severe hypotension. There will be decrease in heart rate, and there will be apnea followed by hyperventilation. So this is typical of visual gyrus reflex that is given. All of you know that the receptor for the visual gyrus reflex is located in the left ventricular muscle wall. That's why whenever you give injection of irritant, whenever that irritant is flowing inside your blood and it is going to the left coronary artery, it is going to stimulate the visual gyrus reflex receptor, and there will be bradycardia, hypotension, and apnea. So this is typical of visual gyrus reflex, right? So I hope all of you have done correctly this thing. So these are the 6 questions that has been asked in physiology topic. So I told you that I'll be quick in discussion of this physiology. So thank you so much. I hope all of you have done mostly correct. Okay. Only I believe that Group 2 may be a little bit difficult or maybe a little bit tricky question for you, but other question you have done correctly. So best of luck for all of you. Okay. Let's hope for the best. Okay. So bye-bye. Take care and good luck to all of you.
Yeah. Hello, dear friends. I'm Dr. Jambukeswaran, your orthopedic faculty for you from PrepLadder. Okay. So happy seeing you all again. Okay, dear friends. So yesterday the FMGE exam was over, and we got just 5 questions from Hello? Yeah? Which screen? Okay. So dear friends, the FMG exam was over yesterday, and 5 questions have been asked in ortho. Okay. The happy thing is all the 5 have been already discussed for you. It's there in our recording and in YouTube session also. Okay. So hope you are done well. Let us see. Okay. Straight away we'll move on to the question. Question number 1. Okay. Question number 1. You see, a patient has painless, underline the word, a painless, palpable, bony mass near the metaphysis of the long bone. X-ray was done which shows the following finding, which is the most probable diagnosis. You look at the X-ray. You see, I am seeing an X-ray. This is the lower end of the femur. This is upper end of tibia. So this is a knee joint X-ray. In lower end of femur, I am able to see a swelling, a mass which comes out, and it's like this. It's outside the cortex, and I am able to see Here, a peduncle. I'm able to see a peduncle. So this is a pedunculated mass arising from the metaphysis. Okay, and in the question, a very strong line, painless. A painless pedunculated mass which is coming from the metaphysis, the most probable diagnosis, there is no doubt, it should be osteochondroma. It should be osteochondroma. Okay, very obvious. Osteochondroma is otherwise called exostosis. This is otherwise called exostosis. Okay, exo means coming out, endo means it's inside. So exostosis, a bony mass which is coming outside the cortex. It is projecting outside the cortex. See, the first choice they had given osteosarcoma. Okay, the first choice they had given osteosarcoma. I will tell you why it is not osteogenic sarcoma. See, osteogenic sarcoma also is a metaphyseal tumor. Okay, this is also a metaphyseal tumor. What is the thing? The very first presentation of osteogenic sarcoma is pain. Pain starts first, swelling comes next. Here, that's why they had given painless. Okay, painless mass, bony mass, which is coming out of metaphysis, it is osteochondroma unless otherwise proved. Because we know pretty well, dear friends, the most common benign bone tumor in the whole world is osteochondroma, otherwise called exostosis. That's the most common benign bone tumor. 50 to 60% of the benign bone tumors are osteochondroma. 9% of all tumors are osteochondroma. Okay, that's what we know pretty well. The MCQ, dear friends, most common bone tumors, secondary. Most common benign bone tumor, osteochondroma. Okay, so this is osteochondroma, right? So it is a painless pedunculated, that's what, from metaphysis. It can't be multiple myeloma. Definitely it can't be multiple. And moreover, dear friends, the appearance of this, no, you just see the X-ray. This is called cauliflower appearance. This is called cauliflower appearance. Okay, this is called cauliflower appearance. If it is osteogenic sarcoma, it should give a sunburst appearance. That's called sun ray or sunburst appearance. And it should have shown you a Codman's triangle. Radiologically also totally different. It won't give this picture. This is a very classical picture of osteochondroma, otherwise called exostosis. Now I'll come to the second point. Why that is not multiple myeloma? Multiple myeloma occurs in elderly, that's okay. The most common site of multiple myeloma in skeleton is vertebra. The second site is pelvis. The third site is skull bone. Here and all, in around knee joint and all, multiple myeloma is very rare. Okay, it's not possible. It's a malignant tumor. You know, the appearance in X-ray also totally different. It gives punched out appearance. Multiple myeloma gives a punched out appearance. If it affects the vertebra, it's called a winking eye, owl eye sign, and that's called pedicle sign. That's called pedicle sign. So totally, it is different. Now, I'll tell you why this is not osteoid osteoma. Osteoid osteoma is a diaphyseal tumor. Osteoid osteoma is divided into two: ivory osteoma, osteoid osteoma. Osteoid osteoma is a diaphyseal tumor. It's a diaphyseal tumor. Okay, so it is not metaphyseal, it's a diaphyseal tumor. So it can't be osteoid osteoma. And osteoid osteoma in X-ray, no, it is if suppose you are seeing an X-ray like this, a long bone diaphysis, you will see a radiolucent area. Inside that you will see a sclerotic mass like thing, a small seed like thing, and that is called nidus. That is called nidus. This is the one X-ray finding, and nidus can be, to read in an X-ray it's very difficult. In CT to some extent you can read well. Bone scans the specific investigation. So totally a different presentation, different radiological appearance. So that can't be. So straightforward hit. Okay, this is a case of osteochondroma, otherwise called exostosis. Okay, you know pretty well. The presentation is painless bony mass. Usually incidentally it is found out. Okay, usually it's incidentally found out. You know pretty well. It is common in pubertal boys, more common in males, pubertal age group. During growth spurt this will come. And one more very fascinating point, you see the mass, this is epiphysis, this is metaphysis, this is diaphysis. You see the mass is growing away from epiphysis. The mass is growing away from epiphysis. Diagnosis osteochondroma. Okay, we'll move on to the next question. Okay, we'll move on to the next question. Again, this was the discussed question, dear friends. I hope 100% you would have answered this. A patient presented to the outpatient department to the following presentation as shown in the image below. Okay, physical examination shows high riding scapula, high riding medially rotated scapula. Scapula on one side is elevated, okay, with equilateral triangle like shape. What is the most likely? So very, see, you see here, one side scapula is in normal position. This is the scapula, it's in normal position. Here the scapula is high riding, it is above. Okay, so obviously you know the answer. It is an elevated scapula on one side, and that deformity is called sprungal deformity, and that's called sprungal shoulder. This is called sprungal shoulder. Okay, so what is sprungal shoulder? In intrauterine life, normally both the scapulas will be at the level of cervical spine, and it starts descending. During birth, it should be at the normal position. Sometimes in some children, one side, what happened, the scapula fails to descend from cervical area because of persistence of what is called omovertebral bone. This is the basic pathology. Dear friends, everything already we had discussed. Okay, omovertebral bone. Omovertebral bone. Omovertebral bone means we should not think it's a bony hard-like structure. It's like a membrane. So that omovertebral bone, normally it is present in the fetal life. Normally that should go away. That should get absorbed. It's a vestigial thing. Suppose if there is persistence of omovertebral bone on that side, it will not allow the scapula to descend to the normal position. So congenitally, abnormally elevated scapula, that is called sprungal shoulder. That's called sprungal shoulder. Okay, if at all you want to do something before 6 years, you should try to divide that omovertebral fascia so that scapula may come to the normal level. But unfortunately, on the affected side, usually scapula will be equilateral triangle shaped and smaller in size. Two things will happen. There will be hypoplasia of the scapula. So scapula will be normal in size. It's equilateral triangle like thing, abnormally elevated. These three things very classical of sprungal shoulder or sprungal deformity. The second choice, some irrelevant word they had given, separated shoulder deformity, nothing. Torticollis. Torticollis, definitely it can't be torticollis. Torticollis is otherwise called wry neck. This is otherwise called wry neck. Okay, this is called wry neck. This is because of a tumor-like thing that's happening in the sternocleidomastoid. So, sternocleidomastoid prominence will be there. Head will be tilted to the affected side. Chin will be tilted to the opposite side. So, the child will present like this. On one side, head tilting to the affected side. Chin is elevated to the opposite side. So this will be the presentation. This is called torticollis, congenital torticollis, otherwise called wry neck. Totally the picture will be different. It's no way it's connected with scapula. So that is wrong choice. Klippel-Feil syndrome. See, I am telling you this, the thing they had given, obviously the scapula is elevated, it is sprungal shoulder. The point I want to stress is, dear friends, Klippel-Feil syndrome is congenitally fused cervical vertebra. It's congenitally fused cervical vertebra. We have 7 cervical vertebra, C1, C2, C3, C4, C5, C6, C7. 7 cervical vertebrae are there. All the 7 cervical vertebra fused to one unit. Congenitally fused cervical vertebra, that's called block vertebra, and that is the pathology of Klippel-Feil syndrome. So what happens? The neck becomes short. The neck becomes short. Since the neck becomes short, the hairline becomes low hairline. Low hairline, short neck, but mind mentation is normal, because whenever you come across low hairline, short neck, downs will come to your mind. In downs also, the neck is short, low hairline, but that's associated with mental retardation. Here nothing. Okay, so this is low hairline, short neck, mentation is normal. That low hairline, the short neck is because of congenitally fused cervical vertebra. That's because of congenitally fused cervical vertebra, right? So that's called Klippel-Feil syndrome. The point I want to stress is, dear friends, most common association of Klippel-Feil syndrome is with sprungal shoulder. Most common association of sprungal shoulder is with Klippel-Feil syndrome. So whenever you get a case of sprungal shoulder, most of the time that's associated with Klippel-Feil syndrome. There is no doubt. That's why he is giving a choice and trying to confuse us. Okay, alright. But we people won't we won't fall into their prey. We know very, very clearly, problem of the scapula means it's sprungal deformity. Congenitally fused cervical vertebra is Klippel-Feil syndrome. a tumor-like state which is thickening of the sternocleidomastoid tumor, then it's called torticollis. Okay, and this is an irrelevant choice. Okay, we'll move on to the next question, dear friends. Nerve damage that is seen in the following image. Obviously, a patient is sitting, this side, the wrist is like this. Obviously, this is called wrist drop. This is called wrist drop. And whenever there is wrist drop, there is no second differential diagnosis. It should be radial nerve. If it is ulnar nerve, you will get a claw handing. Median nerve, it is totally different. Okay, it's called pointing index. And axillary nerve, usually there will be loss of sensation over the deltoid and deltoid atrophy. That's called regiment batch sign. So this picture very obviously says this is wrist drop. Okay, wrist drop is due to radial nerve palsy. Okay, so luckily they had asked a very simple straightforward question. They didn't ask the level and all. Radial nerve palsy means you know that very high radial nerve palsy, that is on the exit of the brachial plexus in the axilla. Problem in the axilla, very high. Then high radial nerve palsy means in the spiral groove. Low radial nerve palsy means below the elbow or at the level of elbow. Low radial nerve palsy. Very low radial nerve palsy means at the wrist. At the wrist. So palsy can happen in the axilla, the spiral groove, at the elbow or just below elbow, and at the level of wrist. Okay, but this is, you see, total wrist drop. The whole thing is the wrist is dropped, fingers are dropped, thumb are dropped. So it should be the case of high radial nerve palsy. It should be high radial nerve palsy. If it is just only, there is no wrist drop, it is only finger drop and thumb drop, that can not be a direct radial nerve palsy, it can be a posterior interosseous nerve palsy. So that's called low radial nerve palsy. But the picture very obviously gives a wrist drop, and they had not asked to that extent. They had given just radial nerve. So we are very safe. The answer is radial nerve palsy. This is wrist drop. Okay, we'll move on to the next question, dear friends. Which of the following area get damaged in housemaid's knee? They asked a question, which area is damaged in housemaid's knee? They had given A. In the A, this is suprapatellar bursa, B is prepatellar bursa, C is infrapatellar bursa, D is pes anserine bursa. Pes anserine bursa. So we all know pretty well, dear friends, what is housemaid's knee. All of us, we know very confidently that is prepatellar bursitis. Prepatellar bursitis is called housemaid's knee. So prepatellar, where it is choice B. So it should be, the answer is D. So this is choice B. Okay, this is the answer is choice D. The marked area is B, prepatellar bursitis. So prepatellar bursitis is called housemaid's knee. Infrapatellar bursitis is called clergyman's knee. Suprapatellar bursitis doesn't have any specific name. Pes anserine bursitis doesn't have any specific name. But what you should know, what is this pes? Just one additional point I'll tell you. Okay, what is pes anserine bursitis? You know what is a bursa? Bursa is a sac filled with jelly-like fluid. Usually, bursa is seen all over our body, throughout our body, where all the tendon and bone meet. This acts like a small cushion which prevents friction. Whenever there is overuse, it can get inflamed. That is called bursitis. Then it will present to you with pain. So what is this pes anserine bursa? Pes anserine bursa, situated between the tibia, that is over the shin, and where the three tendons originates from the tibia. What are the three tendons? The hamstring tendons, sartorius, gracilis, semitendinosus. Okay, so the tendon where sartorius, gracilis, and semitendinosus. These three tendons, when it originates from the tibia, these three tendons, the bursa which is formed between the tibial bone and these three tendons, they are called anserine, pes anserine bursa. And when it gets inflamed, pes anserine bursitis, the patient will present to you with intra-articular, like a knee joint pain, And I told you, in general, the bursitis is due to overuse. Okay, so you know pretty well, clergyman. Who is a clergyman? Clergyman is a church father, pope. So we know how the Christians, we used to pray. We will sit like this and we will pray. So the infrapatellar area is in direct communication with the ground. So constant friction, infrapatellar bursitis, clergyman's knee. Housemaid used to kneel down. So and they used to mop like this. So what happened? The prepatellar bursa is in constant touch with the ground. So prepatellar bursitis. Okay, that's called housemaid's knee. Very simple. Yes. Move on to the last question, dear friends. Identify the sign and the tendon ruptured in the image given below. Okay, I am able to see the skin itself says the patient is a very old patient, and I am able to see, okay, abnormal protrusion of the biceps. And this sign is classically, this sign is called the famous cartoon character, our favorite, okay, Popeye. Okay, Popeye sign. Okay, this is the spelling. Popeye sign. Okay, Popeye the sailor or the old man, the Popeye sign exactly looks like that. So it's called Popeye sign. Popeye sign is because of rupture of the biceps tendon. This is the answer. Biceps tendon rupture. Okay, so that's called Popeye sign. What is that? Popeye sign is because of rupture of the proximal portion of the biceps tendon, especially the long head. Biceps has two heads, especially the long head. You will get a protrusion like this. What is the cause? Most of the time, biceps tendon rupture happens in elderly individuals, male, and it is because of degenerative changes happening in the tendon. So no need of any acute trauma. That's why the books is telling this biceps tendon ruptures spontaneously. That's the word in the textbook. Spontaneous rupture of the proximal portion of the biceps tendon, especially long head, is called, and that sign is called Popeye sign. Biceps tendon rupture. That's called biceps tendon. Suppose triceps tendon rupture doesn't have any specific name to my knowledge, dear friends. Sometimes triceps tendons can stand out prominently. Normally triceps is like this. It can stand out prominently like this, no, like a bulge here. A bulge can happen over the triceps tendon, and that sign is called bowstring sign. That sign is called bowstring sign. Bowstring sign. That sign is called bowstring sign. And where it happens? Elbow dislocation. Okay, it happens in the elbow dislocation. Okay, right. Elbow dislocation. So bowstring sign, that triceps tendon stands out prominently, a pop. Okay, a prominence of the triceps tendon is called bowstring sign, happens in elbow dislocation. A prominence of biceps tendon happens in biceps tendon, spontaneous rupture of the biceps tendon, and that's called Popeye sign. That's called the Popeye sign. That completes all our questions, dear friends, and don't worry, guaranteed 100% all of you will clear the exam. I have no doubt. Okay, all the best, dear friends. Thank you so much.
Just check whether it has started.
Yes, sir, start.
Hi and hello dreamers. This is your Dr. Bharat Kumar Vedi, Pharmacology faculty, PrepLadder. So before I resume this, just message me whether the audio video is fine, and then we can proceed further. Yes. Yes, Sabiruddin, good evening, and happy to see you here. Yes, Himanshu, cool. Yeah, thank you. How was the exam, guys? Mehta, how was the exam? And so let us discuss pharmacology question. Very good, Sabarik, right? Now, before we start this, the disclaimer is it's a recall-based question. So the purpose is to get the questions and get a final question to you, and that will be uploaded in the PrepLadder app. So hope you will help me in this process. So let us start with the questions now. And yes, we'll start now. So the first question, what we are going to start is, which of the following is the antidote for benzodiazepine overdose? So what is the antidote for benzodiazepine? Is it flumazenil, flunitrazepam, barbiturates, or buspirone? So it's a clear-cut question that the answer is flumazenil. So I have told you plenty of times, even in rapid revision, even in the videos, that antidotes, every year the antidotes will come. So 2-3 questions from antidotes list will come. I hope you have followed that and you have written the answer. So the answer is flumazenil. Sir, what about flunitrazepam? Flunitrazepam is a benzodiazepine. So it's a date rape drug. It's a benzodiazepine. So in benzodiazepine, you don't give benzodiazepine. So ruled out. Barbiturate poisoning doesn't have an antidote. So for barbiturate poisoning, what we do is we do hemodialysis. And since barbiturates are acid, we alkalize the urine. So this is what we do. Then buspirone, I told you repeatedly, who will do that sound? Bus, snake. So whenever you see the snake, you get anxiety. So buspirone is a drug which is used to treat chronic anxiety. It's a drug used to treat chronic anxiety. Sir, what is the mechanism of action of buspirone? The mechanism is 5-HT1A partial agonist. So it's a 5-HT1A partial agonist. So the answer for this question is flumazenil. Now, what I want to tell you is, don't confuse flumazenil with a drug called fomepizole. I think I have told plenty of times in the classes, you will get confusion with that. So fomepizole is an antidote for alcohol. So which alcohol, sir? The methanol and then ethylene glycol. So it's an antidote for methanol and ethylene glycol. The name is fomepizole. I told you repeatedly, remember alcohol has 2 O's and fomepizole 2 O. So when the question comes, oh, I told you that. Yes, FMG PG Kumar, welcome. And let us continue with the next question. So the answer is direct here, guys, flumazenil. Now moving on to the next question, what is the antidote for iron toxicity? The question whether it was IV, whether the question was acute iron overdose or chronic, it depends. If it is acute iron poisoning, suddenly some child has taken 10 tablets of iron capsules, then the treatment is deferoxamine. Now deferoxamine was also called as desferoxamine. So it's another name for that, and the drug can be given both IV and IM. Suppose the patient is on repeated blood transfusion, and that will lead to chronic iron overload. If there was chronic iron overload, then in that toxicity, what we use is either deferriprone or there is a drug called deferricirox. So these 2 drugs are the oral drugs. And this drug is the parenteral one, which is given in acute iron overdose. Yes, Vinay, even the question is clinical. That's what I'm explaining you. If they have given the acute, suddenly somebody took overdose of tablets or syrup, then your treatment will be IV. Suppose repeated blood transfusion, chronic iron overload, then your answer will be deferriprone or deferricirox. Okay. Yes, sir, it was child consumed iron tablets. If child has consumed iron tablets, obviously the question goes towards deferoxamine, also called as desferoxamine. So if they're given child, that chances are acute iron toxicity. So that's what. So if you're given child, obviously it's an acute iron poisoning. So the answer is deferoxamine. Very good. Now let us move on to the next question. Which among the following SSRI drug used for management of depression? It's a simple question. They have given the answer SSRIs itself. So any depression, mild to moderate. Nowadays, the first choice of drugs are SSRI, and the drug of SSRI here is fluoxetine. So fluoxetine is the answer here. So all of you agree with that? Is fluoxetine is the answer? Imipramine, desimipramine, amitriptyline, nortriptyline, they all belong to tricyclic antidepressants. Bupropion is an atypical antidepressant. Let me write. It's an atypical antidepressant. And also it is used in smoking cessation. Bupropion is used for smoking cessation and also in obesity management. So you know that lithium is used in two important conditions. One is called the mania as well as bipolar disorder. So the answer is fluoxetine. So question wasn't that much simple. Then do you recall anything else for this? Yeah, whatever. See, clinical, they would have given patient had low mode depressive symptoms, and what is the first choice? Obviously, you know that SSRIs are the first choice, and what SSRI you got in the question is fluoxetine. So that will be the answer. So hope you all agree with that. Yes, fluoxetine is the drug. Okay, so until now we have discussed, they are repeated questions only. I told you the antidotes will be asked, right? The antidotes will be asked. Then moving on to the next question. 32-year-old male bought 3 bottles of alcohol from a liquor shop and later presented with drowsiness, ataxia and blurred vision. So the vision disturbance is seen. Which of the following is the antidote for the given condition? So what is your answer, guys? What did you write? Naltrexone. It's an oral drug. So naltrexone is an oral drug. So its counterpart naloxone. So naloxone is given IV and that is used in opioid poisoning. So that is ruled out. So what is given in the poisoning? So what is this poisoning, sir? This is a case of methanol poisoning. So what happens in methanol? Methanol is converted into formaldehyde, and from formaldehyde it is converted into formic acid. Now this formic acid is responsible for retinal toxicity. So retina gets damaged and that's why the patient is having blurred vision, and also this is responsible for acidosis. So how do you manage this? Before that, let me tell you, methanol to formaldehyde is done by alcohol dehydrogenase, then formaldehyde to formic acid is done by aldehyde dehydrogenase. So if I want to treat this patient, what we can give is ethanol. Sir, why should we give ethanol? Now ethanol metabolism also depends on these two enzymes. So we are diverting the methanol metabolism and preventing the formation of formic acid, and that's why ethanol will be the best answer. Sir, but you told antidote will be something else. Yes, if they had given the another option, that is fomepizole, fomepizole would have been the answer, because fomepizole inhibits alcohol dehydrogenase and that is the antidote for methanol poisoning. Since that is not there, what is the best option we can choose is ethanol. Morphine is an opioid, fentanyl is an opioid. We don't give them in methanol poisoning. So the answer, the best one will be ethanol, ethanol, ethanol. Even ethyl alcohol was in the option. Now just tell me, yeah, diazepam was in the option. Okay, let me write. So the other name for ethanol is ethyl alcohol. Please remember, ethanol has one more name, that is ethyl alcohol, that can be given. Okay, but actually the antidote what they should have mentioned is fomepizole. But you have not given, so you can go with the ethanol. Yeah, Maram Vinay, child with thalassemia with multiple blood transfusion. Remember, if a child with multiple blood transfusion, then you should give oral deferriprone or deferricerox. So it depends on the case what they have asked you. Let me move on to the next question. So HIV positive woman who was not receiving treatment gave birth to a baby boy. What was the newborn's initial course treatment? So we all know that the first thing what we start is nevirapine. Is it for 6 months? No. Zidovudine for 6 weeks? No. Should we give the combination? No. Then what is the best option what we have is nevirapine. So nevirapine for 6 weeks is the one which we start in the newborn. The reason why nevirapine or zidovudine are the drugs which are used for newborn, the simple concept is these two are available as syrup, and you know that syrups are easy to administer to the newborn. So in that, the best one will be nevirapine, which is given for 6 weeks. So the answer will be D here. Okay, so any other things you want to discuss, just put a message, guys. Weren't options different, Ashley? Just to come up with the options. So whatever the option is, nevirapine, if they are given simple nevirapine also, that is the best one you can give to the newborn if a mother is HIV positive. Right. Then moving on to the next question. I told these questions repeatedly in the classes. A group of friends planned a trip to Ladakh. So Ladakh means high altitude. So Leh Ladakh. One of them started having headache, nausea, dizziness, and exhaustion symptoms while they were there. So they already reached the Ladakh, high altitude. So when you go to high altitude, so the most common problem what they face is acute mountain sickness. So the patients will develop acute mountain sickness. The reason is in the high altitude, the oxygen levels is lesser. Patient will have hypoxia. So you will breathe faster and there is a chance of pulmonary edema. So the best drug what can be given here is acetazolamide, and we know that acetazolamide is the drug of choice for acute mountain sickness. So the first thing what we do whenever there is acute mountain sickness is to bring the patient down and then give acetazolamide. Or if we have the problem of acute mountain sickness, we can give the acetazolamide as prophylaxis also. What about sumatriptan? We know that sumatriptan is the drug of choice for acute attack of migraine. Scopolamine, also called as hyoscine, it's a drug of choice for a condition called motion sickness. So motion sickness is due to stimulation of vestibular apparatus. If you go to some small areas like Ooty, Kodaikanal, or you go to Dehradun or some hilly areas, then you don't get the mountain sickness. What you get is motion sickness. So that's why they have given particularly Ladakh. If they had given a small hilly area, then you should not guess it as mountain sickness. So promethazine is an antihistamine. So it is also used for motion sickness. So whenever I take my classes, I will be telling you three sickness: mountain sickness. I told you the answer is acetazolamide. Motion sickness. Then the drug of choice is hyoscine, and then one more sickness they can ask you is the morning sickness. So where you see it in the first trimester of pregnancy, the drug of choice is a combination of doxylamine plus pyridoxine B6. So that's why the case is easily given, and most of them were telling the paper was tougher, but I think this is an easy one to detect, and you could have written the answer, and most of you have answered it, I think. Yes. Yeah. Now, which of the following undergoes Hoffman's degradation? Remember, whenever we give the drug undergoes elimination. That means metabolism as well as excretion. But there is a special type of degradation that is called Hoffman's, also called as elimination. In this, what happens? The drug will undergo spontaneous molecular rearrangement, and the drug is thrown out. So this doesn't depend on the kidney or liver function. So that's the reason these drugs can be used in a liver disease patient and renal disease patient safely, and also in elderly. So the drug name is called cis-atracurium. So another drug which is similar to that is atracurium. See, this is a very old question, guys. When I was doing my MBBS, this Hoffman's elimination was asked. Till now it is asked. So it's not a rare question, it's a new one. No, it's a old one only. So this is the answer. Mevacurium, the specialty is it is metabolized by pseudocholinesterase. So can you tell me one more drug metabolized by pseudocholinesterase? That is called succinyl-choline. So the answer for this question is cis-atracurium and atracurium. Then moving on to the next question. After undergoing lithium therapy for a year, so very long-term treatment, all the following adverse effects are visible except. I'm repeatedly telling you, lithium is favorite for examiner. Either it is NEET PG, FMGE or INI-CET. There is always one question from lithium because one of the wonder drug for mania and bipolar disorder. Will it cause hypothyroidism? Yes. Will it cause tremor? Yes. Will it cause diabetes insipidus? Yes. But it will never cause tardive dyskinesia. So what drugs will produce tardive dyskinesia is done by the typical antipsychotics. Sir, can you give an example of typical antipsychotic? The example of typical antipsychotic is haloperidol. So when you use haloperidol in a schizophrenia patient for years together, then they develop tardive dyskinesia. But remember, lithium adverse effect, there is a mnemonic, all fat hence fell. So what is this? I'll just expand. A for alopecia and acne, fat, obesity, H for hypothyroidism. And one more, high dose. If you give lithium high dose, the patient will develop coarse tremors. So coarse tremors are seen in high dose. It will lead to tinnitus, and the patient may develop seizures. E for EC changes, not to worry about that. N for it can produce nephrogenic diabetes insipidus, and the drug of choice for that is amiloride. Yes, it can cause seizures at high dose. And fine tremor. Fine tremor is most commonly seen with lithium. That is the most common adverse effect. E, Epstein's anomaly. Sir, what is Epstein's anomaly? So it's a cardiovascular defect when you give it to a pregnant woman. So this drug should not be used in pregnant women. It can lead to teratogenicity. L for loose stools, that is diarrhea. And L for it can increase leukocyte, that is leukocytosis. So please, I know that most of you remember the mnemonic lithium and you can try to answer that questions, but will this not help you? No. So this is a mnemonic where you can get all the adverse effect, and repeatedly this question is asked in your exams. Okay. So moving back, tardive dyskinesia is not seen with lithium therapy. Then CA cervix, carcinoma cervix, which chemotherapy agent is used? So most of my FMGE classes I have told you, cisplatin is like a drug which can be used in most of the solid tumors. You take any, like the bronchial cancer, lung cancer, head and neck cancer, testicular cancer, cervical cancer. Even if you don't know anything, just if you know that cisplatin is used everywhere, you could have marked the answer. So the answer will be cisplatin. Yes, जब I was exam में mnemonic ही याद नहीं आता है. That's why repeated reading is very, very important. Yes. So cisplatin, one of the most commonly used anti-cancer drug. So that is the one you can mark it. Okay. So certain times you have to take a guess. Sir, will paclitaxel be used? Yes, it is also used, but most commonly used is cisplatin. So that's the reason why that becomes the right answer here. Yeah. Which of the following drug can cause thymine-less death of cells? So again here, even if you don't know the answer, if you know what is the mechanism, then you can answer this. 6-mercaptopurine and azathioprine, they are purine antagonist. They are purine antagonist. Methotrexate mechanism, you all know that it inhibits dihydrofolate reductase. So the folic acid, that is tetrahydrofolate, is not formed. So do you know purine synthesis is affected? So what is left is 5-fluorouracil. Now this is a drug which inhibits an enzyme called thymidylate synthase. So this enzyme is inhibited. So what happens if we inhibit this thymidylate synthase? Deoxyuridine monophosphate will not become deoxythymidyllic acid monophosphate. So without thymidine, you know that we require purine and pyrimidine for cell division. So cancer cells require division. For that, they require purine and pyrimidine. And if you block this step, thymidine is not synthesized. So DNA synthesis suffers and cells will die. So the thymine or thymidine-less death of cells is done by 5-fluorouracil. Ammo, if they have clearly mentioned oral drug, your answer is absolutely correct. Deferiprone. Your answer is absolutely correct. Okay. Right. So 5-fluorouracil. So similarly, we have a drug called flucytosine. Flucytosine is not an anti-cancer drug. It's an antifungal drug. And after it enters the fungus, it is converted to 5-fluorouracil. So this conversion is done in fungus only. That's why we don't use flucytosine in human cancers. So we use it in fungal infections only. Right? So these are the things. Moving on to the next question. I think most of you know that cytomegalovirus. Whenever we teach in the classes, we tell you that any herpes virus 1, herpes virus 2, then varicella zoster virus. So the drug of choice is acyclovir. or we can use val acyclovir. Cytomegalovirus, the drug of choice is ganciclovir. You may ask a question, sir, can we use acyclovir to treat cytomegalovirus? Never, because acyclovir will never enter and kill cytomegalovirus. So it is not at all effective. So that's why the next drug what we use is ganciclovir. Apart from that, if they become resistant to acyclovir or ganciclovir, the next drug what we can use is called foscarnet. So that is a drug of choice. What are the other drugs for cytomegalovirus? What are the other drugs? One is foscarnet. The other drugs are cidofovir and a drug called fomiversin. So these are the other drugs reserved for the resistant cases. Otherwise, the drug of choice is always ganciclovir. So hope you might have written this answer. Acyclovir, acyclovir will never work on cytomegalovirus. Very clear concept. It will never work. Sir, will ganciclovir work on herpes? Yes. Varicella zoster? Yes. But we don't use it there. We want this drug exclusively for cytomegalovirus. So even acyclovir was in the option. That is not a right answer. Sir, in carcinoma cervix, there was also methotrexate option. Certainly, I can understand methotrexate was also there in the option, but cisplatin is most commonly and most widely used drug for the cervical cancer. So that's the reason why that will be the best option you can choose in your exam. Okay. Yes. So even cotrimoxazole, next time they can ask you if you're attempting the NEET PG or next. After you clear FMG exam, cotrimoxazole, they will ask you for pneumocystitis xerosi, a very common opportunity infection in HIV patient. Right? So this is the thing. So tenofovir, we use it in HIV as well as in hepatitis B. Hepatitis B, the drug of choice will be tenofovir. So these are the other things which can be asked in your exams. Let us move on to the next question. 55-year-old male with complaints of urine hesitancy and retention of urine comes to emergency room. So obviously 55 years retention of urine. On investigation, there is residual urine of 130 ml. Whenever there is residual urine, which suspect one common problem in elderly, that is benign prostate hyperplasia. Which of the following drug is used in the treatment? Calcium channel blockers, obviously we don't use them because they are used in management of hypertension, arrhythmia and angina. ACE inhibitors, same thing, hypertension, we use them, CHF, we use them. Aldosterone antagonist is spironolactone, we use it in chronic CHF, Conn syndrome, and also in resident hypertension. So what is left out is 5-alpha reductase inhibitors. Option, even if there are beta blockers, so they don't form the right answer. Thank you for adding your option, Ranger. So whenever we think of BPH, so management of BPH, there are two important ones, the slow acting and fast acting. So the fast acting ones are the alpha blockers, alpha 1 blocker, they end with zosine, for example, prazosin, terazosin, doxazosin, all those things. Now recently we have alpha 1A blocker selectively. The name is called tamsulosin, and one more drug is silodosin. So these are the drugs which are used for BPH. But slow acting drugs, so what happens? Testosterone is converted into it is converted into, just a minute, dihydrotestosterone with the help of 5-alpha reductase. Now this is responsible for the growth of prostate tissue. So if I inhibit this, then I can decrease the prostate size. So the drugs are called as F for finasteride and D for dutasteride. Let me write them. Finasteride and a drug called dutasteride. So these are drugs. Okay, but next time in your other competitive exam, you will be writing the NEET PG. So remember these 5-alpha reductase inhibitors, they decrease the prostate size. Very, very important. Okay. Yes. Now let us move on to the next question. What is the mechanism of action of bedaquiline? See, bedaquiline is one of the major new drug for tuberculosis. Now, what is the mechanism of it? What is the mechanism? ATP synthesis inhibition. Yes. So it inhibits mycobacterial ATP synthesis. It has a very high volume of distribution. The elimination half-life is 160 to 165 days. But the problem is QT prolongation and hepatotoxicity. Mycolic acid synthesis inhibition is done by isoniazid. So protein inhibition is done by streptomycin. And inhibiting reverse transcriptase, we have the NRTase and NRTase. So it's a simple question. ATP synthesis inhibition is done by a beautiful drug of the century for TB, badaquiline. Badaquiline, very, very important drug. Next, moving on to the next question. Just tell me whether this question was there. Patient present with gout symptoms but forgot to mention asthma history. First day intern prescribed aspirin, later patient developed some symptoms and came in emergency. Now patient with gout was given aspirin and he had a asthma history. So I just want you to add option for this, guys. Java Voice, if they have given alpha-1 blocker in the option, obviously if they have asked you if there is a patient with BPH and come to you, immediately what drugs will work? I will go for alpha-1 blocker. Okay, if that is the option, I will choose that. Yes, this was there. So can you tell me, is it because of aspirin blocking LOX? Aspirin never blocks lipoxygenase. It will not induce this. Prostaglandin induces bronchoconstriction. What is the D? Last option. Now, what is this problem? Now, there may be two possibilities here. Patient, there are two possibilities. Let me roll out this. Now, gout. So, whenever we manage acute gout, there are three modalities of treatment for acute gout. One is NSAID, one is the colchicine, and the steroid. So, the first thing what we start is NSAIDs. In NSAID, we use indomethacin diclofenac, but one is contraindicated. The contraindication is aspirin. Now, why the aspirin is contraindicated? It itself increases uric acid and it can worsen the acute gout. That may be one reason. Now, the patient with gout has asthma. So, what is the problem in a patient with asthma? Now, we know that the membrane phospholipid is converted into arachidonic acid. So, there are two enzymes which act on that. The COX enzyme, which will give rise to prostaglandins, the LOX enzyme, which will give rise to leukotrienes. So, when we give aspirin, aspirin inhibits the enzyme COX irreversibly, so it will not synthesize prostaglandin. And that's why we can see the decrease in fever, pain, and inflammation. Now, in some people, what happens? The arachidonic acid is converted into leukotrienes, and leukotrienes are responsible for bronchoconstriction. So, sometimes we call it as aspirin-induced asthma. So, that may be the reason why the patient would have developed this symptom. So, this is the explanation what I can get from this. So, you should tell me the options, guys. Okay, whatever possibility, these are the options. These are the reasons why either the asthma would have worsened. Okay, because when you block COX, the arachidonic acid is called leukotrienes and they cause bronchoconstriction, so asthma would have worsened up. Or the aspirin is contraindicated in acute gout because it increases uric acid and worsen the gouty symptoms, that is gouty arthritis. Okay, so just check it with that. So aspirin doesn't do anything with LOX, so that is ruled out. Okay, so these are the things. Since we don't know the option, I have given you the concept. Please understand that. Deepinder Chahal. Yes, ratio Bansal, maybe that's why. So these are the things, the concept. So it depends on what options were there and the answer will be like that. Now another question was cheese reaction. So they were asked a cheese reaction. Maybe they would have given a patient who a psychiatric patient was on some drugs and he consumed wine and then developed high blood pressure or headache, something like that. What is it due to? Cheese reaction is due to. Abhi, how to avoid burnouts in preparation? Simple. Only thing is, whenever the classes are done, please revise then and there only. And And once the classes are done, please at least take 5 minutes every day to revise whatever, 1 or 2 pages daily, so that you will avoid that. See, Kabhi, if lipoxygenate pathway increase was an option, I think that will be the best option what we can think of. So don't worry. So what is cheese reaction, sir? What drugs are responsible? The answer is clear, the MAO inhibitors. Sir, what is cheese reaction? Let us understand this in a brief manner. Now there is a compound called tyramine. Tyramine, what does it do? This is the synapse of sympathetic system. Tyramine enters inside and displaces norelin and it increases BP. So this is the role of tyramine, and tyramine is called as indirect sympathetic because it doesn't act directly on either alpha or beta receptor in the sympathetic system. So it indirectly acts by releasing norelin. What happens? This is our gut, intestine, this is the gut, and these are the cells, and they have an enzyme called MAO. They have an enzyme called MAO. So whenever a person consumes cheese, wine, beer, now these food products contain tyramine. So if I drink a beer, wine, cheese, what I am doing, I am also taking tyramine. So when tyramine reaches our intestine, tyramine cannot get absorbed. So it cannot get absorbed because the enzyme MAO is breaking it down. So tyramine is not able to cross inside. Suppose a patient is on depression and he is taking MAO inhibitor. So MAO is inhibited not only in the brain, on the periphery also. So if the patient is already on MAO inhibitor, what happens? Whenever we eat cheese, wine, beer, tyramine will enter the intestine. Now it is not broken down because you have inhibited the enzyme MAO, so it will directly enter the circulation and displace more norelin, and the BP will shoot up, and we call it as cheese reaction. Sir, why they are not called as beer reaction, wine reaction? Because they saw that first in the cheese, and once they are given the name, every time they cannot change the names. So don't worry. So cheese reaction was the name given to that. Maybe they have given in the question wine. So tyramine enters and the BP will go up. And how do you bring down BP? By antihypertensive. The most commonly used antihypertensive, the name is called phentolamine, which is an alpha blocker, which is called as non-selective alpha blocker can be given. Okay, I hope this question was asked in the exam. Then was a question on pheochromocytoma treatment asked. So you know that pheochromocytoma is a tumor of adrenal gland. So there is increase in noradrenaline and increase in adrenaline. There is increase in these two things, and they will be increasing the blood pressure. Now, what is the treatment for this? So the best treatment are alpha blockers. The 3 P's, P, P, P. So phenoxybenzamine, phentolamine, prazosin, all the 3 P's can be used. But whenever you manage pheochromocytoma, you have to follow this rule. First, whenever you want to control the BP, you have to give alpha blocker followed by beta blocker. So repeatedly I told you this in the classes. This is what we follow when you want to manage the pheochromocytoma patient presenting with high blood pressure. Yes. Okay guys, so pheochromocytoma, hello. So pheochromocytoma treatment, was it asked or not? Just tell me. I'm waiting for answers. Okay. Okay, so preoperatively, either we give phenoxybenzamine or phentolamine so that we can control the BP. And during surgery, we don't want the BP to rise. So, yeah. Okay, guys. So, which of the following is a drug of choice for facial nerve palsy, or what we call it as Bell's palsy? I think Bell's palsy was asked. So, during Bell's palsy, the first modality of treatment is prednisolone, that is steroids are the first therapies, right? And earlier you start them, more is the recovery. So the best things to start is prednisolone, steroids. Now, what about acyclovir? Should we start? Yes, you can add them, but the benefit is not that much, but they are added in the regimen. But the best option will be prednisolone. That is the best option what we can give. Along with that, you can use antiviral drug. But if you give antiviral and miss steroid, then the prognosis is very bad. So it's very much important that steroids are started as early as possible. Okay, yes. Okay, so that's it from my side. Thank you all, and hope you all come with flying colors, because don't worry about the complexity of paper. Many times we think that the paper was complex with the language I use. Don't worry, because, and I was seeing some meme, there was no PYQ. See, whatever you study, whenever the 300 questions are there, there are 30 to 40 questions, 50 questions, 60 questions, which is not able to be answered. But there are certain questions which are repeatedly asked, and you should never make a mistake with that. For example, now we discuss benzodiazepine, you should know the antidote. Methanol antidote, you should know, right? So there are other questions you can see here. Bell's palsy, pheochromocytoma, you told. Cheese reaction, you knew it. Then the other options are bedaquiline. Then the PPH cases, cytomegalovirus, very common. And then flu cytosine. Certain times we may not answer the thymidine less cells, trachurium, the mountain sickness, never miss that. So these are the things what I just want to tell you. I think prednisolone will be the best option. Okay. Okay, Medico G, Pharma was good. Thank you guys, and hope you enjoyed the session. Any other questions, please put me. So you can also follow me in the Instagram, Bharat Kumar VD, and you can post your queries there also if you get a new question. So this is the Instagram ID, Bharat, BHARATH VD. You can contact me there. And yes, so I pray the God so that you all come with flying colors. So I want you all to be flying with the super score. And don't worry, you have finished the exam, relax for a few days. Okay, so result will come. Don't worry about the result. Enjoy the process. Okay, so you will all come with flying colors. Don't worry. Okay, so anything else you want to ask me, or shall we move here? Okay, so then I will wind up the session. All the best. For your results. Okay, so thank you all.
Hi guys, good evening and welcome to this deliberation of Obs and Gynae questions. I guess you guys had a very, very long day, and after the exam yesterday, I'm sure all of you are now totally tired, and I'm surprised that you're still here for the answers. So, but yes, good. All of us want to know how you've done the exam. So I hope it was good and all of you could perform to your own expectations. Yes. And I'm sure that is going to get you more than 50% marks. So your own expectations is what is important. Yes, we expect a lot from you, but then I hope you guys have all done well. And knowing that this is the last session of the day, so what I was thinking that, I'm also not near my studio at home, and I was taken up with work. So what I decided that at least I'll tell you the answers to the questions which have come to me. What has actually happened that All these questions which have come, they've come with some choices which are making sense. Some choices are totally not near the question at all. So what we'll do, we'll go through with the choices which I have, and you'll get at least a good idea of how you've done your exam. And as and when I get the complete set of the proper recall and all the questions, we'll have probably another session whenever it is possible. Okay, so maybe I'll send it on the app straight away rather than having a live session, but that is later. So let us start with the questions so that we can give you at least some answers and some idea about how you've done your exam. All right, so we'll take the first question, guys. Induction of labor is not done in which of the following? So, it's fair and simple that we will not induce labor when there is a problem like a placenta covering the os. It obviously makes sense. Complete placenta previa is straight answer that I'm not going to induce labor. But yes, gestational hypertension is no indication for cesarean. I will do a normal delivery. And abruptio placentae, I've been telling this so many times in our discussions that abruptio placentae is definitely not a straightaway indication for cesarean. Yes, we end up doing a lot more cesarean sections in abruption than in patients who are not having abruption. That is correct. But abruption by itself is not an indication of doing a cesarean section. We try to do normal deliveries. So yes, definitely in gestational hypertension and abruptio placentae, I will give a normal delivery. Placenta previa, definitely don't give the normal delivery. Now, the problem is they have said vasa previa also as another choice. So yes, one of these choices would have not been there in the exams. Definitely in vasa previa also, I will not give trial of normal vaginal delivery, because if I've diagnosed antenatal itself, you know, how do you diagnose vasa previa? Good time to recall that. Vasa previa is diagnosed by an antenatal 3D ultrasound with a Doppler. So if you diagnose a vasa previa, the vessels are in front of the head of the baby and they are at the os. Vasa previa, vessels at the os. That's Latin, isn't it? Vasa previa, vessels at the os. Placenta previa, placenta at the os. So if the vessels are covering the os, obviously you're not going to give a trial. So in the frame of the questions which have been sent to me, we will not induce in A and C both. Of course, if vasa previa was not there, then the best answer is obviously complete placenta previa. Okay, here it is like that. So let's see what you guys are telling me. Some of you are telling me the right choices. Are you? Okay, somebody's saying that premature rupture of membrane was an option. So yes, Ashley, if you're saying premature rupture of membranes is there, then obviously let's replace choice number C with PROM. If you say choice number C is PROM, then straight away we know that the answer is A. And gestational hypertension will induce. Premature rupture of membranes will definitely induce. If she doesn't go into labor within 1 hour, we'll induce. And in abruptio placenta, will induce. So with pre-ROM, the answer is good. We can say complete placenta previa. Anything else? Yes. All right, Abha. Hi, how are you? And nice, sir. Yahi the option. All right, if this was the option, then I would say out of these two, A and C, I'm sorry, both of these you cannot induce labor. So, of course, that's not a very good option. Anyway, let's say A and C for the time being. Let's wait and watch if another, the same question with given with some another choice. All right, next slide, please. Okay, question number 2. A medical termination at 21 weeks requires consent and permission of which of the following? Husband and one dog. That is never the... See, look, I don't know how the choices are recalled, but please understand, if a patient is needing an MTP, now we can do MTP till 24 weeks. But remember, from 20 weeks to 24 weeks, 2 doctors are required for giving the opinion and counseling the patient and taking a decision of doing the abortion. So yes, after 20 weeks, it is 2 doctors. So yes, there's one choice which is saying only mother and 2 doctors. That is the obvious answer. Where there is 2 doctors involved, there is only one choice. So choice B is the obvious answer. Now, it also makes sense for us to realize that if a mother wants an MTP, she can decide herself to do that. Yes, it is a moral obligation of the mother to tell the husband that I'm undergoing an MTP, but the husband need not be involved in the decision making by law. A mother can on herself decide to do an MTP. So only mother and 2 doctors is the best option here. So MTP now can be done up to 24 weeks. That's the modification of the 2021 amendment which has come. And we know that after 24 weeks, also, if you want, we can do an abortion. There's another question which has come, but that requires an approval from a board. All right. So we'll come to that question and discuss. We'll take the questions first. Okay, Vasapriya was not there probably. I choose PRM, that's why I remember. Okay, Ashley, PRM was a choice, so good. I'm sure that previous question. And now this question number 2. This FMG, Dr. FMG, this question is coming. What doubt you asked me? So we'll come to that. Next question, please. What is the maneuver shown in the image below? Now, this is a sitter. I mean, they wanted to just give you 1 mark straight away. Okay. Now, this is a baby which is about to come out. The head is crowning the perineum. Can you see? This part of the head is pushing out of the vagina. So, one hand of the examiner is under the chin of the baby. So, the doctor is not actually at the chin. He's actually at the perineum. You see, his hand is not inside the vagina. One hand is outside the vagina, but at the level of the perineum. Through the perineum, this doctor is pushing the chin up, and with the other hand, he's pushing the head up. So this is that modified Ringen maneuver where the pushing of the chin and pushing of the head is going to allow the extension of the head. So all of us remember what I taught you in the class, that when we have a delivery of the fetus, the head, which is in occipital anterior, that delivery which we are talking, the head will always come out with extension. So when the head comes out with extension, delivery is best. So to help the extension, this Ringen maneuver is good. So it hastens the delivery and also helps in extension. All right, so that's a fairly simple question. So what did you guys say? Image was not there. Okay, no image was given. So anyway, what was the question then? Which maneuver helps the delivery of the head better? Which of the following maneuvers helps in the delivery of the fetal head better than just a normal self-delivery? Was the question like that? Never mind. We'll get to that. You guys are getting tired. I'll just tell you what is there in front of me and you guys can go off to sleep. All right. So we'll take the next question, guys. Just after delivery, the position of the uterus corresponds to the level of how many weeks? Basically, they're trying to say this question, I always, when we discuss physiology of pregnancy, we always discuss how the uterus increases in pregnancy. 12 weeks at the level of the pubic symphysis, 24 weeks at the level of the umbilicus, and at the level of the xiphisternum at 36 weeks. And at 40 weeks, it comes down a little and the flanks fill up. That's how it increases. How does the uterus reduce after delivery? Immediately after delivery, the uterus is at or below the level of umbilicus. That's how I always taught you, at or just below the level of umbilicus. Now, if you have a choice between these two, it is straightforward, given in your Williams obstetrics. There's no doubt that if you want to put one answer, then it is just below the level of the umbilicus. So when umbilicus is roughly 24 weeks, then just below the umbilicus or the lower level of the umbilicus will be around 20 weeks. So that is a great answer here. All right, simple answer. 28 was not there. 18 weeks. 18 weeks was there. Between 20 and 18, yes, that will become a controversy. Was 18 and 20 both given? Options were 16 and 18. Was 20 and 24 given? Look, if it was 24 and 18, I'll go with 18. And if it was 24 and 20, then between 18 and 20, if there's a problem. 16, 18. No, tell me all the 4 choices. See, Ashley has given me 2 choices. He's told me about 16 and 18. Ashley, I presume that you're a gentleman. Anyway, even if you're a lady, then 16 and 18. (20, 24, 16, 18). Now, 20, 24, 16, 28. Yes, 20, 24, 16, 28. So some people are saying even 16 and 18 and 20 was there. Guys, now that is a very, very close thing they've given you. So at or below the level of umbilicus, so we'll always say below the level of umbilicus. And since umbilicus is 24 weeks and just below, it'll be around 20 weeks. So I will have to go with 20 weeks. All right. So yes, there is always a little bit of controversy about the level of the uterus. But remember, we want to read this because if the uterus is at the level or just below the level of the umbilicus, which is around 20 weeks, why it is good? Because you can make, if this woman has delivered 2 children, then tomorrow morning, I can post her to the OT and do an easy puerperal sterilization. Because the uterus is an abdominal organ, I can make an incision on the abdomen and reach the uterus very easily and get to the tubes and do a tubectomy. So that's why these questions are always asked to you. Okay, remember, I'll go with the answer at 20 weeks. Okay. Okay, 20 weeks is a better answer than the 18 weeks because 18 is much lower. So at or just below is what William says. So just below umbilicus will be around 20 weeks. So we'll go with that. All right, so let's move on. Next question. Can you change the slide? Primary gravid at 32 weeks present to the emergency room with severe abdominal pain. On examination, the uterus is tender and the fetus was not palpable. What is the most probable diagnosis? Now, this question has come so many times in our discussions in every forum. I'm right now in Chennai and I was taking a class here. Here, the students also were asking me about this. So please remember, it's a straightforward question. Severe abdominal pain and the uterus is tender. Fetus were not palpable. So tender uterus, first thing, think of abruptio placentae. Fetus was not palpable. So that is because the placenta, see the placenta is at the anterior wall, the placenta is probably separated a little and there is a blood clot. So through the abdomen and then the blood clot and then the placenta, the baby is behind that. So sometimes you cannot feel the fetus, especially because the uterus is very tense and tender. So tense uterus, tender uterus, you cannot palpate the parts of the baby, then it is definitely abruption. The abruption is the reason why you cannot reach the fetus. Now, if it is a case of rupture uterus, the fetus is easily palpable. In fact, it is more easily palpable than when the baby is inside the uterus because the baby is outside the uterus in the abdominal cavity. So as simple as that. If the baby is in the abdominal cavity, through the abdomen, you will easily feel the fetal parts. So severe pain and loss of uterine contour, easily felt fetus and no fetal heart sound, that is what is a rupture uterus. If tense uterus, high blood pressure, and inability to feel the fetal parts because of tense uterus and not able to hear the heart sound with a stethoscope, all of that is known to happen in a abruption. So yes, this is straight away a case of abruptio placentae. I hope all of you got that right. This has come so many times in your exams. I mean, in our discussions wherever we've met. Bleeding was mentioned in the question. Yeah, bleeding was mentioned. So that's what is also a case of BP less than 90 by 50. Look, if you're saying BP is less than 90 by 50 and you're trying to say that there was bleeding vaginally, so you have to tell me more information. With this information in this question, which is present, I will have to mark abruption. If there was some information saying that there was loss of blood pressure and the fetus was easily palpable, then I'll think of rupture uterus. Anyway, after this discussion, you know what will be asked in rupture, what will be asked in abruption. So don't worry. I'm sure that all of you had a very clear question in the exam. And this is a recall, which is a problem here. So let's not get too upset about this. All right. If the metal pressure is low, we will definitely think in terms of a rupture, but I need more information in this question. All right. Let's go to the next question, please. Outlet forceps is also known as. So outlet forceps is the classical forceps, which has got a short pelvic curve and a good cephalic curve like this. And this is that classical instrument which we use for taking a baby out, which is beyond +3, +4, +5. When the head is at the perineum and the mother is having an exhaustion, then we can help her in a delivery by applying these forceps. This is the Wrigley's outlet forceps. This is classical Wrigley's outlet forceps. Piper forceps is longer. There's a classical Piper's forceps and a short Piper's forceps. And this classical Piper's forceps is having a very short pelvic curve. And that is because it is used not very deep in the pelvis. Why? Because it is used for the aftercoming head of the baby. So the breech has come, the head is inside. So for this head, which is in the perineum, now for the aftercoming head, then we apply the blades. So for that aftercoming head, short pelvic curve is enough. That's why that is the Piper's forceps for the aftercoming head. Keelan's forceps are generally the rotational forceps, and I don't know where rotation will be asked now in your exams. Definitely, PG entrance exam and MCA exam, they'll not be asking you rotational forceps. In fact, we are advising our postgraduates also not to do rotational forceps till a senior consultant is with you, because senior consultants also rarely put rotational forceps these days, because rotational forceps need a lot of experience, and rotational forceps can cause a lot of injury to the fetal head and to the metal organs inside the pelvis. So it is, rather than doing a difficult forceps, it's a basic thumb rule now. Rather than doing a difficult forceps operation, it's better you do a safe cesarean operation, because forceps have traditionally more injuries than vacuum. Okay, yes, vacuum will cause more hematomas and scalp injuries, and hematomas and cephalomatomas can be more with vacuum, but other injuries, around the head, compression injuries and intracerebral bleed, and things like vaginal lacerations and pelvic muscles lacerations, all of these are more with forceps. So yes, rotational forceps is better avoided. Okay, so what are you guys asking me? Let me see. No photo forceps was there. Image was not there. Okay. Outlet forceps is also known as Wrigley's forceps. That's fine. I just thought, well, put a picture for you. Okay, Jan exam also some forceps were asked. All right, so we are getting big on forceps. So maybe we'll include even more, rather than the regular lecture, we'll include even more discussions in FMG exams now. Anyway, FMG exam and PG entrance exam is all the same. From here on, everything is going to be the same for you. Okay, next question, please. Hyperechonic conditions are all of the following except. So, yes, ovarian cancer. Okay, ovarian cancer. Yes, women with PCOS will have ovarian cancers. A lot of ovarian cancers make a lot of estrogens, like especially like granulosa cell tumors make a lot of estrogens. So yes, women with hyperestrogenic conditions may be related with ovarian cancers. Okay, fine, given. Low BMI. Wait, let's see. Tamoxifen. Yes, tamoxifen is given for the role of anti-estrogen action on the breast. Breast cancer, we give tamoxifen, but it has got estrogenic action on the endometrium. So side effect of tamoxifen is the high estrogenic action on the endometrium, causing endometrial cancer, and it is anti-estrogenic on the breast. So wait a minute, endometriosis definitely hyperestrogenic condition. So ovarian cancer, endometriosis definitely hyperestrogenic conditions. Low BMI means there is less fat. Less fat means less estrogens. So that's a very straight logic. So there are two possible answers, but the best answer in this choices is B. B for Bombay, low BMI, because tamoxifen is estrogenic and anti-estrogenic. So I wonder what were the choices once more. Let's look at what you guys are answering. Estrogen secreting tumor. Okay, granulosa cell tumor is correct. Then and did by eliminating technique. What are the other choices, guys? BMI. BMI looks like the best answer here. It is not a hyper. Low BMI will be having lesser fat. Fat is a factory which produces estrogens, because the circulating androgens, when they reach there, they're converted to estrogens. So fat is a factory for estrogens, and that fat, if it is less, then because of low BMI, there'll be relatively lesser fats in this woman. Okay, of course, fat is not the only place where the estrogens are made. They are probably, they are always made much more than in the ovary, than the periphery. So I'm sure you got this right. Low BMI is fine. Let's go to the next question, guys. Middle swab is stained in a 3-swab test. Now, 3-swab test is that simplest test you can do for the diagnosis of the vesicovaginal fistula. When there is a VVF, the most common VVF is because of obstructed labor. And obstructed labor will cause compression of the vagina and the urethra against the pubic symphysis. So that is going to cause necrosis at the level of mid-vaginal area. So mid-vaginal area, vesicovaginal fistula. So the middle cotton ball will be stained. Classical mid-vaginal fistula is because of obstructed labor, mid-vaginal VVF. So what is the choice here? Mid-vaginal fistula swab is stained in vesicovaginal fistula, ureterovaginal fistula. That's a very, very rare thing. Uterovaginal. I am sure they meant ureterovaginal, not utero. They meant ureterovaginal fistula. Ureterovaginal fistula, all the three swabs will be stained, but they'll not be blue in color. So when you put blue dye in the bladder, then the vesicovaginal fistulas, the fistulas from the bladder to the vagina, those will stain the cotton pads blue in color. If there's a ureterovaginal fistula, ureter is having normal color urine, or yellowish or clean or clear urine. Only the bladder is having blue urine because you put methylene blue. So if there's a ureterovaginal fistula, all these swabs will get wet, but all of these will be colorless. So that helps you. If you do a 3 swab test and top, middle, or bottom swab is blue, you know it is high, middle, or low fistula. But if these swabs are wet and not blue, then we know the fistula is coming from the ureter. So yes, ureterovaginal fistula would have been the choice in choice C. But the answer to this MCQ, middle swab is stained in a vesicovaginal fistula. If this was a choice, this was a fairly simple. Look, this all of the above and none of the above. Please, the answer to this question is A. All of the above, none of the above. Please put a hand on your heart and tell me, did it even come as a choice in any of the MCQs? All of the above, none of the above. It is never a choice. I'm so confident of it. It is only a guidebook thing. This all of the above, none of the above, whoever has recalled the MCQ for us, that guy probably did not know what to do. So he said all of the above or none of the above. Come on, tell me. Tell me about all of the above, none of the above. Come on. Continuous dribbling in the second swab was stain mentioned. Yeah, this answer is, rectovaginal fistula was also there. Fine, the answer is vesicovaginal fistula. Tell me about all of the above, none of the above. Come on, I'm waiting. Dr. Danger, I assume that you've done well. All of the above, none of the above was not there. All right. Yes. Fourth option was rectovaginal. Okay, rectovaginal also. This middle swab will not be stained. All right, guys. This is a simple question. Let's go to the next question, please. Leydig cells and Sertoli cells secrete respectively which of the following? So Leydig cells and Sertoli cells, we're talking about men now. And recently, whenever we've discussed in our classes, I've always taught you about GnRH acting on the pituitary, making LH and FSH, and FSH and LH will act on the ovaries, and in men, LH and FSH will act on the testes. Now, LH and FSH, they will act on the testes. FSH, S for Sertoli, LH for Leydig. That is the basic of LH and FSH. Now they're asking, what does Leydig and Sertoli cells secrete? Leydig cells make the androgens. Sertoli cells make the sperms. That is basic. Now they're asking only the hormones. So Leydig cells makes the testosterone, Sertoli cells makes the inhibin. Okay, men also make inhibin, women also make inhibin. Women make the inhibin from the granulosa cells. And in men, the Sertoli cells makes the inhibin. All right, I think I got that right. Images with arrows or full pathway. This was image-based, all right. That's. I hope the PrepLadder team is looking at all of these comments, and whenever we recall our MCQs, all that inputs from these students we'll use for the proper MCQ discussion whenever we have. All right, so answer is B, testosterone and inhibin. Right, next question, guys, please. When is a suction evacuation done? So basically, I'm sure that the question was till when the suction evacuation is done. Guys, I'm not answering this question till you tell me the choices properly. Yeah, 12, 15, 18 is too close set of choices. So can you just tell me the choices, please, guys? Yes, I'm waiting for your choices, guys. 12 till, okay. Till what time? Manual, yes. Manual vacuum aspirator, yes. I've always told you, please. Manual vacuum aspirator has suddenly become a hot shot for PG entrance and MCI. Manual vacuum aspirator, I marked 12. There'll no manual vacuum aspiration. Choice was the same. All right, fine. So ideally, when we say suction evacuation, it's still 10 weeks. But yes, with the manual vacuum aspirator, we can do up to 12 weeks. Yes, 12 weeks is the answer. Simple question, manual vacuum aspirator. Please see the videos of manual vacuum aspirator. You should understand about the syringe, and the capacity of the syringe is 60 ml. And it generates a pressure of minus 610 to 660 millimeters of mercury. Right. So that's his favorite question. 15 is not correct. 15 is after 12 weeks, the baby is too big, and too big a baby you cannot take out by suction. So you'll have to do, dilatation of the cervix and take out with a ovum's forceps or a sponge holder. You have to crush the fetus and take out. So that's a little, you need to have a heart of steel to go ahead and do such abortions. So generally people say it's better in the second trimester. The drug of choice for doing an abortion is prostaglandins. So that causes a mini labor and expulsion of the fetus. Otherwise, you can go inside and, do a lot of crushing and pulling, and you can take out by a dilatation and evacuation after 12 weeks. Anyway, let's move on and see. When is English version coming? Jay Vyas. English version has been put onto the back burner now by PrepLadder because of many reasons, and I'm sure the prep team will be giving you a great explanation about that. It's very important to understand that we must concentrate on what we have now, and English is the way it's going to be asked in the exams. I know all of us appreciated the English version, but then for the timing, it's been put on the back burner. Priority used to give you many more products in one language, priority is on that. So we want to give you rapid revision. We want to give you the questions, MCQs, the next kind of MCQs, the best clinical questions which we're having. And then we want to give you the, the updated apps and updated topics. So one language looks like the option for the time being, but feedback taken, we'll discuss with the prep team. All right, what is the direct cause of maternal death? This question I need to know. Choices solunga pa. Yaron patranga solunga. In the choices, I am not very happy. Was it direct cause of maternal death? Because somebody gave me a call in the evening saying, which of the following is a direct cause of PPH? So what was the question? Yes, guys, this direct cause of maternal death, or was it a direct cause of PPH? Direct cause of what? PPH or maternal death? PPH is not there. No, I'm asking the choices, not the choice. I'm asking the question. I'm asking the question. What is the direct cause of maternal death, or what is the direct cause of PPH? Because two set of questions have come to me. Okay, you mean to say this was the question and this was the options. Metal death, the PPH was not there. Metal death, PPH was not in the options. Was the same. Metal death, metal death. All right. So what did you guys? Anemia is obviously not a direct cause. Heart disease is also not a direct cause. So what did you choose between embolism and preeclampsia? Yes. See, PPH was not a choice. So why are you answering PPH? Twins was there in the choices. Question and option is correct. Okay, fine. So if this is the question and this is the options, I will have to go between embolism and preeclampsia. So there is only one condition which is involving a pregnant mother. See, anemia, heart disease, embolism can happen to any human in this world. It can happen to a child, it can happen to an adult, and it can happen to a pregnant lady. But preeclampsia is a specific disorder which is related to pregnant mothers. It is preeclampsia or hypertension pregnancy, like we say, complicated by proteinuria, is a specific disorder which causes a direct cause of maternal mortality. So that itself can cause maternal mortality. Preeclampsia getting into eclampsia, convulsions, going into DIC, cortical sinus thrombosis, and HELLP syndrome, all of that is going to cause a death. So direct cause of maternal death is preeclampsia. Of course, the other causes can also cause. Embolism can also cause maternal death. We all know amniotic fluid embolism can cause. After that, thromboembolism can cause. But between embolism and preeclampsia, I will have to choose the choice of preeclampsia. So what did you answer? Heart disease causes maternal death. It is a cause of maternal death. I did not say that it does not cause, but the disease is not just specific for that. Heart disease is a coexistent problem for a pregnancy. Like that, even liver disorders can cause maternal death. So can, tuberculosis in pregnancy can cause maternal death. And also, gastric disorders, like suppose a patient has a, tropical sprue, malabsorption syndrome, can cause maternal death. I'm trying to say, what is a direct maternal cause of death? Okay. Maternal disease. There's only one disease which is specific to pregnancy. Maternal means related to pregnancy. So yes, there's only one condition which is making sense here, that is preeclampsia. Embolism is also an important disorder which causes maternal death, but that's not just specific to pregnancy. It can happen even otherwise. But preeclampsia happens only in pregnancy. So that's one logic which looks like maybe the choices are the correct ones. Maybe the question was more exorbitant and there was more details, but in the information given now, I'll have to go with preeclampsia. Okay, after delivery they mention. After delivery they mention. Look, guys, now that's where you are getting me now. If you say after delivery and the patient dies, then I'll have to go with embolism because I'm not including embolism in that cause. So if you give me this choice, I'll have to say preeclampsia and I'll give you the logic. But suddenly one gentleman, what is that? After delivery, Subramaniam, right? Thanks you. Rajasundaram. Modala solavandi danapa idila. So if that is given, if they've given that the woman delivers and then she has death, then the cause of death is obviously the amniotic fluid embolism. Or if PPH was given, I would have thought of that. Anyway. If they're giving, I don't think after delivery was present. Okay, fine. So I've given you both the options. If they're asking this direct cause of maternal death, we'll go with all these. Preeclampsia is that one disorder which is directly related to preeclampsia is that one disorder which is present only in pregnancy. Okay, all the others can be there in pregnant mothers, but can be also there in so many other conditions. All right, guys, let's go to the next question. At day 5 postpartum, patient has come with low mood and mild depressive symptoms that are transient and self-limited. The depressive symptoms include sadness, crying, exhaustion, irritability, anxiety, decreased sleep, decreased concentration, and liable mood. What is the diagnosis? Seriously, you guys recalled such a long question with so many details? I don't know. Hats off to the guy who recalled all of this. And 5 days postpartum, that's when I stopped thinking. This is psychiatry. But yes, the only psychiatric disorder which happens very frequently in postnatal women, and the most common psychiatric disorder in postnatal women is postpartum blues. So I've stopped reading after all the choice after the first line. So because I'm sure the psychiatrist friends, they are going to tell you, the answer in much more details and the reasons. But the most common psychiatric disorder in postnatal women is postpartum blues. Next most common is postpartum depression. And the rarest is postpartum psychosis. So blues, depression, and psychosis. So what order do they come? BPD. Like I said, biparietal diameter. They come in BPD order. First week is blues. First month is psychosis. And first year is depression. So roughly around this is the best way to remember. First week to 2 weeks is the blues, and around 1.5 to 3 months is the psychosis, and around 6 months to 1 year is the depression. So in the order of BPD, blues, psychosis, depression, these are the 3 things. I'm not saying that a mother who gets blues will later get psychosis and will later get depression. Please, I didn't say that at all. I'm saying that these are the times of occurrence. The most common psychiatric disorder is obviously the postpartum blues. And yes, what is the cause of postpartum blues? Anybody? Come on. Might as well finish that off here. More postpartum blues. Yes, what is the reason for postpartum blues? One of the favorite questions we discuss in a classes. Yes? Come on, somebody has to tell me that. Postpartum blues. What is the, yes, answer is postpartum blues. What is the cause of postpartum blues? All right, guys, will not take much time. Anybody? 1, 2, 3, 5 seconds. And I'm not waiting. Postpartum blues is because of a progesterone withdrawal. So yes, in the classes, I keep pulling your legs, live classes especially. Yes, I keep asking you that progesterone withdrawal is very important when we discuss about the cause of menstruation in women. But I take that topic, wait till the end of gynae, then the end of obstetrics, and ask you again, what else is because of postpartum? I mean, what else is because of progesterone withdrawal? Postpartum blues is because of progesterone withdrawal. All right, guys, let's go to the next question, please. In which case we can extend medical termination of pregnancy beyond 24 weeks? Now, that is a question which I told you is going to come. Extending medical termination beyond 24 weeks. Which of the following conditions we can do that? Yes, contraception failure, rape, and a minor getting a pregnancy. All of these, the limit is 24 weeks. Now, sometimes what happens, we get to know anomalies only later. Suppose a woman comes to me at 22 weeks, 20 weeks, when I do the anomaly scan these days, and maybe I have not been able to pick up a very small defect. But later I find out this defect is present. I know there's a major cranial defect, there's a major cardiac defect, something like that, with presence around 26, 27 weeks, which is not viable with life. You know, suppose there's a congenital heart block, 60% mortality is there. Suppose there is, SLE presence slightly late. So there's a conduction defect because of that. SLE in the mother and conduction defect, and the bundles of his that get spoiled. And because of that, the baby will have a conduction defect that will present somewhat later. So when something like that presents, I know that the baby is not going to have a viable, baby is not going to be viable after the baby is born. Baby is not going to make it. So then I will have to do an abortion even after 24 weeks. And thanks to the modification in the MTP law, even after 24 weeks, we can do an abortion. But that has to be approved by a board. You cannot just decide individually. Till 20 weeks, doctors will decide. 20 to 24 weeks, 2 doctors will decide. But after 24 weeks, a pediatric surgeon, a neurosurgeon, a gynecologist, a lawyer, and a person who knows about female rights, a civil rights, female rights specialist, right? A person who is aware, person who is women and child welfare aware person who can advise us on these rights of women. So that kind of person of social importance, that person is that there in the board. So all of these people put together, they will think and tell you that, okay, fine, since it's a case of anomalous baby in this woman and this baby is not going to make it, then it is best that you can do an abortion. So that will have to be approved by a board. All right. So yes. Till 24 weeks. अरे यार, पूरी कहानी सुना दी. In which we can extend medical terminal pregnancy till 24 weeks. Doesn't make sense. Till 24 weeks, you can do abortion for all these conditions. Obviously, because 24 weeks is the legal accepted time of doing an abortion. So I'm not too sure. I mean, you'll have to tell me something more than this information which you've given me. Okay. So let's move ahead and see something else. Next question, please. Yeah, I will. Next question, please. A 32 weeks pregnant lady at risk of gestational diabetes, likely having a screening test during which time of pregnancy? Okay, basically we are trying to do GDM diagnosis, and GDM diagnosis is by the one-step GTT, and that one-step GTT is done after 24 weeks. Because when does GDM happen? Okay, I've been screaming loud and hoarse in all my classes and everywhere that GDM is after 24 weeks. And before that, suppose first trimester sugars are high, that is pre-existing diabetes, and pre-existing diabetes is the reason for congenital anomalies. And GDM, which is after 24 weeks, the organogenesis is complete, so GDM does not cause anomalies. So yes, that is what I've been trying to tell you in all the classes. Now they've asked you a much simpler question: how do you screen for GDM? After 24 weeks, do the glucose tolerance test with 75 grams of glucose. All right, the GCT and the GTT, all of that is still done in some practice. But yes, what is recommended now, accepted by the Government of India, and what has been asked in the AIIMS exam regularly, AIIMS and INI-CET exam, is the GTT, which is 1 step. So please remember that as your MCQ answer. 1 step GTT with 75 grams of glucose after 24 weeks. Fasting should be less than 92, 1 hour should be less than 180, and 2 hours should be less than 153. All right, guys, that's fair and simple. Next question, please. Meanwhile, read what's the answers. Okay. All right, guys, so let's move on. See, if they ask GDM, I'll have to say that. If they ask that if the family has diabetes, then I'll screen in the first trimester itself. So then the question becomes different. Anyway, let's move on. No, I'll do the next question. All right, go to the next one. What is the most likely diagnosis of the image given below? So I don't know, was this the image, guys? Oh, thanks, Abhi. That's such a hearty statement. Question number, was this the image? Yes, somebody's saying that this was the image. So if you look at the first part of the image, it looks like a straightforward case of anencephaly. I would have marked A. But if the second image is given, see, the defect is not only just in the head, the skin behind the neck and behind the chest, all of that is also deficient. So I'm not too sure, but if this is the picture which is given and these are choices, so then I'll have to say there are 3 types of anencephalies, all right? There's a meroencephaly, where there is some brain tissue left. There's a hollow anencephaly where there is no brain tissue left. So here, along with the anencephaly, there is also a defect on the neck and the chest. So yes, we'll have to go with the next type of anencephaly, and that is anencephaly craniorachisis. So craniorachisis is the extra part which is given in this picture. Well, I've not taught you this. I will not take the credit of this one. You know, I will not say that everything which I've taught has come in the exam, please. That is, everything asked in the exam I was teaching you in the classes. No, I will not take such tall claims. Yes, sometimes these questions, maybe your radiologist friends must have taught you, or maybe embryology, anatomy, they would have taught you about the congenital defects. Yes, medicine is a very, very big branch. 19 subjects. There's no limit, all right? There's no course. So every time something extra comes, and I've not taught you this, all right? Please, I'll not take the credit, but I hope you got that correct, guys. Let me see, what did you write? Okay, fine. None of you are commenting anything. So I guess all of you are a little stumped with this question. Let's move on. Question number 16, 17. All right. In which trimester the quadruple test is done? So when we are doing the screening for any aneuploidies, abnormal numbers and abnormal karyotypes, so we are doing in the first trimester to the early second trimester, so that you can do, if there is something wrong, then we can do abortions by 24 weeks. Earlier, we could do till 20, now till 24 weeks. So yes, all these screenings should be done before the abortion age, before a permitted abortion age. So yes, we do the triple marker or the quadruple marker from the 16th week onwards. When the 16th week starts, so 16th week onwards, so you know, some people say after 15th completed week, when the 16th week starts, that's so 16th week onwards we can do. So here the answer is second trimester. This is a fairly simple question, and they mentioned the first and second trimester only. Hi guys, come on, this is fairly simple, and I'm not going to, you know, get into too many variations of this question. Looks like a simple MCQ which came. So simple MCQ, straight away answer. Anything you want to tell me? Options were in weeks. All right, fine. 16 weeks is the answer. This was the easy one, guys. I'm sure all of you nailed this one. So far, looks like a simple exam. Next question, please. Identify the needle. Yes, my favorite needle. What did you write? Jamshidi needle for bone marrow biopsy? Come on, I'm just joking. I'm sure you did not write that. What did you write, guys? Hypodermic needle is not that. I don't know what is a Huber needle. Dialysis fistula needles. No, dialysis needles are like a thick scalp vein. You know scalp veins you've seen? Dialysis, there's a 16 gauge or a 14 gauge, thick scalp vein kind of a thing. So that is not this. Yes, this is an easy one. Come on, I'm going and looking at BCD just so that I can do some discussion. This is a straightforward, easiest question which could have come. And that is a Verus needle or Viris needle, like people say. The Verus needle is, needle which is used to insert into the abdomen and create a pneumoperitoneum. All right. So when we do a pneumoperitoneum, we can get into the abdomen and go ahead and look into the abdomen, do a laparoscopy. Yes, of course, laparoscopy was started by the gynecologists, and gynecologists are the ones who did almost all the major inventions earlier on. Yes, I can't say much because I think my surgeon friends must be listening to this and they'll get a little bugged with me. So yes, all right. A lot of modification now have been done by the surgeons. All right. Surgeons are the greatest. All right. We'll always say that. But laparoscopy was started by the gynecologists. Quickly, next question, please. Which of the following emergency contraception is not acceptable? I don't know what was this question. I mean, I was racking my heads and my friends were saying, let's start the session. And I was happy that Bharat was taking a little longer session because this question didn't make any sense to me. What are you guys saying? Come on. Come on, what were the choices? Which of the following is not acceptable? I'm not understanding. None of the above will definitely not be a choice, which I've already told you. All of the above, one of the above, none of the above. That's nonsense. It is never a choice in any exam. Okay, so this obviously the gentlemen who were, the students who recall this did not know the choices properly. That's why. OCP was an option, all right? OCP was. So in the following emergency contraception is not acceptable. So levonorgestrel in the first 72 hours, 0.75, and second after 24 hours. So we can give 0.75 2 tablets. So first one we give and the second one after 12 hours. That was the original method of giving levonorgestrel. So B is not a wrong answer. C, 1.5 single dose within 72 hours of unprotected sex. That is also not a wrong answer. So here, B was the previous protocol. Now the accepted protocol is 1 tablet of 1.5 grams. Milligrams, guys. 0.75. Come on, guys. Yes. So choice A doesn't make sense to me. Okay. Choice A doesn't make sense to me. Okay, milligrams. Anyway, the dose here is written wrong. So let's not get confused on that at all. So answer is A in the choices given here. None of the above is just neglect, just ignore that choice. So what are you answering? Cent chromos also given. None of the above. IUCD was an option. So if IUCD is there in emergency contraception, it is acceptable. So I don't know what was the choice which is unacceptable, because in this, the only method which is wrong is that you give 1 tablet now of 0.75, then the next should be given within 12 hours. So that is the only choice in the given choices to me. That's the only answer. A looks like the only good answer. What are you guys saying now? Let me see. All right, let's move on. Next question, guys. Question number 21. Molar pregnancy is a form of abnormal pregnancy in which the formed placenta-like tissue sometimes invades the wall of the uterus. Molar pregnancy is usually diagnosed early in pregnancy due to bleeding. Abnormal features in the ultrasound and higher than usual levels of which of the following pregnancy hormone? Oh, so long story about molar pregnancy, an invasion and causing a trophoblastic tumor. Long history is given. What is the hormone responsible and what is the hormone which is usually associated? So trophoblast, syncytial trophoblast and cytotrophoblast is what is the trophoblastic tissues. And syncytial trophoblast is the one which makes the HCG. And syncytial trophoblast is the one which will cause choriocarcinoma if it persists in cytotrophoblast. If the syncytial trophoblast persists, it will make the choriocarcinoma, it will make the invasive mole, and in both of these, the HCG is high. So the answer is HCG. Is straightforward question. But yes, if they ask you placental site trophoblastic tumor, now placental site trophoblastic tumor is from the cytotrophoblast. So cytotrophoblast, the human placental lactogen will be increased. All right. So here the answer is HCG. I think it's a simple, easy. Human chorionic gonadotropin, Akansha Gupta. That's, I'm sure. Okay, fine. Let's move on, guys. Next question. Patient comes to the emergency department with 32 weeks pregnancy and pedal edema, blood pressure more than 140/90, dipstick 2 plus. Dipsticks for protein is 2 plus. What is the likely diagnosis? Guys, what do you say? Come on. Very tough question. I think you must have been pulling your hair on this one. Yes, this is the easiest question possible, guys. I'm sure you knew the answer. So this was looking as if they gave you a question just to give you 1 mark straight away. Yes, this is preeclampsia. Remember, I don't know how this is getting into the discussions that now for the preeclampsia or preeclampsia syndrome or the preeclampsia, proteinuria is not required for the diagnosis. I don't know how it is coming into the discussion. Please, very much required. Now they've asked you a question also on that. So I hope all of you will agree with what I tell you in the live classes and also in my app, that please remember preeclampsia is very much the same. The latest Williams Obstetrics 26th edition also, there's no change in the diagnosis of preeclampsia. High blood pressure, proteinuria is equal to preeclampsia. And proteinuria is not required. I don't know. This is definitely not there in the discussions, okay? It is required for the diagnosis. And they asked you a question also on that. So rest assured, and controversies laid to rest. Fine. What are you guys saying now? OBG was okay, I guess, and lot of options were tricky, but language and options were tricky. Yeah, I also hate the language, So many times they test the knowledge of our, the understanding of the English language more than just the theory. So sometimes it becomes a little tricky. I had a lot of problems with the language sometimes. But yes, I've grown much older, and I've now, discussing with so many of you, and I'm reading so many books. So yes, I can understand the frustration you people have. But yes, more practice will always make you understand these things better. That's all I can say about this. All right. So what are you guys saying now? Oh, yeah. Monica. That's a nice emoji you sent. That's why English is the best. Yes, Jev, yes. I know. I'm sure the prep team is listening to this and they will take appropriate action. Guys, is there any other question? Next question, please. What is affected in polycystic ovarian disease? Sleep study, urine study, FSH level, serum testosterone level. Did you mix up some choices here? I can't ask the prep team to say because the students who gave this question should be asked. So are these the choices, guys? Oh, I did not mark. Ashik, I'm so sorry I did not mark. There are some technical problems. I'm trying to do everything on the iPad. There are some technical problems here. It's not working. So I think we'll just take the answers for today. So I'm sure your friends have already marked the answers for you, so you can discuss with them. Come on, guys. Yes. Girl with PCOD taking medicine falls asleep. What to be done? Whoa. PCO medication, sleep inducing. Like clomiphene citrate is known to cause headaches. And seriously, you're testing my pharmacology. Dr. Bharat, are you around? Please help me here. I don't know what medication or PCOS causes sleep. All my patients, they come very much awake when they come. I give clomiphene citrate like I sell, somebody would sell peanuts. So yes, we sell a lot of clomiphene citrate, and none of them have complained to me that they're drowsy. So also of letrozole and clomiphene citrate. So I don't know what was this question. The question had a person who couldn't sleep well. They asked which test is least useful in such a scenario. And those were the options. All right, guys. So if the person cannot sleep, I'm sure that it is nothing to do with me. All right. So in PCOD, okay, then let's just look at choice number C and D. That's why I said you mixed up some questions and gave me this one. So yes, what is affected in PCOD? FSH levels are not high. LH levels are high. So LH-FS ratio is high in PCOS. So what is affected? Serum testosterone. Classical diagnosis of PCOS is hyperandrogenism. Either clinically she's hairy or the lab is showing high testosterone. So answer in this, choice A and B doesn't make any sense to me. C and D, if you give me the choices, I'll mark D. D for Delhi. So what are you guys saying now? I think this medication causing daytime sleep, some other choices would have been there. Okay, so maybe when we do the discussion, there'll be better choices. What is next? Do we have another question? CS cervix drug used in chemoradiation. Okay, so guys, I hope all of you remember that the early stages only we can do a radical hysterectomy and give complete treatment to a woman with CS cervix. So please remember, from stage 1 to 2A1, from stage 1 to 2A1, we can do a surgery and give a complete relief to the patient. Of course, the exception to this is 1B3. Any lesion more than 4 centimeters, again, we can't do surgery. So yes, stage 1 to 2A1, we can do surgery as a treatment, exception being 1B3. Now, beyond 2A2 and beyond, your surgical treatment won't be enough to take out the disease completely. So yes, we don't do any surgery. We give chemotherapy and radiotherapy together. That is what is chemoradiation. Don't say that beyond, 2A2 and beyond, you do surgery and chemoradiation. No, I didn't say that at all. 2A2 and beyond, we do chemotherapy and radiotherapy together. That is known as chemoradiation. Now, what is the drug used for chemotherapy? I'm sure they don't mean to say chemoradiation. So yes, cisplatin, okay, platinum-based drugs, along with Taxol, the dual therapy, okay, the double therapy, like we call it, that is what is done. So the doublet regime, like we say, is using cisplatin and paclitaxel. So cisplatin is the drug. Apart from cisplatin, you can use carboplatin also. So when we say combination chemotherapy, cisplatin and paclitaxel, this is a very good combination chemotherapy, but a lot of patients do not tolerate combination chemotherapy so well, because its chemotherapy alone is given only for advanced disease. So those patients who are as it is sick, they cannot tolerate the combination chemo so well. So it's best that we give a single agent chemo. So if the question is asked a single agent chemo, then I would say carboplatin. Of course, that's not in the choices here. For you, the answer straight away is cisplatin, which is the drug used for chemotherapy in a case of CS cervix. Go ahead and mark cisplatin. End of discussion for this question. But I'm trying to tell you something extra, that chemotherapy, if you're giving as an option, then the doublet chemotherapy, the double chemotherapy with cisplatin and paclitaxel, or carboplatin and docetaxel, whatever combinations, those two combinations are better. But those who cannot withstand, if they ask you single agent, maybe for the PG entrance, they'll ask you, if a single agent chemotherapy is asked for CS cervix, then single agent, if you want to give, then go ahead and give platinum-based drug, but then it is carboplatin, not cisplatin. Okay, so fine. Here the answer is cisplatin. Let's move on. What are they asking you? And what are you asking me? So question was just after delivery, uterus will be, okay, that's question is done. Both cisplatin and paclitaxel was given. Oh. So then my answer is correct, that if you want to use a single agent and you have to choose between cisplatin and paclitaxel, you'll go with cisplatin. And if that was the choice, then platinum-based drugs, single agent, single drug, platinum is the better answer than giving paclitaxel. So then that answer would have been still cisplatin. What else were the choices? Cyclophosphamide is not the answer here. Okay, so that was the question which came about cisplatin, and of course, I'll be waiting for the right choices for this one. Anything else which came in the exam? Oh, thank you. So yes, I don't think anything else came in the exam, and you guys can ask me on. I'm still around. Yes, since this is the last session, and you guys are just going to sleep now. Of course, please have a good hearty dinner, because you worked very hard for this 6-7 months, and you gave an exam yesterday, and quite a few of you, around 200 of you were here. Now around 180 are left. So yes, you deserve a hearty dinner after this. But what are you guys here? From Hyderabad and from so many other places. Okay, don't worry about PSM, guys. Akansha, you did well in Gynae, right? So you'll get 40 marks in Gynae, and you'll get good marks, at least 80% marks in other subjects. So if not in PSM, doesn't matter. You'll make up in the other 18 subjects. So don't get depressed. Now's the time not to worry. Now's the time to relax a bit after your exams, and thank the Almighty that you have everything else in your life which is given perfectly to you. by your parents, and the love and affection, you should value all of that. Please go and hug your parents from my side and tell them thanks for everything what you've done. And I've done my good exam, and I hope I get a good result. All right. So do your effort, and the results will follow. All right, guys. So I hope you have nothing else to ask me. Okay, guys. Then this is time for me to say goodbye, and I hope all of you pass the exam and write to me and tell me that each one of you got what you wanted in your life. And that's this 50% marks for the time being, right? All the best, guys. See you around once again.